Okay, so we're going to, good afternoon. Welcome to the Health and Government Operations Committee. Chairman Pendergrass. I am actually Jocelyn, and with Jocelyn Pena-Melnick. We have a full agenda today. So I want to read just some of the rules for the committee. This is a virtual committee, so I ask for your patience. If we encounter any technological or streaming issues, which are bound to happen, just be patient. This bill hearing is being streamed on the Maryland General Assembly YouTube channel. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question, one answer from the panel, not one question and one answer from each individual panelist. Also, please keep your questions shorter than the expected answer because we have a lot of bills, a lot of hearings, a lot of witnesses. The bill sponsor or a designee is allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. And then after that, we have favorable with amendment, get 5 minutes as well. In opposition, they get 2 minutes as well. In the opposition, get 2 minutes and 5 witnesses. So please stay in the hearing until the delegates have had an opportunity to ask questions. Please conclude your remarks when you see the timer, when it goes off. And Richard or Susanna, who are amazing and staff our committee, will let you know when the time is up. Members, you must remain as always present with your video camera. Those are the rules, and they must be on during the entirety of the hearing. Thank you so much. We're going to start today with House Bill 915, followed by House Bill 1370, then 1127, 1352, 935, 1017, 1020, 1160, 0900, 981, 1302, 1357, 1082, and the last bill of the day, 1078. Richard or Susanna will let you know in the chat room what bill we are on and which is the next bill. So let's get started with House Bill 915, Delegate Sample Hughes, Maryland Healthcare Commission, Patient Safety Center, Designation and Fund. Good afternoon, Delegate Sample Hughes.
Good afternoon, and good afternoon to Chairman Pendergrass and Vice Chair Pena-Melnick and all the members of my favorite committee in the House, HGO. Today, I am asking for your support for House Bill 915, which is entitled Maryland Health Care Commission Patient Safety Center Designation and Funding. This bill is necessary to guarantee the health and safety of Maryland patients across our entire state. So to do this bill will require the Maryland Healthcare Commission designate a patient safety center for the state, a position that the Maryland Patient Safety Center has held since 2004, and provide $1 million in annual funding for the organization, allowing them to invest more in our current patient population and prepare for future endeavors with a more clear fiscal outlook. What I will say is that I am and have been a member of the board for Maryland Patient Safety and have come to learn an enormous amount of the work that is being done as it relates to their efforts here in the state of Maryland of working with maternal health, reducing the number of cesarean sections in our state by educating medical personnel as well as our hospitals. And that work is significant. That work has transitioned into recently with the pandemic, work with the hospitals and nursing homes with COVID issues, meaning that the necessity for all of our medical facilities to be aware of what ways to be sanitizing items, as well as looking at the proper trainings that are in order for the staff. What you will hear today, and specifically may be coming from Johns Hopkins, is that they have a program, it's entitled RISE, and it speaks to the fact that when medical personnel are in traumatic situations, they too have to figure out how to respond, not just in the physical sense of responding to the trauma and the situation, but emotionally. And so trainings such as those have been very instrumental in working in our hospitals throughout the state of Maryland. So they too, our first responders, they too can have the ability to work through their emotions and stay with their colleagues through the process in traumatic situations. So where we are today is that, again, the legislature founded in 2003 Maryland Healthcare Commission. And as I said, they had to designate a patient safety center. And with that being said, their work has been not only a frontline leader in Maryland, but also a national leader. And so what has been very beneficial to our state is not only the work that they've done, but also the fact that they've been able to boast this excellent record of service on a steadily decreasing budget. So what we're trying to show you is that they've been doing all this work through their seed funding. And now we're at the point with the fact that the Maryland Healthcare Commission, the HSCRC, here's all of our acronyms, but are no longer funding them at that level. And so that's why I'm coming to you today to say this is critical work that they're doing and that we need to be able to fund them and have that continue. And lastly, I did ask for this to be a supplemental, in the governor's budget. And with that, the ability to that to happen has not occurred yet. But I do know that the importance of this particular piece of legislation is necessary for our state. And I would like to ask for your support for House Bill 915. And thank you for your time. You'll certainly hear from the executive director and others on this very important cause.
Wonderful. So you have 50 seconds left. Would you like me to give that to who would you like to call next from your panel?
It would be Blair Eag. He's
Wonderful.
the director of the patient safety.
Wonderful. So I'll do that. Thank you, Delegate. So we have Mr. Eag. Will you come up? Blair Eag. Susanna or Richard, are they here?
Yes, they just haven't unmuted.
I was not unmuted. I apologize.
It's okay. So Mr. Eag, you have 50 seconds, the remaining time for the speaker pro temp, and you have also your 2 minutes, okay?
Thank you so much.
My pleasure.
So Chair Pendergrass, Vice Chair Pena-Melnick, and members of the committee, thanks for having me here today. I'm Dr. Blair Eag. I'm the president of the Maryland Patient Safety Center. And the Maryland Patient Safety Center and our board, of course, are pleased to express strong support for House Bill 915. The bill will provide greatly needed ongoing funding for Maryland's designated patient safety center, as you heard from Delegate Sample Hughes, to allow for continuation of our mission to keep Maryland healthcare safe. The center's programs are more vital now than ever as the Maryland healthcare industry faces, as you know, a workforce crisis and many more challenges created by the pandemic. The Maryland Healthcare Commission has been designating the Patient Safety Center for the state since 2004, and we have been the designee from the beginning. The designation process outlined in this bill codifies and clarifies the Maryland Healthcare Commission's existing practice. And as you will hear, the Healthcare Commission is in support of this bill. So the Maryland Patient Safety Center is a nonprofit organization, was one of the first patient safety organizations listed by the federal government. Our key initiatives have included caring for the caregiver, as described just a moment ago by Delegate Sample Hughes. That's the RISE program in conjunction with Johns Hopkins, which is focused on peer support, resiliency, and the emotional well-being of the healthcare workforce. Health equity, which is focused on the significant disparities in outcomes for pregnant Black women in Maryland through education on maternal morbidity, racial bias, and the value of the patient's voice. We've also facilitated education on COVID vaccine acceptance in communities and healthcare staff of color. In addition, we've had ongoing successful programs addressing reducing facility-acquired infections, and again, as Delegate Sample Hughes described, especially in nursing homes during the pandemic, improvement in sepsis survival in hospitals, reducing first-time cesarean sections, and reducing fall injuries at long-term care facilities. The center's programs have led to better, safer healthcare for all Marylanders and less expensive healthcare for the state. All of this takes money and resources. The Health Services Cost Review Commission, the HSCRC, had initially provided seed funding for the center to launch and expand operations, and had gradually reduced the amount over time. Those seed-funded resources have now expired. A stable revenue source going forward will allow us to commit to the priorities of the state to improve patient safety, healthcare worker well-being, health equity, and the quality of care. So thanks for the opportunity to speak today. And I am always available, and as you may tell, pretty passionate about it, if you wish to learn more about what we do at the Maryland Patient Safety Center. Thanks.
Perfect timing. Thank you so much for being with us. Next, we have Mr. Ben Steffen. Ben, good afternoon.
Good afternoon, Vice Chair Pena-Melnick, members of the committee, Ben Steffen, Executive Director of the Maryland Healthcare Commission. And I'm pleased to be here on behalf of the 15 members of the Maryland Healthcare Commission to voice our strong support for this funding initiative. As you know, the hallmarks of the Maryland Total Cost of Care model are to reduce costs while improving health outcomes. And we do that through reducing duplicative service, unnecessary care, monitoring and connecting people to care that more effectively avoids increases in severity, increasing preventive services to avoid future care. And most importantly, I think in terms of this legislation, also working with the provider community to avoid medical errors that occurs while care is delivered. The Maryland Patient Safety Center, as has been already mentioned, is a key element in these patient safety efforts. And this legislation would give the Patient Safety Center a clear funding stream going forward. Previously, the Patient Safety Center was funded through a grant from the Health Services Cost Review Commission. As many of you know, the Centers for Medicare and Medicaid have sternly advised Maryland that additional funding efforts using the hospital rate setting system can no longer be supported given the commitments the state has made to meet total cost of care goals. So consequently, we need the state of Maryland, the public, if you will, to step up to fund this. We strongly support it. Our ability to monitor the funds that are spent through the Patient Safety Center are in place through the Maryland Healthcare Commission, and we strongly support and encourage a favorable report. Thank you very much.
Thank you, Ben, for everything you do for us. We really appreciate you. Next, we have Deneen Richmond.
Hello, good
Yes.
evening or good afternoon, everyone. My name is Deneen Richmond, and so I want to thank first Chair Pendergrass, Vice Chair Pena-Melnick, and the other members of the committee. I am the president of Luminous Health Doctors Community Medical Center and also a board member of the Maryland Patient Safety Center. I also want to thank Delegate Sample Hughes for sponsoring this bill, and I'm here to speak in strong support of House Bill 915. Years ago, I was part of the joint team from the Delmarva Foundation and the Maryland Hospital Association that helped to form and then run the Maryland Patient Safety Center in those early years prior to it becoming a separate not-for-profit organization in September of 2007. For all of these years, Maryland Patient Safety Center has been a trusted voice in all aspects of patient safety and has a long history of improving patient safety across the entire Maryland healthcare landscape, working with hospitals, physician practices, long-term care facilities, and others. There's a direct connection between improving quality and safety with decreasing costs, which we all know is an important focus for Maryland total cost of care. I myself and many others have personally seen the impact of the Maryland Patient Safety Center as it serves as a vital role as a convener, facilitating collaboration on proven evidence-based change initiatives. This allows healthcare organizations to focus on implementation of evidence-based interventions and address barriers that are unique to them without having to reinvent the wheel. Just last Friday, the Maryland Patient Safety Center hosted an annual conference that was well attended by several hundred participants who came together to share and learn. This is just one of many examples of how Maryland Patient Safety Center is helping healthcare providers to accelerate patient safety across the state and make our state a better place, a safer place for all Marylanders. thank you for your time this afternoon.
Thank you for being with us today, for everything you do. Next, we have Mr. Kevin Hefner. Good afternoon.
Good afternoon, Chair Pendergrass, Vice Chair Pena-Melnick, and also Delegate Sample Hughes and other members of the HGO Committee. It is my privilege to be here with you today to speak in strong support of funding for the Maryland Patient Safety Center. My organization, Lifespan, represents more than 300 institutions that provide care for older Marylanders, ranging from nursing homes to assisted living facilities and home care. And during the pandemic, I was able to see firsthand not only the impact that the Clean Collaborative had on patient safety, infection control, as well as falls prevention initiatives in the nursing home environment, but also I've had experience over many years of being part of the Maryland Patient Safety Conference and seeing the impact that that's had on thousands of professionals who practice in the field and make it their business to provide quality care and safety for residents. It's been my honor to be part of the board to see the impact that these programs have had. I am very proud to support this initiative and to encourage full support and funding for this program. Thanks for your time.
Thank you for being here. We have Tracy Lavalle, and I don't know if I pronounced your name correctly.
You did. That's
Okay.
right. Thank you.
Thanks for being with us.
Yes. So good afternoon. I'm Tracy Lavalle, the Senior Vice President of Quality and Health Improvement at the Maryland Hospital Association. And I very much appreciate the opportunity to testify in support of funding for Maryland's Patient Safety Center. You've heard a bit about the Safety Center's past successes in increasing the number of people who survive sepsis or severe blood infections, lowering rates of first-time C-sections and early elective deliveries. I want to speak today about how they've been a great partner and how quickly they responded to the healthcare field's needs since the start of the COVID pandemic. Early on, it became clear that there were three areas where the Safety Center could really fill a gap. The first was supporting healthcare providers who were and still are under incredible stress. They ramped up the Caring for the Caregiver program, the Johns Hopkins program, to help nurses and doctors who have experienced unexpected traumatic and stressful events. It's been enormously successful and very beneficial. Secondly, for nursing homes, they needed help with infection control. The Patient Safety Center identified and implemented a Clean Collaborative. It partnered nursing homes with a hospital to bolster infection control practices. Third, in equity. And the Patient Safety Center is creating new programs to fill this gap. So drawing on clinicians who are experts in health and racial equity, they created a very practical series to help clinicians understand and work through barriers and historic reasons that people have for distrust of healthcare providers. Those skills help clinicians to better engage patients in making decisions about their health. There's more work underway in this area, and I'm excited to see it continue. So for these reasons, we ask for a favorable report on House Bill 915.
Thank you so much for your testimony today. The committee appreciates it. Are there any questions for the sponsor or for the rest of the witnesses? I don't see any questions. You did a great job. Thank you so much for being with us. This concludes the testimony on House Bill 915. And we have our next bill is House Bill 1370, Delegate Sample Hughes, Organ and Tissue Donation Awareness Fund, Annual Funding and Extension. Good afternoon, Delegate.
Thank you. Good afternoon again. Delegate Sample Hughes, and I'm here today to ask for your support on House Bill 1370, Organ and Tissue Donation Awareness Fund. This is very important to our state, as you probably hear that quite often, but when you're in need of someone's organ to continue your life, it just makes it all the more important for you to have the information at your fingertips and to be able to know how to access that need if you are certainly in that position. So what I'm asking for today is that the bill reauthorizes and extends funding for Maryland's organ donor registry and to raise awareness of those donations that occur across our state. So the program has been annually funded at $400,000 since inception in 2007. And this bill increases funding to $500,000 and authorizes the funding for another 5 years. Donate Life Maryland is the state authorized nonprofit organization responsible for managing the Maryland Donor Registry. Donate Life works closely with the 2 federally designated nonprofit organizations that serve Maryland, and those being the Living Legacy Foundation of Maryland and the Washington Regional Transplant Community. In addition to managing and operating the Maryland Donor Registry, they are also in partnership with those entities to spread the word about organ, eye, and tissue donation and how to register as a donor in Maryland. Since 2009, Donate Life Maryland has registered over 2.2 million donors and provides outreach and education on the importance of organ, eye, and tissue donation. I had an opportunity during the interim in preparation for this bill to visit the Donate Life Center, and just that short bit of time, just seeing how impactful the work is, and also to know that some of our colleges here in the state of Maryland also benefit from visiting, touring, to just have an understanding of how they further their work in the medical community as well. So it certainly has served great purposes. And if you aren't aware by now that when you go to register or renew your license, there's an option for you to donate at $1. And so that's part of where their funding has derived from. And so where we are today is asking for the difference of what is not achieved through that process on general funds. So in Maryland, organ demand has steadily increased over the past 20 years, and the need for Donate Life's work is more necessary than ever. So for that reason, I'm asking for a favorable report on House Bill 1370, and thank you for your time. And you'll certainly be able to hear from the panel on more in depth as a recipient and the executive director. Thank you.
Okay, you have 1 minute and 47 seconds. Who would you like to go next from your panel?
That would be the executive director, Ms. Spignall.
Wonderful.
Followed by
Johnson. Followed by which one, Mr. Johnson? Ms. Johnson?
Johnson, and then the last one will be Healy, the transplant recipient.
Wonderful. Lisa Spignall.
Good afternoon, Madam Chair, Madam Vice Chair, distinguished members of the committee. I am Lisa Spignall, Executive Director of Donate Life Maryland, and I'd like to thank Delegate Sample Hughes for sponsoring House Bill 1370. As you have my written testimony, I would like to share some additional details regarding our support for House Bill 1370. As Delegate Sample Hughes shared, Donate Life Maryland is the state-authorized nonprofit responsible for managing the Maryland Organ, Eye, and Tissue Donor Registry. Currently, the registry securely and confidentially maintains the records of over 2.2 million organ donors here in the state of Maryland. Since our inception of 2007, we have created the registry, established and maintained it, along with the allocation of over 4,700 organs to transplant recipients on the organ donor waiting list in Maryland. We work very closely with the Maryland Motor Vehicle Administration to ensure that every Marylander who applies for their driver's license or ID card has the ability to register as an organ, eye, and tissue donor. This collaboration allows Donate Life Maryland to train MVA staff on the importance of organ donation, while also allowing us to be on site to answer any questions that potential new registrants may have, giving us one outlet to educate the public on the importance of donation and providing all necessary outreach materials to all 24 branches of the Motor Vehicle Administration. This partnership has seen our registry grow over to 2.2 million registrants we have today. We also partner with Maryland's 2 federally designated organ procurement organizations, the Living Legacy Foundation and the Washington Regional Transplant Community. These partnerships allow Donate Life Maryland not only to identify barriers in the community, but also dispel the myths and misconceptions that come with understanding organ, eye, and tissue donation, while allowing us to educate the community with national observances, all while working to increase donor designations and building a culture of trust in the community. In 2016, Donate Life partnered with the Living Legacy Foundation on the Decision Project, which you will hear a bit more about shortly. This grassroots initiative identifies priority low designation areas of our state that are in need of support, outreach, and education. Since our inception in 2007, Donate Life Maryland has received $400,000 a year from the Organ, Eye, and Tissue Awareness Fund. This fund has allowed us to see the successes we have so far. Every registrant at the donor registry can potentially save up to 8 lives with organ donation and enhance up to 75 lives with tissue donation. These incredible gifts restore health, extend life, and heal many people each year. By passing House Bill 1370, Donate Life Maryland will be able to continue donor education awareness, increase donor designations, and foster lasting relationships while identifying barriers and continuing to save lives by registering donors. We sincerely appreciate the legislature's ongoing support of our efforts and ask for a favorable report of House Bill 1370. Thank you.
Thank you for your work. We have next Leisha Johnson.
Hi, good afternoon. My name is Aisha Johnson, and I'm the Community Outreach Director at the Living Legacy Foundation of Maryland, and I'm also a tissue recipient. Community outreach and public education is not a one-size-fits-all effort. Through strategic planning, we can move our mission of saving lives by supporting the communities we serve by having adequate funding. We can accomplish this through public outreach, education, and grief support through Bill HB 1370. In our work, we are privileged every day to see the positive impact of donation and transplantation on 2 distinct groups, the donor and their family, and the recipient and their family. When one person becomes a donor, we can clearly see how their gift can save and heal lives. However, to get that far and to have someone say yes to donation, it takes a lot of education and support. When the Living Legacy Foundation of Maryland implemented the Decision Project, a grassroots campaign that focused on increasing donor designation and underserved populations in Maryland, we knew there was more that we could be doing for our communities. Here we had in Maryland where many people needed an organ transplant, and yet their next door neighbors, people who can potentially save their life, were not designated. Additionally, with so many people in Maryland on the wait list, we had to recognize our responsibility to provide education, not only why it's important to be an organ donor, but also how to take care of their health and to avoid needing a transplant in the first place. Our donors come from various backgrounds and social circumstances. When you serve a population, you must look at each individual and ask, how can we best serve them? Without the proper funding, community outreach will continue to be one of the biggest hindrances that nonprofits face, especially in the health and human services sector. I hope that the committee can maintain the funding for HB 1370 so that one day the waitlist across Maryland will significantly decrease and more residents, especially in our communities, that are underserved. Thank you.
Thank you, Ms. Aisha Johnson. We appreciate your testimony. Next, we have Tim Lely.
Yeah. Good afternoon, Madam Vice Chair and committee members. My name is Tim Healy. I'm a resident of St. Mary's County, retired Navy Rear Admiral, board member of Donate Life Maryland, father of 3 children, grandfather of 3, and a recipient of a heart transplant in 2013. Graduated from Naval Academy. I spent 33 years in the Navy flying jet fighters from aircraft carriers. I found 10 years in the Navy where I was stationed at Naval Air Station, Patuxent River, Maryland, where we settled when I retired. Life was good. I had a great job in Rosslyn, Virginia, to which I commuted daily. Then in 2011, I started experiencing shortness of breath and a lack of stamina. Being a fighter pilot, the last person I ever wanted to see was a doctor, but my wife insisted and drove me to the hospital. I was diagnosed as having had a couple of heart attacks, treated with a couple of stents, and then eventually received an artificial heart or a left ventricle assist device, which kept me alive for 2 years until I was able to get a heart transplant. I was lucky. I was healthy enough that I was able to function near 100% while waiting my heart. And so I was not deemed a priority for the few available hearts. But after a couple of years, my luck began to run out. The device began to shred my red blood cells, and it was my turn for the next available heart. Since I got my transplant, I've run several small companies, served on a half dozen pro bono boards, such as Donate Life Maryland. I've given away our daughter in marriage and welcomed a daughter-in-law to the family, met my 3 grandchildren. I've listed myself as organ donor since it first became available. Today in Maryland, over 50% of the people do the same thing, but that's not enough to provide the organs and tissues to meet the demand. Medical advances have greatly increased the life expectancy of recipients like me, but the availability of the organs and tissues are lagging. This bill will go far in providing the funds to carry out this education process and will allow so many others the opportunities and the second life that it's given me. Thank you for your consideration.
And thank you so much. I'm so glad you're doing well. Thank you for sharing your experience with us.
Thank you.
We appreciate it. Our pleasure. So are there any questions for the sponsor and her panel? Seeing none, that concludes the bill hearing on House Bill 1370. Thank you, Delegate Sample Hughes. Next, we have House Bill 1127, Chairman Pendergrass, Public Health State Designated Exchange Health Data Utility.
Eventually, I find the unmute. Thank you, Madam Chair.
My pleasure.
I am going to turn this bill entirely over to David Sharp, who is the expert, and I presume he signed up and in the meeting, and I will ask him to present the bill for me.
He did, Chairman. So, Mr. Sharp, good afternoon.
Good afternoon. It's my pleasure to be here, and thank you, Madam Chairman and Vice Chair, for the opportunity today. So I'm going to talk a little bit about HB 1127. I'm going to frame it up and give you the position of the Maryland Healthcare Commission. So for the record, my name is David Sharp. I am the Director for the Center of Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. I'm here today in support of House Bill 1127, Public Health State Designated Exchange Health Data Utility. The bill establishes a health data utility operated by the State Designated Health Information Exchange, CRISP. It requires the Maryland Department of Health, pharmacy dispensers, nursing homes, and electronic health networks to submit certain data to CRISP for public health purposes. CRISP must make select information available to providers and health officials for public health interventions and health equity, and MHCC must develop support regulations. A report to the General Assembly on the revenue sources to fund the health data utility is due by January 1st, 2024. This legislation would formalize many of the roles that CRISP took on during the COVID-19 public health emergency. CRISP served as a data enclave for hospitals and nursing homes and monitoring and planning, as well as capacity monitoring and planning. When vaccines became available, CRISP applications and data infrastructure supported vaccine distribution, scheduling, and uptake monitoring.
Yeah.
These new capabilities were developed even as longstanding CRISP provider-facing applications continued to advance.
Okay, so how long do you think?
Can you please mute yourself? Thank you. Sorry about that, Mr. Sharp. You can continue.
No worries, thank you. The bill establishes a dispensed prescription drug repository that builds on the existing controlled dangerous substance framework, which will enable providers to have access to a comprehensive patient medication history for patients under their care. Provider access to comprehensive medication history has great potential to increase patient safety by improving the medication reconciliation process, which will reduce medication prescribing errors. Medication errors are among the most common cause of morbidity and mortality in hospitals. This particularly holds true for hospital emergency departments, the origin of at least half of all hospital admissions in Maryland and the nation. Pharmacy and Therapeutics, a peer-reviewed journal for managed care and hospital formulary management, reported in November of 2018 that for 50 to 70% of patients admitted to the hospital, the initial medication error history contains at least one error. Manual medication reconciliation processes often require lengthy conversations with patients and or their caregivers, along with multiple calls to pharmacies. House Bill 1127 will address hurdles in care delivery and patient safety due to a missing or incomplete medication history. The MHCC began planning for this use case several years ago. The MHCC convened a work group to study electronic prescription record systems for care management in 2018. The MHCC released the final report from the work group in July of 2019. The work group recommended that an electronic prescription record system should ensure patient privacy through an opt-out process and to define certain classifications of medications that could be excluded from the electronic prescription record system. In 2021, MHCC began working with stakeholders to operationalize a consumer HIE consent management utility. The utility requires HIEs registered with MHCC to implement consent registries and integrate those registries with CRISP. The MHCC is already working with payers and providers and consumers to update the HIE privacy regulations to reflect recent changes in federal law. The HB 1127 formalizes CRISP technical capabilities. The MHCC asks for a favorable report on HB 1127. Thank you for your time, and I'm happy to answer any questions.
Thank you for your work. We really appreciate it. We have next Mr. Ben Steffen.
It's entirely possible that he's not in the meeting and may not be testifying. I'm not sure.
Let me see if Susanna or Richard, do you see him? Yes, oh yeah, I do see him. He's there. He's just not. Can you please ask him to unmute himself?
Yes.
Thank you, because he did sign up. Ben Steffen, can you unmute yourself? While he does that, let me go on to the next witness and we'll come back to him. Why don't we have Craig Beam? Good afternoon.
Hey, good afternoon. Craig Behm, I'm the Executive Director of CRISP, our State Designated Health Information Exchange. First, I'd like to thank you, Madam Chair, Madam Vice Chair, for your leadership and support. It's hard to believe, but nearly 15 years ago, this committee laid the foundation for the HIE. We now deliver over 200,000 pieces of data into EHRs at the point of care. We support the Health Services Cost Review Commission and hospitals with population health reports. And of course, we've done a lot for public health over the past few years. I'm actually starting with the opioid epidemic and the prescription drug monitoring database. It's been a really natural evolution. I'm proud of what we've accomplished and where we're going. As David Sharp said, really HB 1127 will advance the HIE in three key ways. First, it formalizes the position as a health data utility, which means we have a long-term role in sharing data for public health and may continue to supplement the state's public health IT infrastructure. It does not force the department to use us, but it creates expectations if they do. Second, it expands the data available for providers and health departments by mandating the sharing of medications. And then finally, it ensures the HIE will continue well into the future by requiring financial sustainability report and additional consumer protections. As one very brief example of why this is so important, during COVID-19, the Department of Health cared a lot about equity and accessibility for test results and vaccines. We care about that also with new antiviral drugs. But unlike those other use cases, we don't have the data to do reports by race, ethnicity, and geography to make sure the drugs are distributed equitably. We could do that for vaccines. We could do it for lab tests. We can't do it for medications. Then, of course, there are many other uses, as David laid out, with medication interactions, antibiotic stewardship programs, and more. We are very ready to assist healthcare leaders as they confront new challenges beyond direct patient care, like social determinants of health equity, access, etc. A comprehensive, safe, and thoughtful approach with the HIE operating as a health data utility will give Maryland significant advantages, just like it did during COVID-19. I urge a favorable report. Thank you for your time.
Thank you, Mr. Bam, for your work and everything you do. I really appreciate it. Next, let's try Ben Steffen. Steffen?
Madam Vice Chair, this
Yes.
is David. Ben is not presenting today. He sends his regards.
Well, thank you for letting us know. So we're going to go to Ms. Robin Elliott. Good afternoon, Robin.
Good afternoon. Thank you so much for having me. I am here on behalf of a lot of organizations. You have a letter of support signed by the American College of Nurse Midwives, Healthcare for the Homeless, Domestic Violence, Survivor Advocates, a number of different groups, all in support of this bill. We do understand the clinical utility of data sharing and how it can be used to improve patient outcomes. We have worked hard in discussions with, I wanted to thank Craig Bem and Ben Steffen on really thinking through how the system can protect consumer privacy for those who have a heightened need for confidentiality of their data. For instance, an individual who is worried about a abusive partner finding out about prescription information or other healthcare information. And so they have promised to work with us. There's an amendment from us in your packet to put together a consumer advisory group to really think through how the system can be shaped to both be efficient for providers, but as well as offer protections for those consumers who just have a little bit of an extra need for privacy. Thank you.
Thank you, Ms. Elliott. Are there any questions for this favorable panel? Okay, seeing none. Oh, yes, we do. We have Delegate Hill. I almost missed you there.
I couldn't figure out how to get to the button.
Oh, it's okay. It's all right.
I'm sorry. Thank you. I don't know who wants to. I'm not really understanding practically, what this is doing for all the authority we're giving it. So can someone give me 2 examples of where this would be used and how it would be used?
So who will be the best person? Is there Mr. Bam or is it David Sharp?
So might I offer up Craig Bem as an opportunity to speak, and then I can build on his response.
We would do that.
Thank you. And thank you.
And we only allow 1 person though. So we're going to stick to the rules and I know he can handle it.
I will do my best. And you'll forgive me for not being a clinician, so I might not give a very adequate response, but 1 example. So right now, if you were to search for a patient in CRISP, you could see all sorts of information related to their care team, past hospitalizations. You could pull up summary health records and scroll through and read pages. You could see the CDS, the controlled dangerous substances, in a special view and where they were prescribed and everything. The actual medications, the non-CDS drugs, are either buried in clinical documents or not available. And so this would allow us to present medications kind of along with the rest of the health data in a much more kind of precise way. So it could be more usable. You could see when things were dispensed. As we look at claims data also, you could see prescribed and not dispensed. And so it would just give you, I think, more robust, kind of cleaner views of medication data within the broader clinical context. Another example that we received from an epidemiologist was, as we look at things like antibiotic stewardship in nursing homes, understanding the level of prescriptions and where they're happening could help with different outreach programs and training programs. It's another kind of evidence-based point for them as they do their interventions.
Okay, just as a follow, maybe you can follow up with me offline, because I know what you're describing is what we do with Shore Scripts and Express Scripts. So I have a lot of questions about why the state has access to this, and maybe I'm misunderstanding that it's the state not having access to the information but being the entity that shares it for other providers. But I would love to have a conversation with someone about this. I have some concerns. Thank you.
All right, will you be so kind and reach out to Delegate Hill offline?
Certainly
please?
will.
Thank you so much for addressing her questions. Are there any other questions for this panel? Seeing none, thank you so much for being with us. We do have an unfavorable witness, and that is Mr. Vince McEvoy. Good afternoon.
Good afternoon, Chair. I want to confirm we're on HB 1127, yes?
You are on HB 1127. That is correct.
Very good. Thank you so much. As I'm reading this bill, we have to put the timing on this, and I heard some of the explanation that the technical issues have been looked into. I think that we're far from having these issues resolved within the state with respect to public health data. But this is just a bad time for this bill. Finding those that the bill talks about collection, aggregation, and analysis. This is granular data, and finding that those that are not vaxxed have a political orientation. We have issues where currently, for whatever reason, I was just over in Economic Matters talking about social media, whether it's social media branding or just happenstance, anecdotal. We're having people make assumptions about their medical choices that are very personal issues. That piece is actually brought up in the bills today. And this kind of coalescing of data where we're sort of Minority Report, that movie, sort of judging people by what's going on with their personal medical choices, I find very concerning. We're having more data come out through alternative news sources such as Rumble, Church Militant, Odyssey, Cozy TV, a whole bunch of others that are giving unbiased, unslanted information that's very helpful to help us make clarity of these facts. Also, the bill talks about public health data, and as I've affirmed for you lawmakers, public health is highly partisan, often highly ideological, and I haven't seen it to fix anything, but I do see that it injects a lot of toxicity and concern. When we have database collection like this, we should all be very concerned, especially in this era. So I would urge an unfavorable for this. I do thank you all for listening.
Thank you for your testimony today. We appreciate it. Are there any questions for this witness? Seeing none, thank you so much for being with us. And this actually concludes the bill hearing on House Bill 1127. Next, we have House Bill 1352, Delegate Hill, Health and Wellness Standards Correctional Facilities. Delegate Hill.
Thank you very much, Madam Chair, and to Chair Pendergrass and the Vice Chair and the other members of the committee. For the record, Terry Hill, here before you with a bill that most of you are very familiar with, having worked on it with me and passed it out of this committee a couple of times. This is the bill HB 1352, which is the Health and Wellness Standards, which is designed to improve the short and long-term health of Maryland's incarcerated population by requiring adoption of health and wellness standards in all of the correctional institutions that incorporate plant-based meal options, that require that the food standards at correctional facilities and residential treatment centers be regularly updated every 5 years, consistent with the latest science and knowledge about best practices in diet, that the plant-based whole meal foods and beverages be available as options at two institutions that are participating in a pilot study to see if the access to nutritionally balanced plant-based diets improve the health outcomes of the incarcerated population. And then it also allows that inmates, and this is supposedly something that's already done, but this was statutorily allowed that all inmates have the opportunity to opt into available diet plans, whether it's kosher, halal, vegetarian, diabetic, what have you, without having a religious reason or medical excuse to do so. And so essentially, this is the bill that we've had before us that we have modified and amended, with the exception that in past years, we've also included hospitals and the diets that they serve. And we've taken that section, the references to the hospitals, completely out of this bill. So again, as you all know, what you eat has a great deal of impact on the health, particularly with respect to chronic diseases like diabetes, high blood pressure, and heart disease. And we see in our incarcerated population that they have particularly high rates of these chronic illnesses. They're offered some options in diet, but the option to eat from a vegetarian menu, but not necessarily a complex carbohydrate-rich plant-based diet that gives you a full balance of nutrition is not there. And we wanted to see and believe that there's ample evidence to prove that if inmates voluntarily are able to opt into those diet plans, and those are actually can be very tasty, enjoyable meals to eat, that those who the population that opts into them, that we would see over a relatively short period of time, changes in their health outcomes, a little bit like the reverse of what we saw in Supersize It, when the guy went around and ate only McDonald's food for a year and saw enormous detriments to all of his measurable health indices. So that's the bill. I've explained what the changes from the bill that we've had before us in the past, and I really ask for your favorable support, and we'll turn the rest of my time over to the panelists. Thank you.
Okay, wonderful. So you have 1 minute and 27 seconds. Would you like Ms. Jo St. George to have that time?
Or, sure.
Okay, great. Ms. St. George, good afternoon.
Good afternoon, and thank you. And I'm going to keep mine short so I can give my time to Dr. Milton Mills and Ruby Latham. Good afternoon, Chair, Committee. I'm the Director of the Maryland Plant-Based Advocates Coalition and the new Chair of the HBCU College of Plant-Based Lifestyle Medicine, which is a 501c3 focused on training and educating HBCU future medical professionals and current prison inmates and professionals in plant-based lifestyle medicine. According to the CDC report, June 2021, chronic disease represents the top 7 killers of all US citizens, but is the primary determinant for those who have poor outcomes with COVID-19. As you know, chronic disease makes up 30% of the inmate population's healthcare costs of $130 million a year. And consequently, we believe that this plant-based meal bill will address the underlying chronic diseases that put inmates at the highest risk for death and poor outcomes from not only COVID, but any communicable disease. And they should have the right to choose not only what they eat, but actually choose food as medicine, because the data is already out there. Hundreds of reports have demonstrated, scientific reports have demonstrated that plant-based lifestyle does prevent chronic disease. And so we're just asking for the opportunity to allow the choice to be provided so that we don't focus on one form of intervention, but use a holistic approach in addressing the healthcare needs of inmates. So we ask for a favorable report. Thank you so much.
Thank you for being with us. We're going to give you time to Milton Mills. Will you please, good afternoon, get started.
Good afternoon, Chair, Vice Chair, and members of the committee. My name is Dr. Milton Mills. I am a critical care physician and board member for the HBCU College of Plant-Based Lifestyle Medicine, and for the organization Switch for Good. And in the interest of complete transparency, you should know that I'm also the medical director for the United States Census Bureau and chief medical officer for the Nuclear Regulatory Commission's health units, although obviously I'm not here speaking for those organizations. But as a plant-based critical care physician for over 30 years, I wanted you to know I do support HB 1352, the Prison Plant-Based Meal Pilot Project, because I have seen over the course of my career the deaths of thousands of patients from chronic diseases which are directly related to the standard American diet, which is high in animal foods, fats, and low in protective plant-based diseases. And one of the things that has been unmasked by this COVID pandemic has been the direct relationship between the health of our immune systems and the foods that we eat. We're also starting to realize that plant-based diets can be protective in helping to prevent long COVID. And so it is critically important to help protect the vulnerable prison population by providing healthy, balanced, whole food plant-based diets to these people who otherwise might not have access to these foods. So I want to throw my wholehearted support behind this bill and encourage the panel members to please support this bill because we can help prevent unnecessary illness and death. Please vote yes on HB 1352. Thank you.
Thank you for being with us, Doctor. We appreciate it. We have Ruby Layton.
Good afternoon. I'm Dr. Ruby Lathan, a certified holistic nutritionist and board member of the HBCU College of Plant-Based Lifestyle Medicine. I support for the third time HB 1352 and ask for a favorable report. It is essential that this committee provide inmates not sentenced to the death penalty the right to choose a nutritious plant-based diet so they can live and not die a premature death from chronic disease, which the cost of which makes up 1/3 of the prison's $130 million healthcare budget. As I reported in 2020 and 21, my comprehensive review of the Maryland Department of Corrections 5-week meal menu revealed that inmate meals consist of a high amount of animal fat, sodium, very little fiber, water, and micronutrients. This has for years placed inmates at risk for death to all communicable diseases. The good news is that this committee can do something about that, the health crisis in the Maryland prisons, and that's to pass this bill so that inmates can have some control of their health and reduce the risk of COVID or any communicable disease by eating a plant-based diet. In 2021, 3 important scientific studies were published that proved the efficacy of a plant-based diet against COVID. According to one of the studies, of hundreds of healthcare workers, those who ate 100% plant-based had a 73% reduction in COVID severity, and those who ate a predominantly animal-based diet had approximately 45% increase in COVID severity. The medical evidence establishes that HB 1352 is an effective and preventative strategy for preventing death by pandemic and communicable diseases, and also reversing chronic diseases, which the CDC says is the primary cause of COVID-related deaths. Therefore, I ask for a favorable report on HB 1352.
Thank you very much, Doctor, for your testimony. Next, we have Michael Wilson. Good afternoon, sir.
Good afternoon. My name is Michael J. Wilson. I'm the Director of Maryland Hunger Solutions. It's my honor to appear before you, Madam Chair and Madam Vice Chair, members of the committee. Maryland Hunger Solutions is a statewide, nonpartisan, nonprofit organization working to end hunger and increase nutrition in the state of Maryland. We work with partners, school districts, elected officials, community organizations to help utilize federal and state nutrition programs. I've submitted testimony for your consideration, and so I will briefly summarize our support with amendment for this bill. So the COVID-19 has impacted all of us, and our prison population has not been exempted from that. The challenges from people who are incarcerated is very severe, and the proposal to update standards for their food services is welcome. In addition, mandating vegetarian options gives greater choice and opportunities for intentional nutrition for a population that has very little choice in their food selection. That is a step forward, and we support it. However, the proposed mandatory Meatless Mondays is a step back. Incarcerated Marylanders should not have choices taken away, which is what this part of the legislation does. If the first part of the bill successfully offers vegetarian options, then this provision should be unnecessary. But when a population has no voice, no opportunity to choose, and no ability to vote, has this imposed on them, it is not an option. It's simply another rule that's forced on an incarcerated population. In addition, it's quite clear that given the racial composition of the population, that making choices made for a population that is overwhelmingly Black and brown and denying them an opportunity to make choices for themselves should not happen. It's our hope that that second provision will be dropped and the rest of the bill goes forward. And I thank you for your time and your attention.
Thank you for your testimony today. Now we're going to the question part of this hearing. And I see first Delegate Chisholm. Good afternoon, Delegate.
Thank you, Madam Chair. Before I ask my question, I want to say ditto to Mr. Michael Wilson for both myself and my old colleague, Delegate Barron, because this has been in front of us several times. And I do have a question. I am interested. I looked at the fiscal note, and I understand this is a pilot and we're just adopting standards, but it's a, relatively speaking, a very small fiscal note, 45,000 this year and then 12 or in 23 and then 12,000. So does the pilot just include us adopting standards, or does this include the actual plant-based food?
So Delegate Hill?
Yes, sure.
Who would like to address that?
The pilot includes the plant-based food at 3 institutions, a small, a medium, a large institution. And it is offered. And one of the other things that the bill does stipulate is that the plant-based diet be offered at a cost that is no greater than what the standard diet costs are. So these foods can be sourced economically. So the small fiscal note is really not surprising.
Thank you, Madam Chair.
My pleasure, Delegate. Next, we have Delegate Shalega. Good afternoon.
Thank you so much, Madam Chair. So I'm reading the bill, and it sounds like what you're looking for is the correction system to, on page, what page is this on? 4, to allow inmates without requiring an exemption to change their food options to kosher, halal, diabetic, or any other diet that's available. And they have to stick to that for 6 months. Is that right?
That's correct, because that is essentially what happens when the diet is opted for the corrections institutions, because they have to purchase in advance and have savings by purchasing in bulk. There's a fixed amount of time. And so what we did not want to do was handicap them or have them have to accommodate changes on a weekly or more frequent basis than what they're normally able to accommodate. So we're essentially allowing folks to stick with the diet the same way that's consistent with what works for corrections.
And the number 4 says any other diet that is available to an inmate. Is that where you're looking for your plant-based meals?
Correct.
Okay. And so they'll make this selection, and then what happens if they don't like it? I guess it doesn't matter. They're in prison. So they're going to stick with their choice. Is that what you're thinking?
Well, remember, they also have a commissary, which is costly to them, but they always have the option of not eating the cafeteria and opting to spend their money to purchase the commissary, where there are outside vendors like, for instance, a Chick-fil-A, where they can get their food, right?
Yeah, I do, of course, know that many of the folks in prison don't have money to go to the commissary. And so that's great, but I hear they eat a lot of oodles and noodles out of the commissary when they don't like the food.
And so at a high fee. So yes, we're on the same page with that.
Yeah. So
a lot of money out of the community.
And later in the bill, I see that you have the also addition that you want them to have a meatless day. Is that still part of it, or are you trying to get them to select the meatless diet for 6 months?
I'm going to let Ms. St. George explain that, but there is a question about whether the meatless Monday is something that we would amend out of the bill. So that's still open for discussion, but Ms. St. George can take the question.
Thank you, Delegate Shalega, for asking that question. The purpose of the Meatless Monday is we're seeing plant-based meals as food as medicine. We already know that for the last 15 years, the prison has spent 130 million, 30% of that on chronic disease. The purpose of this pilot is to demonstrate and show the efficacy of plant-based food as medicine. And so by having the Meatless Monday, which remember, inmates don't have a choice at all with regards to what's served to them, everyone will get the benefit of having food as medicine and them not being discriminated against for them not choosing per se a plant-based meal, and others benefit when they do because their health improves. The health improvement that's provided by changing diet and increasing fiber is already evident. We don't really need to prove it. There's over 200 studies around the world. We're just using this pilot to demonstrate that it can work in a prison system using prison infrastructure to make it happen. So
I guess my question was about how you're implementing. So page 6, each correctional facility participating in the pilot shall, and then little I, provide at least one plant-based meal option, at least one plant-based beverage to all inmates at each meal, at least 1 day a week. So the bill allows them to choose that for 6 months, but then there's also going to continue to be a Meatless Monday.
Correct. So you have the choice, and then you have the Meatless Monday, but that's to address the potential issue of there being some discrimination between those who benefit from making the choice and those who don't make the choice, but still should be entitled to food as medicine. Currently,
but you're not giving them a choice on Meatless Monday, is that right?
Let me give.
Actually, wait a minute. Let me stop it right here. Delegate Shalega, that was like 8 questions. Yes. I allow it. It will probably go to subcommittee. So let me move on, okay? To the rest of the members. All right, thank you so much. Because we have been also joined by Judiciary, and Delegate McComas has a question. Then I have Delegate Saab, okay? Delegate McComas.
Thank you, Madam Chair. I feel like a little bit of an interloper, but because this is the first time I've heard the bill. But my question, I guess, would be for the doctors, the 3 doctors that I think we have here. Has this ever been experimented elsewhere in any prison systems where they have tried a better diet for the inmates as opposed to just meat and carbs, bad carbs?
Delegate McComas, this is Joe St. George. I can better answer that question for you, having worked in a prison that did use plant-based meal in California. It was Maranatha Prison for 5 years. They offered a whole plant-based side of the prison itself. So everyone in that part of the prison for a 5-year period was on a all vegan diet, and they had education and training, and the recidivism went down to 4%. The health of the individuals was improved. And when they, left the facility, they were changed people. So that's actually where this bill is born out of, because I volunteered in that prison from 1997 to 1999. And my brother is a California incarcerate. So I have personal firsthand experience with the meals in prison.
So basically, before they started the program, did they sort of experiment to see if the inmates would take to it? Because I'm just kind of wondering, you always think of, men wanting meat and potatoes kind of, and, the stuff that a lot of us that are a little older were raised on, as opposed to, fiber and vegetables and all that good stuff. So I was just kind of wondering if they ever did a test case to see if it was going to work before they implemented it completely for one section of a institution.
The bill does have specifically in the provision that this bill requires there to be a taste test so that there is that buy-in, number one. And number 2, for 15 years, the Federal Bureau of Prison has been offering plant-based meals, and they do survey their inmates. They ask them what they prefer. Some prisons around the country, though, regretfully, where I used to live in Arizona, they didn't do that, and they gave them garbage food, and it was plant-based mush. So we tried to prevent that from happening by building that into the bill. And Dr. Ruby Latham is a fabulous chef, and will make sure that the food tastes good. And that's why she's here to be a part of the education process. Dr. Milton Mills.
Yeah,
No, you cannot, we only allowed the one witness to answer, okay? And let me just remind everyone, we have 98 witnesses, okay? So you can ask a question, you can ask maybe two, but we have to move on, okay?
Thank you.
Delegate McComas, you could have one last one because you're new.
No. I've got to go back to my judiciary. So, but thank you very much. It was very enlightening.
Thank you so much. And you're welcome to come to the subcommittee. Okay.
Okay.
Thank you.
Thank you.
My pleasure. Delegate Saab.
Thank you, Madam Chairman. I guess my question is, I've always wondered, why is it called Meatless Monday? Was it just because it rhymes, or is it because there's a science behind it? And the other real question that I have is, when the program automatically renews after 6 months, I didn't see it anywhere in the bill that says like how much of a notice they have to let the, I guess the prison officials know that they want to either stick with the diet or change to the original diet that they have.
So let me answer. So it actually does say that they have to give notice. They have to use a written form that the prison provides if they're going to change their mind, just similar to what they do right now. And I also want to be clear, what the question seems to be missing, that even in the pilot study, we're saying an option. So it's not that every prisoner or inmate or incarcerated person at a pilot facility is only offered a plant-based diet. At the meal, they are offered whatever the regular choice is, and they're given a plant-based choice as well. And that's being tracked. But what happens is you have to choose, just like if you're taking a plane flight, you choose the meal. But in corrections, you choose the type of meal you want to be served for a period of time. So there will be prisoners who will be saying in that pilot, I want my regular meat and potatoes meal. There are some who are saying I want a vegetarian meal. And we're hoping, because this prison will be in the pilot, that they will be offering a plant-based diet option, that there will be prisoners who say, okay, I want to be in the plant-based diet group. So it's not that at every meal, everybody is eating a plant-based diet.
The question is, how far in advance they have to turn in their notice to say that I don't want to be in the program anymore? Because what if everybody decides they don't want to be in the program, and now we're buying food that no one is eating? So what is
the end of the 6 months, it defaults out then.
But it says here, it's to be renewed automatically unless the inmate provides additional notice in writing of a change. So how far is that notice? Like, my question is, how far in advance that notice has to be?
It's the same. I don't think we have to specify, but if we do, we can certainly put it in there for the subcommittee. But it's the same period of notice that they need to give now when they want to change. It's so that the corrections can make the change in their purchasing. And I don't know if that's 2 weeks notice, and I don't want to speak on behalf of corrections to what that notice is, or be prescriptive when they already have a notice period that's required.
Thank you. Thank you, Madam Chairman.
My pleasure. Are there any other questions for this sponsor in her panel? Okay. Thank you very much for being with us today. And this concludes the real hearing on House Bill 1352. Next, we have House Bill 935, Delegate Bagnall, Health and Health Insurance, Behavioral Health Services, Expansion, Behavioral Health System Modernization Act. Welcome, Delegate Bagnall. You have 5 minutes.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. For the record, I'm Delegate Heather Bagnall, District 33 in Anne Arundel County, here on behalf of HB 935, the Behavioral Health System Modernization Act. It is no mystery that I have a passion for behavioral health. In 2020, when the pandemic first hit Maryland, I started raising alarm bells about a potential second behavioral health crisis. The pandemic has caused a huge increase in the demand and the need for mental health and substance use services. Maryland already has a really good behavioral health system, one of the best in the country. It's It's part of how we were able to continue providing services throughout the pandemic, why we worked so hard to expand access and equitable reimbursement for telehealth. But as we begin to see a reduction in COVID, we need to use this opportunity to turn our full attention to making our good system a great system with just a few enhancements. Building on the great work in Maryland shepherded by this committee, the Behavioral Health System Modernization Act will implement a series of reforms that will bring Maryland's behavioral health system fully into the 21st century so we can meet the increasing demand for high quality mental health and substance use services by focusing on equitable community-based services, individualized integrated care, and workforce development. I want to thank this committee as well as the Appropriations Committee for your consideration, because this is not only sound public health policy, it is fiscally responsive, investing our dollars in the most strategic and effective way to ensure quality and continuity of care and access of comprehensive behavioral health services while reducing emergency department visits. Because this is a large bill, I'll use my time to give you the overview, and then my panel will speak to the 5 components, which expand comprehensive community-based treatment with certified community behavioral health clinics, or CCBHCs, by requiring the establishment of CCBHCs across Maryland. These federally designated proven models deliver a comprehensive range of outpatient mental health and substance use treatment, care coordination with other providers and services, and connection to other systems and supports. The bill will improve health outcomes and treatment quality by expanding the delivery of individualized, data-driven, measurement-based care in behavioral health settings, and by enhancing care coordination in primary care settings. It will strengthen the behavioral health workforce with peer support networks and certified peer recovery specialists. Specifically, the bill will expand resources and professional opportunities for individuals with lived behavioral health experience so they may better assist others in navigating treatment systems and recovery support services. It will improve care for children and youth with behavioral health needs by increasing the availability of comprehensive home and community-based wraparound services and supports for children, youth, and families. And finally, it will reduce the reliance on law enforcement and emergency departments by enhancing Maryland's network of crisis call centers, mobile crisis teams, and crisis stabilization facilities. I've offered a sponsor amendment to address concerns raised by the Maryland Insurance Administration, and we're continuing to work with the carriers to address their concerns. And you will see in your packet that we have no opposition from the carriers and widespread support from the hospitals, providers, MedCai, behavioral health organizations, and advocates across the state. As you review the fiscal note, I want to point out a few things. One, these numbers were an estimate on anticipated utilization and are likely somewhat inflated. 2, that we have federally matched funding for these programs. 3, mandated appropriations do not begin until 2024. And 4, we will see savings on uncompensated care, reduced ED visits, and repeat emergency services utilization. Finally, I want to leave you with a couple numbers. $775.30. That is the cost per person per year for services under the collaborative care model. Less than half of the cost of a single ED visit. And $471.34 per member per month. That is the cost of the community-based services for youth. I won't pretend this will be easy, but it is absolutely necessary, will ensure more effective, coordinated, and financially prudent care, and will be life-saving. Maryland has already been moving in the direction of an integrated system of care, and the Behavioral Health System Modernization Act will bring all of that work together. We can't wait while our Maryland citizens suffer. We have the opportunity to be a leader in the nation on behavioral health care. And for all these reasons, I am asking for your favorable report on House Bill 935.
Thank you, Delegate. We have the first panel favorable is Mr. Dan Martin. Good afternoon.
Good afternoon, Madam Chair, members of the committee. Thank you so much. Dan Martin here in strong support of House Bill 935. And I want to thank Delegate Bagnall very much for introducing it. This is priority legislation this year for the 100+ members of the Maryland Behavioral Health Coalition who really spent a lot of time last year. We're putting our heads together and saying, what can we do coming out of this pandemic to really increase access to services for folks with mental health and substance use needs? And this is the solution we came up with, the Behavioral Health System Modernization Act. like Delegate Bagnall said, the idea is it takes a good system and makes it a great system by implementing just a few enhancements to bring our system into the 21st century. The reforms here aren't groundbreaking. They're not new. These things are going on in other states. We've been talking about them here in Maryland for years. And it's really just time to push these things over the finish line. And I know there's a fiscal note, but I just want to say we have a tendency here in this state and in this country, whether it's commercial carriers or the public system, whether it's primary care or outpatient behavioral health services, to really resist paying for the prevention and early intervention treatments that can keep people out of medical emergencies and behavioral health crises. And it ends up killing us on the back end, both literally and economically, in high ED visits and serious chronic conditions and high cost procedures. And so we really need to just break the cycle, get upstream and prevent more serious, costly and sickly illness. And so I'll just mention one piece of the bill before I turn it over to my colleagues. Like Delegate Bagnall said, it would require reimbursement for the collaborative care model. This really is the best tool we have to improve the delivery of behavioral health care in primary care settings, which is where most people with mild to moderate depression, anxiety, et cetera, go to get their care. There's been a pilot going on in Medicaid pursuant to legislation you all passed since 2018 that's showing fantastic outcomes, clinically significant improvement for over 65% of the participants. 19 other states' Medicaid departments are paying for these codes. In Maryland, commercial carriers and Medicare are paying for the codes, but the inability to expand it broadly is stifled by the failure to reimburse through Medicaid. So, Delegate Bagnall for introducing the bill. We're really excited about it, and I'll turn it over to my colleagues to talk about the rest of the bill.
Thank you. Next, we have Ms. Lori Doyle.
Thank you, Madam Chair. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland, and my remarks will focus on certified community behavioral health clinics, CCBHCs, which are in the uncodified section of this bill. This is a federal designation based on federally qualified health center model of providing comprehensive care to those in need, but with a behavioral health focus. We have a problem here in Maryland. Our emergency department wait times are the longest in the nation. MIMS did a study of ED throughput in November 2021. They found that at any given time, there are 200 to 350 patients boarding in our EDs. Psych patients accounted for 25% of ED boarders, but 68% of ED boarding time. So that suggests we need a different approach to getting people out of EDs and avoiding them to begin with. That approach is CCBHCs. Just a couple statistics to give you. In Missouri, when they implemented this model, hospitalizations dropped 20% after 3 years and ED visits dropped 36%. In New York, all-cause hospital readmissions dropped 55% after the first year. And in New Jersey, the number of clients receiving medication-assisted treatment, which is the evidence-based practice for treating opioid use disorders, nearly doubled from year 1 to year 2. So it's very consistent with our total cost of care model. We currently have 5 organizations in Maryland that have 2-year grants from the federal government to implement CCBHCs. This bill would simply require the state to apply for a state plan amendment or a waiver to implement them in the state so that we don't lose all the momentum we've gotten with these 2-year grants in these 5 jurisdictions. So I'll leave you with 2 other statistics, not happy ones. Since the pandemic, Maryland has seen a 46% rise in youth suicide attempts and an 18% rise in overdose deaths. So it's time to do what we know works. We ask for your favorable report on this bill. Thank you.
Thank you. Next, we have Mr. Dan Rabbit.
Thank you, Madam Vice Chair, Madam Chair, members of the committee. My name is Dan Rabbit, Policy Director at Behavioral Health System Baltimore, Bhsb, for the local Behavioral Health Authority for Baltimore City. We stand in strong support of HB 935 in its entirety, but I'll focus my remarks on the provisions establishing reimbursement for crisis response services. As you've heard from Lori and likely recognized in your own districts, we are in the midst of an unprecedented mental health emergency, and that is also leading to a spike in mental health and substance use crises. I won't belabor the statistics, but it's pretty clear in what we're seeing. And what we need to respond to these behavioral health crises are tailored services that are specifically designed for mental health and substance use emergencies. The traditional EMS system of 911, ambulances, law enforcement intervention, and emergency rooms is not designed for behavioral health crisis. Being strapped to a stretcher or handcuffed and sent to a loud, chaotic emergency room is not what folks who are experiencing emotional distress really need. We do know what they need. It's the services provided through our crisis response system. It's crisis call centers, mobile crisis response teams, and crisis stabilization centers. We have some of these services today in various parts of the state, but the problem is that these services are not always available when and where people need them. They're largely grant funded and limited in their scope and reach. Insurance reimbursement established in this bill would provide the sustainable, scalable funding we need to expand our state's capacity. And it's a good investment. Crisis services save money otherwise spent on ER visits and higher levels of care. The HSCRC identified crisis services through their regional catalyst grants. It's one of the highest value investments they could make to bring down hospital costs. And for Medicaid, the federal government passed legislation in the American Rescue Plan to provide an 85% match for mobile crisis response. So we think providing insurance reimbursement, makes good clinical sense and good fiscal sense, and we urge a favorable report.
Thank you for your testimony. Next, we have Michelle Lifshin.
Thank you, committee members, for your dedicated service and to Delegate Bagnall for your leadership on this bill. I'm Michelle Lifshin, representing Honor Own of Maryland. We're in strong support of HB 935. This bill invests in independent peer-run programs like our statewide network of over 20 wellness and recovery centers, which provide walk-in services to more than 5,000 people with no fees, no time limits, and no barriers to entry. Peer support makes our system accessible by meeting people right where they are and making sure they feel safe, respected, and hopeful about their recovery. Peer support specialists know what it's like to use services, what it's like to be in crisis, what helps and what harms. Peers help individuals grow skills for self-care, and we help programs and services become more trauma-informed, more healing-centered, and more effective. As described in our written testimony, centers in our network achieve incredible outcomes despite shoestring budgets, often less than $150,000 per year. The funding provided through this bill will add staff, add hours, and add services. Now is the ideal time to invest in peers, not only because having a strong support network is essential to recovery, but because peers are the next generation of certified specialists, community leaders, and change agents who are eager to join the behavioral health workforce and move us forward as a system. HB 935 puts funding directly into programs and services created by peers for peers, where mutual understanding, respect, choice, recovery, and wellness is a shared journey that everyone can make. We encourage a favorable report. Thank you.
Thank you for your service. Next, we have Ms. Ann Gibbs.
Thank you, Madam Chair and committee members. My name is Ann Geddes. I'm with the Maryland Coalition of Families. MCF provides family peer support to families that are caring for a child or other loved one with behavioral health needs. And I'm here in support of House Bill 935. Specifically, I want to speak the portion of the bill that addresses strengthening the targeted case management and 1915I programs for children and youth. These two programs were intended to be the pillars of home and community-based services for children and youth in Maryland. They are based on the wraparound model of service delivery, which is the gold standard for treating children and adolescents with intensive mental health needs. Ultimately, there have been a number of problems with the programs, eligibility requirements that are extremely restricted, limited numbers of providers, underutilization of evidence-based practices, and low satisfaction with the service by families all have contributed to the weaknesses of the programs and consequently very low enrollment. House Bill 935 would do 5 things to strengthen the 1959 TCM programs. It would require that care coordinators be trained in the delivery of high fidelity wraparound and that providers be reimbursed at adequate rates for that service. This would improve the quality of the service. It would require that providers of evidence-based practices be reimbursed at rates commensurate with industry standards. Currently, for example, the rate for family-centered treatment is about 1/2 of what DJS pays for the same service. Adequate rates would promote the use of evidence-based practices and would attract more providers. It would establish adequate funding in BHA's budget for customized goods and services, which is one of the benefits of the programs, for things such as equine therapy, art therapy, and martial arts classes, things that are not covered by Medicaid but can do much to promote a youth's recovery. Currently, BHA has to find money from various pots that might be available, and House Bill 935 would provide a dedicated pool of funding. It would expand the number of slots for non-Medicaid eligible youth from 50 to 100. Currently, there is a lengthy waiting list for these slots, and it will require that BHA look at loosening eligibility criteria so that more youth can take advantage of the programs and expand the programs to serve youth with substance use disorders. I just want to add the shortage of residential treatment beds for kids and the problem of kids stuck in hospitals and emergency departments can be attributed to the lack of community-based services, and House Bill 935 would strengthen those services, so we urge a favorable report.
Thank you very much for your testimony. Are there any questions for this panel? Second. And we're joined, by the way, by the Appropriations Committee, and you're welcome to ask questions. We have Delegate Geraldine Valentino Smith, followed by Delegate Lewis Young.
Thank you, Madam Chair, and I want to be respectful of the long day that you have. So quickly for the provider panel that supported it, they know how to find me too with extra details. Can you just let me know how many states have applied for amendments to their state plan or for a waiver similar to this? And are the amounts that you have set forth in the bill, are those general fund and special fund, or are those just general fund amounts counting on matching federal money?
I will try to answer that, Delegate Valentino Smith. I think it depends on what part of the bill you're referring to. I mean, there's CCBHCs that require state plan amendments. There are collaborative care type efforts that require state plan amendments, a lot of different things. And the bill does go through, both general funds and federal funds. Actually 2/3 of the funding in the fiscal note's a little misleading. Actually, 2/3 of the funding is federal funding. And a lot of the bills can be done with kind of little or no state fiscal impact, a lot of the different pieces of the bill. So it's a little misleading there. And I think it depends, in terms of how many states and which specific piece you're talking about.
Okay, well, thank you. Thank you, Delegate Bagnell, for raising opportunities to explore different ways to get these important healthcare services out. Thank you, HGO, for including us.
Thank you. Next, we have Delegate Lewis Young, followed by Chairman Pendergrass.
Thank you, Madam Chair. I also wanted to explore aspects of the fiscal note a bit deeper. If someone could share the fundamental assumptions. And also I heard the number $775 a person. Is that per Maryland resident? Is that per patient treated? So whoever would like to elaborate on that.
Lori, you or me, it doesn't matter.
Whoever is the best person to answer the question, please.
Go ahead, Dan, because I don't think that's specific to CCBHCs.
Yeah. So I mean, again, the fiscal impact. Digging deep, Delegate Lewis Young. I'm happy to kind of walk through all these different pieces with you, either here or kind of offline. But again, there's the certified community behavioral health clinic piece that has zero fiscal impact. There's a collaborative care piece that has a modest fiscal impact. Again, because the note itself is based on potential eligibility, not uptake. That the measurement of care piece has depending on whether it's commercial carriers or whether it's Medicaid funding. It depends on the actual fiscal impact. So there's a lot that goes into kind of what the fiscal impact is of each different section of the bill. And I do have all that charted out, and I'm happy to go into it with you either here again or in subcommittee or wherever it makes the most sense. I just don't want to belabor the process here.
Okay, thanks. I think between your answer and the last question, I got most of what I was looking for. Thanks.
Thank you. We have Chairman Pendergrass, followed by Delegate Kurt.
Thank you, Madam Chair. I'm also struggling with the fiscal note. So I want a clarification that the fiscal note, which presumably the dollar amounts were provided by our infamous health department, are just plain wrong, that it's 62% match in the fiscal note and it would really be 85%, and they were unaware of that. And the second question is, if you're doing this also with private insurance, are we talking about the state putting a mandate on all private insurance companies, which brings a whole other bag of worms into this piece of legislation? So could you clarify those two things, please?
Yeah. So again, I think you're right. I think the note is inflated a lot based on a lot of kind of faulty assumptions, on who would be eligible, on how this kind of would roll out. And I'm sorry, go ahead, Chairman.
I want the match, not the,
Well, I think
assumptions.
so. The match varies. So for collaborative care, the match is 60%. For the measurement-based care, it's 75%. For the peer support, clinical peer support is 75%. For the crisis response is 60%. So it varies depending on what the actual service is, what the federal match will be.
So nowhere did I hear the 85% that you mentioned.
Oh, I don't know. When did I mention? I don't. The 2/3.
Somebody mentioned, was it you or
Yeah,
Mr. Rabbit?
I mentioned it, Dan.
Okay, Dan.
Other Dan.
Okay, all right.
Sorry, Chair Pendergrass. Yes, the 85% match was passed in March by in the American Rescue Plan, and that's specific to mobile crisis teams, and it's only for 12 quarters. It's an incentive match. It's not an ongoing match. So I think that was not incorporated into the fiscal note, but that would be something the state would be eligible for if they were to go down this road.
And as far as the commercial carriers, the other piece of your question, some of these things, so the bill doesn't implicate commercial carriers in every single piece of it. Some of the times when it does, for instance, in measurement-based care, they are already doing a lot of it. A lot of the commercial carriers are already reimbursing for this. They're already reimbursing for the collaborative care model. When it comes to certified peer recovery specialists and crisis services, that's something that there are ongoing conversations with the commercial carriers about how we can do this. So,
may I ask a follow-up?
Sure.
The way the bill is written, it seems to be a mandate, and a mandated benefit has very big repercussions. So you would be willing to change it from a mandate to an encouragement?
we're in conversations now and open to anything that would help us kind of get some of these things moving.
Thank you. Next, we have Delegate Kirk.
Thank you, Madam Chairman. Lori Doyle, I'd like to ask you about the CCBHCs. Again, with the fiscal note, there's a mention about federal authority, and then it says that if we're going to serve all Medicaid enrollees in every county, there's a big number, 727 million annually, with 55% coming from the federal government. And then there's also the mandated funding for the wellness and recovery centers beneath that. Can you help put that in perspective for us, please?
Thank you. Yes, a few thoughts on that. One, of course, that this bill only requires applying for the waiver or state plan amendment, which has no fiscal note, but they're projecting down the road. And I think perhaps the department doesn't realize that they have ultimate control over the basket of services that CCBHCs provide. So they can make that consistent with their Medicaid state plan. So those things are already covered in the state by Medicaid. They also may not realize that CCBHCs have to present their budget to the state for approval and in fact live within that budget. So it gives the state greater budget predictability than what they have right now. And also finally, I'll just say that, we're happy to work with the sponsor, with this committee, to allay the fears of the department. I think if they understand this model and how it's working in other states, they'll understand that it's actually of great value to go forward with this.
Thank you, Lori, and thank you, Madam Chair.
My pleasure. Any other questions for this panel? Delegate Riley, good afternoon.
Thank you, Madam Chair. I guess this was to Ms. Doyle. So you had mentioned, probably that the administration doesn't understand the model of this particular bill. So the letters, I don't know if you saw the two letters of information from the Department of Health and also the Department of Budget and Management. So the funds that they're talking about, what they want to do, the additional funds that he put in the current budget, and the two plans for the mobile crisis services and the certified peer recovery specialists would, if we pass this bill, do these monies apply to this particular bill? Could they apply to this bill, or would it be in addition?
So if that was directed to me, I think that there are a couple investments that the state has made in emergency services and peer supports. So this would be different reimbursement for those same things. And I think we'd like to work with this committee and figure out how we prioritize the issues in this bill. We think it is an aspirational bill, and that we may chew pieces of this off a little bit over time, similar to the way you all did with the Kerwin investment. But I think that we are talking about lots of federal money coming in for many of these things, and including the CCBHCs, where actually CMS has said they are the connection between crisis services and 988 and are eligible in that capacity for that 85% match. So there's lots of ways to do this.
Okay, so some of these funds may overlap. It's just a matter of how we come up with a better program to advocate those monies to the
Correct.
services. Okay, thank you very much. Appreciate it.
Okay, any
Thank
other
you, Madam Chair.
question? My pleasure. Any other question for this panel? Okay, now we go to the favorable with amendment panel, and we have Mr. Neil Karkanis, the League of Life and Health Insurers of Maryland.
Good afternoon, Madam Chair and members of the Health and Government Operations Committee. My name is Neil Karkanis on behalf of the League of Life and Health Insurers to testify favorable with amendment to House Bill 935. Thank you for your time and attention today. I just want to start off by saying that we're firm believers of expanding behavioral health services, including implementing an effective crisis response system. We applaud Delegate Bagnall for bringing this bill, as well as the people on the ground that are doing the work. The need here is undeniable, and we want to continue to be a partner in ongoing efforts. Our concerns are operational in nature, and we do think these issues can be worked out. I did hear that Delegate Bagnall mentioned that she was submitting amendments based on feedback from the Maryland Insurance Administration. So I haven't seen those amendments, so I'm not sure if they address the technical concerns or not, but we're certainly happy to take a look. Basically, in the commercial insurance framework, there's no programs in a network. There's simply providers and claim codes. So those certified peer recovery specialists can currently be reimbursed by Medicaid and through grants. They're not recognized as licensed providers and do not currently have claim codes in the insurance article. So we need to look at how the accreditation standards work and how that works into the commercial insurance structure. We basically need to know who's performing the service, how the professional is licensed, and whether that service is through a licensed provider and how the codes are submitted. We'd also like to get additional specifics on the measurement-based care. Some of the terms that define it are ambiguous, and we'd like to work together to further define those terms. But like I said, generally speaking, we're in favor of improving these types of services, and we are favorable with amendments. Happy to work with the sponsor moving forward. Thank you.
Thank you for your testimony and for your willingness to work with the sponsor. Are there any questions for this witness of favorable with amendments? Seeing none, thank you so much. Now we go on to the panel of unfavorable. We have Mr. Vince McAvoy.
Thank you so much, committee, for taking my input on this. I see this as basically establishing a comprehensive substance abuse treatment. Wraparound services, the thing we just heard was what I used to hear from our former mayor, my former mayor, your former senator, formerly federally indicted convict, Kathleen Pugh. And the way that she put it up, she was going to build homes for these kind of things with her own lockers. And she had a very elaborate system for the substance abused. But what I'm looking at is where in this model is a mandate for something from the substance abuser, because they're not all children. And that's the core of this issue is people have to need to change. I live in Baltimore. Addicts don't use these type of systems to improve or get off drugs. They use them as rest stations. I see this firsthand in Baltimore City. So when I say here lived behavioral health workers, that hasn't helped the system. I can tell you from experience with people I run into in Baltimore, that these workers suffer relapses as well. So it's not the best model. This is a large bill. I'm going to have to hurry through some of these things. Senator McFadden talked about this issue in 2017 about how these homes are going up. And even in that part of Baltimore, it was making things unlivable. So when I hear drug homes going everywhere throughout the state, people should evaluate what bringing a little piece of Baltimore to their quiet town is going to be like. The addiction issue has only gotten worse. We talked about, I'm hearing mandated appropriations, sort of word salad on what type of results to expect. Let's get to the money. These are staggering numbers for wellness. When I consider this, that some of this is going to go to paying dental issues for meth addicts, that's a real concern. There's Measure-based care is by nature a fallacy. People giving the data are drug addicts. The accounts by definitions are flawed, incomplete, and substandard. And in closing, I just want to say that when I hear family-centered treatment, bet any amount of money this would be single moms only, excluding standard nuclear family. And there is, as a fact, nothing written into the bill to promote nuclear family, which brings me to my closing thought. You just received data from me, from national parents organizations, about fatherlessness. For that kind of money, you could be addressing this from a root cause. And this is what I want to keep saying, root
Mr.
cause
McAfee,
matters.
you have to please wrap up.
I am done. And thank you so much
Thank
for
you.
your leisure there, Senator Delegate. Appreciate it.
No, I always like let you finish your thought.
Grateful. Thank you.
My pleasure. My pleasure. Are there any questions for this witness? Thank you so much for being with us and providing your testimony.
Thank you.
We appreciate it. Next, we have, actually, there are no other questions for this bill. This concludes the bill hearing on House Bill 935. Next, we have House Bill 1017, Delegate Young, Frederick County Mental Health Law Assisted Outpatient Treatment Pilot Program. Delegate Young, you have 5 minutes.
Thank you, Madam Chair. I also have been cautioning a mental health pandemic for well over a year, but some of the services Maryland has for those with serious mental illness are not meeting the needs of some of our most vulnerable, severely ill individuals. Our options need to reflect our realities. Too often, our well-intentioned preference for voluntary engagement has left that very small percentage of people who will not voluntarily engage literally out in the cold. This modest pilot program is a chance to test an evidence-based practice that is authorized in 47 other states. Assisted outpatient treatment, or AOT, has existed for decades, and there is significant data demonstrating its effectiveness. It has reduced hospitalizations, arrests, incarceration, homelessness, violence, and victimization between 74 and 87% for program participants. AOT is the delivery of outpatient treatment under a civil court order to a small subset of individuals with severe mental illness, such as schizophrenia or bipolar disorder. These individuals have a history of inconsistent or no engagement with outpatient treatment. This is often due to denial of the need for treatment, which may result from the illness itself. Participants must be likely to deteriorate and become a danger to the life or safety of themselves or other, according to a psychiatrist. AOT provides an outpatient treatment option that is the least restrictive way to maintain health and safety. The court and the mental health system work collaboratively to assist individuals with severe mental illness to engage in treatment and ensure that the mental health system is addressing their needs. AOT is a powerful tool to empower those enrolled to continue stabilization after discharge. This is treatment, not punishment. Criminal content is not part of this program. If something isn't working, there is no forced medication or treatment. It's a collaborative effort. In a recent SAMHSA survey, 92% of participants agreed with the statement, "I like the services I received." The Frederick County delegation has sent a letter of support for this program, and we respectfully ask that you allow us to test this program that exists in most of the rest of the country. Thank you, and I'd like to allocate the remainder of my time to Mr. Steffen.
Mr. Stanton, will you be so kind? Mr. Brian Stanton? Or Miss Amanda Woodward?
Hello. Good afternoon to the House and Health Government Operations Committee. Thank you so much.
May I ask you a question, ma'am? It says Brian Stanton or Amanda Woodward, so I suppose you're testifying for both, correct?
Oh, no, I
No.
don't want to do that.
Okay.
I'm here as well. I'm Brian Stetton and I'm here as well.
Yes, that's who I want to testify, please.
Okay, you'd like me to go first?
So why don't we do something? Why don't you allow Mr. Brian Stanton to go first, please, Miss Amanda?
Sure.
Really appreciate your flexibility, okay?
Okay.
Go ahead, sir.
Sure. Thank you so much. My name is Brian Stetton. I'm the policy director for an organization called the Efficacy Center. And I'd like to speak to just a little bit as to what this bill is about and why it's so important, and give you a sense of how AOT actually works in the real world. You know, the opponents to this bill start with the assumption that AOT is a form of coercion or forced treatment, as they call it. They seem to envision that this is about a judge trying to scare a person into submission to adhere to their outpatient treatment through negative reinforcement, that is, fear of some bad consequence that will occur if the person does not adhere. I want to tell you, I spend my career all over the country helping to establish these programs. I would not support this myself if I believe for a minute that is at all what this is about. This relies on a court order, but not because the person is going to be in trouble if they don't follow the court order. We take contempt of court off the table. The purpose of the court order is primarily to give the judge an opportunity to connect with the person and oversee and monitor their treatment and give them a sense that the court cares about them and is going to be involved in their life on an ongoing basis as this person comes to understand how adherence to treatment makes their life better. The experience that other communities have had with this around the country is that people really enjoy being a part of this. There is no evidence that people tend to feel coerced or stigmatized by the participation. And so I ask you, you're going to hear from an AOT participant in a minute, to please keep that in mind when you are given this picture of AOT by the opponents that is not at all based on how this actually works in the real world. I see that my time is kind of low. I just would like to say that all we are asking here for is an opportunity to prove through a small pilot program that this program can be effective. And we hope that will set the stage towards statewide implementation in the future.
Thank you. We appreciate you being with us today. Okay, Miss Amanda Woodward, why don't you take the other time?
Madam Chair, I think
Yes.
there's a mix-up. Amanda was an alternative if Mr. Stetton couldn't make it. Eric Smith is supposed to be next.
Okay, but because I call her out of
Okay.
courtesy from the committee, we usually don't allow it, but I feel badly because I have called her and she's here. Why don't we go through the order of Mr. Smith and then I will call on her, okay?
Okay, thank
Thank you, Mr. Smith.
Yes, thank you. As a point of clarification, is this 2 minutes yielded as part of my time or the 2 minutes that I am available? to
You
testify?
have 2 minutes.
Okay, thank you.
Thank
Good
you.
afternoon. My name is Eric Smith, and an assisted outpatient treatment AOT program saved my life from bipolar and schizoaffective disorders. I support disability rights, civil rights, and other related advocacy groups. That said, some people from these groups speak against AOT, and they are good people operating on incorrect information. For example, some opponents in Maryland believe AOT is forced treatment. I did not receive forced treatment or forced medication in AOT. My rights were never violated, and forced treatment and forced meds can happen in a hospital, but that's true regardless of whether AOT exists or not. Opposition also claims AOT is unconstitutional. 47 out of 50 states currently have AOT laws on the books. If it were unconstitutional, would 47 very blue and red states have it? I do not want to be psychotic. But when I was psychotic, that isn't something I could understand due to anosognosia. When I was psychotic, I told numerous treatment providers in my family to leave me alone and that I didn't want treatment. Thanks to AOT, they understood my voiced opposition to treatment, and anosognosia was not the real me talking. It was me being held hostage by my own mind, not a personal choice. After more than 10 years of failed voluntary care, I lost faith in treatment providers. Since the judge played a very active role in communication during my AOT plan, I was able to place trust back into treatment providers I lost faith in because the judge's authority resonated with me in a way that no psychiatrist or social worker could. Without the judge, I would have continued on my path of not seeking out or trusting treatment providers. And without AOT as step-down care, and with that judge, from my psychiatric hospitalization, I would have stopped taking the meds I need to no longer be a danger to myself. I was diagnosed with SMI, dropped out of high school, incarcerated due to SMI, committed as a psych inpatient. Then AOT entered my life, and thanks to AOT, I graduated magna cum laude with a BA in psychology, then earned a master's degree with a 4.0 GPA. Please support HB 1017 as a recognition that a population of people exists, including me, who need AOT and are failed in the absence of it. Thank you.
Thank you for sharing your experience, Mr. Smith, with the committee. We really appreciate you, okay? We have Ms. Amanda Woodward. We usually don't allow it, but since it came in that way, you can go ahead and give your testimony to the committee, okay?
Okay, thank you and good afternoon. My name is Amanda Woodward and I'm a registered nurse. I've been a nurse for 24 years. And in that time, I've worked in the criminal justice system, the emergency department, and inpatient psychiatry. What the opponent to this bill will tell you is that they speak for all people with mental illness. They do not. They speak for a subset of individuals who are able to choose whether or not they want treatment and who choose treatment, who can choose treatment. They do not speak for the small subset that we are talking about, and that is the seriously mentally ill. They because of anosognosia, do not seek treatment. They are out in the cold. They come through the emergency room repeatedly, having been brought there by police. If they're lucky, if they're unlucky, they go to the prison system where they are abused. They're preyed upon by sociopaths in the prison, and they're at the mercy of officers who don't understand mental illness. And they do not ask for treatment there, so they just disintegrate mentally while they're there. I've watched it personally and I've seen it, and it's heartbreaking. The opponent will tell you that this is a violation of someone's rights. That's ridiculous. What's a problem with people's rights is that they need treatment. They need treatment to be supplied to them when they are not able to choose it for themselves. They're stuck in a cycle of psychosis. Their brain has been hijacked by mental illness, and they are not able to make good decisions for themselves. I am personally affronted when these individuals say that they do not appreciate or care about treatment in hospitals. I've been a nurse for 24 years. I've always been very highly respectful of my patients. I've loved to do psych nursing, and it's a calling. I truly believe that these individuals, specifically the seriously mentally ill, need this program. Thank you.
Thank you for your testimony. Next, we have County Executive Jan Gardner.
Okay, good afternoon, Madam Chair, Madam Vice Chair, and committee members. I am Frederick County Executive Jan Gardner. I want to thank you for the opportunity to speak with you today in support of House Bill 1017. We've been working diligently in Frederick County to build a behavioral health care system that leverages multiple partners with a robust mix of traditional and non-traditional services to provide a client-centered care and services to individuals where they are and when they need it. This bill will establish an assisted outpatient treatment pilot in Frederick County, acknowledging the needs of those with severe persistent mental illness who may lack the awareness and the capacity to direct their own care, which can lead to poor treatment outcomes. Frederick County is well equipped to establish this needed pilot, which will address gaps in care for these individuals. Our Behavioral Health Services Division is working to build a behavioral health care system in Frederick County that is accessible, culturally sensitive, and can respond 24 hours a day, 7 days a week. We have strong collaboration with a variety of agencies that provide outpatient services, school-based support, walk-in services, and mobile crisis services. One of our programs, a Recovery and Wellness Center funded with a grant from the Substance Abuse and Mental Health Services Administration, is the first of its kind in the state and one of 11 in the nation. This pilot will not only serve individuals in the county, but serve as a model that can then be replicated and scaled throughout the state. And while we expect modest expenses to support this work, we anticipate cost savings with improved treatment outcomes, improved prognosis for those people who are served and served better, and earlier intervention, allowing us to prevent individuals from entering into the public system. The required annual report provides important data for this purpose, as well as accountability with regard to the use of resources. I want to thank Delegates Henson and Proctor, and particularly Frederick County Delegate Karen Lewis Young for this important bill, and we respectfully ask for your support and a favorable report. Thank you.
Thank you for being with us today. We appreciate it and appreciate your service. Next, we have Ms. Evelyn Burton.
I'll be right there. I'm having a little technical problem.
Ms.
Okay.
Okay.
Yeah, I'm here. Okay. Good afternoon. I'm Evelyn Burton. I am the Volunteer Advocacy Chair for Schizophrenia and Psychosis Action Alliance, a family organization. And I'm here to plead for the lives of our loved ones with severe mental illness who languish in the hospitals, the jails, and under bridges because they cannot get treatment that will help them, mainly AOT. Unlike 47 other states, 31 of whom have active AOT programs, when voluntary outpatient services are ineffective for some of our loved ones who lack the ability to recognize the need for treatment, the Maryland health system provides nothing. We should call this what it is: blatant discrimination and unequal treatment under the law. No one here today is seeking to deny anyone's civil rights. However, there's much misunderstanding about mental illness. The current system is neither civil or right. When I said to my loved one recently, "How are you doing?" and she replied to me, "You're pink lemonade. What's it like to be pink lemonade?" Is that exercising freedom of speech? Recently, my relative was unable to obtain her medication and she lost insight into her need for treatment. She refused all voluntary treatments, including ACT teams, and suffered terribly. In 1 year, she had 12 hospitalizations and 18 ER visits. Without access to AOT, she spent more time in the hospital than in the community. In New York, before AOT was established, some feared negative consequences due to their lack of understanding, but extensive research showed those fears were misplaced. We should not let misunderstanding and unsubstantiated fears violate the right to appropriate treatment. Martin Luther King said, "Of all forms of inequity, injustice in healthcare is the most shocking and the most inhumane." So please support at least a trial of AOT. Thank you.
Thank you for being with us today and thank you for your advocacy. Next, we have Mr. Ron Honberg.
Thank you very much. Can you see me?
Yes.
Okay, good. Good afternoon, Madam Vice Chair and members of the committee. My name is Ron Honberg, and I formerly served as the National Director for Policy and Legal Affairs for NAMI, the National Alliance on Mental Illness. I'm testifying today on behalf of NAMI Maryland in support of HR 1017, and I would like to offer the following perspectives about this program based on my more than 30 years working on issues at the intersection of law and mental health. First, assisted outpatient treatment, when implemented properly, can be very successful in helping people with severe mental illness whose symptoms prevent them from recognizing their need for treatment and who experience negative consequences as a result. States that have actively implemented AOT have demonstrated success in engaging recipients in services and in reducing hospitalizations, arrests, and other adverse and costly outcomes. Second, although AOT requires upfront investments in community-based services and supports, these investments can lead to cost savings over time. In fact, a study in New York showed savings in overall expenditures for recipients of AOT stemming from reduced hospitalizations and shorter lengths of stay for individuals who are hospitalized. And finally, while AOT is sometimes described as coercive, it is noteworthy that an evaluation of the experiences of AOT recipients in New York revealed that many experienced their services as non-coercive. Those recipients reported feeling more fairly treated than non-AOT recipients who receive comparable services. In this regard, the importance of engaging persons meaningfully in AOT as partners in decisions about their own services is very important. This can be accomplished through the utilization of peer support specialists, shared decision-making, psychiatric advance directives, and other methods to foster active engagement and recovery. And it will also be important to involve families and caregivers whenever possible. Thank you very much for this opportunity to testify.
Thank you so much for being with us today. Actually, I will open it up now for this panel of favorable. Any questions for this panel? First, we have Delegate Rosenberg.
Thank you, Madam Chair.
for someone on the panel. Why do you think there is a discrepancy between your view of the services offered by AOT and the view of the Mental Health Association? Whoever is most appropriate to answer that question.
Well, I can tell you this, sir. Most of the people that are on this panel, the family members, the mothers who care very deeply about their children, and I, as a nurse, know and work with the seriously mentally ill that are affected by this condition called anosognosia, whereas the mental health opponents run organizations that rely on them to be voluntary in their programs, so they don't see that the seriousness of the illness like the parents and perhaps the practitioners do, is my opinion.
All right. As we move forward for the questions, just because I saw Delegate Young, she has her panels and her experts. Why don't you let me go to her and ask her who does she want to answer the question, just to be fair for the process. Thank you so much. Delegate Rosenberg, is there a follow-up?
No, there is not. Thank you.
Thank you so much. Next, I have Delegate Riley, followed by Delegate Shalega. Delegate Riley.
Thank you, Madam Chair.
My pleasure.
Yes, so we kind of heard, some of the panel say that the opposition was basically that they felt that it was forced treatment. I didn't really understand completely how and when the AOT program or whatever, starts with the patient. Can you kind of explain that? So, tell me, why don't you think it's forced treatment and how that works and when the patient goes into this particular program? Whoever is best to answer.
Delegate Riley, I can speak from a first.
One second. Delegate Lewis Young, who would you like to answer that question?
Mr. Steffen, please.
Mr. Stanton, okay. And sorry, Mr. Smith, it's just that we have a lot of bills and the delegate has worked with her panelists, but we do appreciate your information. Okay, Mr. Stanton.
Thank you.
Sir, you are muted. Will you be so kind and unmute yourself and start again? Thank you very much.
And I think there were really two questions there from Delegate Ross. First being about when it is that AOT is typically commenced, how a person gets into the program. And the answer to that in the majority of cases is upon discharge from a hospital stay. A person who has come to the hospital for the umpteenth time, who is clearly trapped in that revolving door, once they are stabilized with hospital treatment to the point where they are now ready to return to the community, are no longer a danger to themselves or others, but we have significant concern that that person is going to soon become dangerous because of their pattern that they've demonstrated of not adhering to their outpatient treatment, usually because they lack insight. That is the opportunity to file a petition to attach to this plan of outpatient care that would have been developed for them anyway, to attach to that a court order and the monitoring and supervision of a court to give that person a soft landing back to the community. And more often than not, I can tell you from experience in other states, people are embracing that and not contesting the petition that's filed. They're stipulating that they meet the criteria and are entering the program willingly, but still under a court order. Now, as to how this is different from forced treatment, which the opponents talk about, forced treatment means the forcible administration of treatment. All the court decisions that are out there about when you can actually go to the point of forced treatment are talking about the unfortunate last resort situation where a person has to be restrained physically and injected with medication that they don't want. And that is something that can only take place in a hospital setting after a finding that the person lacks capacity to make treatment decisions. We don't have a lack of capacity to make treatment decisions as part of the criteria for this law because we want to be able to use it at the point, as I mentioned, the person is doing well when they're coming out of the hospital where they may very well have capacity. But there's nothing in this court order that would authorize the forcible administration of meds. So there's no forced treatment here. There's court-ordered treatment. There's an opportunity to give a person an impression that it's very important that they adhere to treatment. And the consequence of not following that order is not going to be that you'll be strapped down and injected. It's going to be making it a little bit easier to bring that person in for a short-term hold for evaluation to see how their condition may have changed and whether an inpatient commitment is now necessary. That's the only legal effect of the court order.
Okay, thank you, Mr. Steffen. I appreciate it. Great explanation. Thank you, Madam Chair.
My pleasure. Delegate Shalega, followed by Delegate Kerr.
Thank you. I guess this could be for Eric, but I'll leave it up to Delegate Young. What's the input that the patient has into the treatment plan?
You're correct. That's a good one for Eric.
Thank you so much for your question. The input that I had into my plan at all times in which that I was lucid and present and able to provide thoughtful feedback about what was going on with me, which is to say not psychotic, in other words. My feedback mattered. There was time during my AOT order where I was experiencing rapid weight gain, some untoward side effects, and I met with my treatment team. This included the judge, and I said, like they usually do, at the beginning of every hearing, Eric, how are you doing? What is it you'd like to share with us? And I told them, I said, I don't like the way these meds are making me feel. This is the safest I've ever been, and I want to stay like that, but I also am getting unbearable side effects. That did not fall on deaf ears. That allowed me to work with them collaboratively to find something that worked for me, which is what I did. Now, I believe I can also help provide a more complete picture concisely with this as well. So yesterday, I heard a legal expert in Maryland testify before the Senate about how AOT is like the movie Minority Report, because AOT would force people into treatment based on something that hasn't happened yet, something that may or may not happen, right? Respectfully, that's wildly misleading and a mischaracterization of AOT. I was not in AOT to collaborate with that team based on what might happen or what might not happen. I was there to collaborate with them based on what did happen. And what happened was the SMI-based cognitive deficit anosognosia, which is qualitatively different from denial, prevented me from being able to perceive reality. So leaving psychotic people to make personal choices is no different than leaving someone with severe dementia to pose serious danger to themselves or others. They don't know what's going on, and neither did I in any lasting fashion before AOT. So in closing, please do not make AOT a victim of misinformation from the opposition who are making unrealistic claims about AOT is or where I would fit in with my opinions or my thoughts as someone who the order is about. I personally have faith in the wonderful treatment providers and judges throughout Maryland to make AOT work well. And if anyone doesn't have faith in the expertise of Maryland's treatment providers and judges to collaborate with me and with each other to the benefit of those in need with severe mental illness, that is the message sent by opposing it. And I thank you for the question and for the time.
Thank you.
Thank you so much. Next, we have Delegate Kerr, followed by Delegate Bagnall.
Thank you, Madam Chairman. Delegate Lewis Young, some of the opposition testimony that's come in, the written testimony, claims that this is over applied to communities of color. Is there someone on your panel you would like to have address that?
Again, Mr. Steffen is best equipped to address that.
Yes, thank you so much. Am I being heard?
Yes.
Okay, thanks. So for starters, I can tell you, Delegate, that charge has been thoroughly debunked. The evidence that they're presenting there comes from a 2004 report that was made in New York from the New York Lawyers for the Public Interest. What they're doing there is they're comparing rates of AOT participation to the general demographics of New York City and saying that certain communities were overrepresented. And because of this report that came out, this was a question that New York legislature directed to be studied among several other questions when they extended their AOT law with an additional sunset in 2004. They put it out to 2009. And this was among the questions that an independent research team, which turned out to be Duke University Med School, was required to look at whether this allegation was true. And what they found was that that report that had come out had overlooked a major factor, which is that the significant overrepresentation of people of color in the public mental health system. And there are many factors to explain that. It's complex. It's fair to point to a large degree to structural racism as to why that is the case. But that is the reality, right? That's the population from which AOT participants are drawn. And it was found in the study, which I'd be happy to share with you, that once that reality is accounted for, there is no overrepresentation of people of color in the AOT program. All that said, I also think we have to remember here exactly what AOT is. You know, to the opponents who are making a lot of hay over this, AOT is just another pair of handcuffs that we're slapping on people. But to anyone looking reasonably at the evidence, AOT is actually the key to the handcuffs that people already have on, right? The studies tell us it dramatically reduces the main factors that are currently causing people to lose their freedom: hospitalization and arrest. So given what we know about the effectiveness of AOT in keeping people out of jail and out of the hospital, all, as Ron Honberg said, while studies show it does not lead people to feel coerced or stigmatized, we really should view this program as a means of liberation, not a means of coercion. And, from my perspective, why would we be troubled by the possibility that people of color would be overrepresented in such a program? If anything, we should be vigilant to ensure that structural racism does not lead people of color to be underrepresented in AOT, because AOT is the key to keeping people out of jail and out of the hospital.
Thank you, Mr. Steffen. Thank you, Madam Chair.
My pleasure. Delegate Bagnall.
Thank you, Madam Chair, and thank you to the bill sponsor for bringing this for our consideration. I'm looking at the opposition testimony from the Office of Public Defenders, and they actually speak to bodily integrity, constitutionality, concerns about authorized forced treatment. So I was wondering if anyone could speak to how the courts in other states have addressed constitutionality.
Are you muted, Delegate?
Yeah, I had a hard time unmuting, sorry, but that would be Mr. Steffen again.
Sure, thank you. So there has only been one state where the opponents have actually raised a constitutional challenge, a facial constitutional challenge to the very practice of AOT. And the threat has been made in many of the states where we have passed these laws. None have actually brought suit except in New York, where the New York Civil Liberties Union did in fact make this argument that AOT was a form of forced treatment and was therefore unconstitutional because it was being imposed without a finding that the person lacked the capacity to make a treatment decision. And this lawsuit, called the Matter of KL, was thoroughly rejected by the courts in New York. It ultimately went up to the New York Court of Appeals, the highest court in the state, which is a famously liberal court, extremely protective of civil liberties and civil rights. Unanimously, the court found that there was no serious constitutional issue here, simply because, for the reasons we've already stated, AOT is not forced treatment. It does not rely on administering medication involuntarily to people who don't adhere to their court order. And that ultimately it just came down to the encouragement that people get by having a judge kind of engage with them, and the duty people tend to feel to take seriously something a judge has directed them to do. Without that element of forced treatment, the court was completely untroubled by the modest deprivation of liberty that was involved here, and unanimously rejected the argument in an opinion written by the Chief Justice. And that's all we have. That's the only state where this challenge has been presented. And I think the example that was set in New York has had a lot to do with why we really haven't seen these suits brought in other states.
Thank you so much, sir, for your answer. Any other questions for this panel? Seeing none, we are now going to go to the favorable with amendment panel. And the first witness we will call is Deborah Bennett. Ms. Bennett, you have 2 minutes to address the committee. Good afternoon.
Yes, good afternoon. I'm Deborah Bennett from Prince George's County. My 33-year-old son is diagnosed with schizoaffective disorder with psychotic features, in addition to having a severe hearing loss. When on medication, he had an apartment, a car, and worked for 2 years in Frederick, Maryland. He has been homeless since last June. He stopped taking medication. He had a diminished awareness of his need for treatment caused by the illness itself. This resulted in periodic outpatient treatment refusal, 11 involuntary hospitalizations, 11 ER visits since 2020. 8 were last year, so far 1 this year. His last hospitalization cost $47,000, and the total cost to taxpayers so far is over $200,000. It is agonizing to watch him cycle between hospitalization, outpatient treatment failure, psychosis, homelessness, and rehospitalization. I lay awake waiting for the next crisis that requires emergency petition for hospitalization or to search for him again on the streets to bring him clothes or food. I shudder at the thought that he will have a fatal police encounter because he is psychotic, cannot hear, and African American. How will he ever recover when Maryland offers only voluntary outpatient services, all of which, including the ACT teams, have failed to stabilize him? designate more criminal charges, and a referral to a mental health court to stabilize. He needs a civil order with committed providers and time for treatment to provide lasting stabilization. He needs AOT. 47 out of 50 states now have an AOT program. Denying him the only proven effective treatment for those unwilling to participate in voluntary treatment is blatantly discriminatory. I cry in my spirit for the wonderful person I know he could be if he gets AOT before his psychosis damages his brain. An AOT program can liberate my son from the prison of untreated mental illness, help him rebuild his life with dignity. He deserves a chance at a better life. I ask for a favorable report. Thank you.
Thank you for being with us, and thank you for sharing your experience about your son, okay? Hope he feels better, he gets better. We have next favorable with amendment, Christina Rolfos. Good afternoon, ma'am.
Good afternoon. My name is Christina Rolfus. My nephew, who is 20 and lives in Frederick with my 74-year-old mother, is severely ill with mania and psychosis. He is currently in Frederick Health Hospital after saying he wanted to die, handing his grandmother a saw and asking her to cut his head off as he lay down across 2 trash cans. When the police came, he asked them to kill him. The hospital is planning to discharge him soon back to his grandmother's home. He's been hospitalized several times before, and each time he will not see an outpatient psychiatrist or participate in any outpatient services and will not take medication because he doesn't think anything is wrong. He has no insight into his condition, which is a symptom of the illness itself. Because he is unable to accept the treatment he so desperately needs, I am terrified that he will kill himself or harm my mother. I'm unfortunately very familiar with what can happen with untreated severe mental illness. My brother suffered from schizophrenia and in a delusional episode attacked my father, leaving him with a severe traumatic brain injury and unable to work. My brother, just like my nephew, refused treatment because he didn't understand he was ill. The AOT pilot program could help my nephew have a chance at a happy and productive life. We need to stop saying that treatment is a punishment rather than a compassionate life-saving measure. We need to stop insisting that the current system is working when it is so clearly not. And we must stop pretending that we are protecting a person's civil rights when the result of doing so is lifelong suffering and a bleak existence of cycling through hospitals, jail, homelessness, and even death. Please put yourself in my family's shoes for a moment and ask if this is what you would want if this were your child or grandchild, or would you want the life-saving treatment that AOT can provide? Please, I urge a favorable report with amendment. My nephew's life and possibly my mother's depend on it. Thank you.
Thank you for sharing your experience. Again, sorry about what your family's experiencing. Okay, we appreciate it. Next, we have Mr. Charles Richardson. Good afternoon.
Hello.
Yes, sir.
Hi, I'm Charles Richardson. I'm a psychiatrist. I recently retired from Spring Grove Hospital, state-run hospital, after 32 years of working there. Opponents claim that it's just unjust to forcibly medicate competent citizens. There are 2 problems with this argument. The first is that the psychosis itself undermines one's competence to make informed treatment choices, specifically because it prevents one from perceiving the illness. But secondly, there's a denial of the current reality for patients with severe mental illness. My experience at Spring Grove and my concern there was for the thousands of citizens whose untreated illness-driven behaviors have led to arrests, charges, and extended and expensive court-ordered inpatient treatment lasting for far longer and with far greater restrictions in life choices than would be the case under civilly mandated AOT. Nothing about this provision would change current civil commitment statutes or forced medication statutes. Forced medication can only occur in inpatient settings, only on patients who've been civilly committed or court-ordered for treatment, and only if dangerous behavior has been displayed, and only with a legal procedure that provides both clinical representation and a right to appeal. Under criminal court-ordered outpatient treatment, whether under the not criminally responsible statute or under the direction of a mental health court, non-adherence can lead to rehospitalization or incarceration regardless of clinical need. As with mental health courts, which seek to divert criminally convicted patients from jail, AOT seeks to divert patients at proven risk of potentially criminal behavior due to their illness from ever becoming charged and convicted. Current laws allow for the forcible medication of patients under specific circumstances. I would wish for my patients that the forcing occurs before rather than after they become entangled in the criminal justice system. Thank you. I would ask for a favorable review on this bill.
Thank you for your testimony today. We appreciate it. Now we're going to open it up for questions for this panel favorable with amendment. First, we have Delegate Kaiser.
Thank you, Madam Chair. As particularly listening to Ms. Rolfs, and I'm sorry if I'm pronouncing your name incorrectly, and your story about your nephew, I'm sorry to hear about it. Oh, you signed up favorable with amendment. What did you want to change about the bill? I did not hear that part of of what you had to say.
I'm sorry, I thought that there was one with amendment, and maybe Delegate Young, you could speak to that better than I could.
Madam Chair, would you
Yes.
like me to? There is an amendment on this bill, and it was sent out to you all this morning. You may not have seen it. And I think the favorable, I'm just guessing, the favorable amendment panel was aware that there was an amendment, and so therefore they signed up favorable with amendment.
Okay, I just didn't hear why they liked the amended version, but I can talk to you later then. Thank you.
So Delegate Lewis Young, if I may, what is the amendment?
Let me pull it out of the file.
Thank you.
Well, let me tell you where the amendment came from. The amendment, we've been talking to psychiatrists, to psychologists. We've been talking to people in the judiciary system, and we've been talking to healthcare providers. And what the amendment does is address cumulatively the concerns coming from those three groups.
Okay, thank you. So any follow-up, Delegate Kaiser? You okay? Great. We have Delegate Bagnall next.
Thank you, Madam Chair. And I'm actually following on to Delegate Kaiser because I had the same question. I looked in the floor system and there is an amendment that was offered by the Maryland Psychiatric Society. But Delegate Lewis Young, if you could let us know, is that the amendment or was there a separate amendment that was emailed out?
Yes, there was a separate amendment that was emailed out this morning. We just got the amendment from the Psychological Association, I believe either over the weekend or on Monday. The amendment that was sent out to you this morning is like a 3-page amendment. It amends the preamble to further elaborate on the purpose of the bill. The amendment talks about the Office of the Public Defender and what their role is. It also discusses criminal procedure, and it goes into an indigent individual in all stages of a proceeding in this subsection. What happens in district court, because there's a lot of confusion there about what happens if someone's in violation. You know, are they sentenced? Are they in contempt of court? And no, the answer is no. What happens is that the order is delayed for a year while we try to bring the individual back into the system, and the amendment clarifies that.
Thank you. Thank you, Madam Chair.
My pleasure. Any other questions for this panel? Seeing none, now we're going to go to the unfavorable panel. And we have our first witness will be Ms. Adrienne Bridenstine from the Behavioral Health System of Baltimore. Good afternoon, ma'am.
Thank you, Madam Chair, and thank you, members of the committee. Adrienne Bridenstine with Behavioral Health System Baltimore. For those who don't know us, we are a nonprofit that serves as the local behavioral health authority in Baltimore City. We don't normally weigh in on local bills like this, but this AOT bill is in stark opposition to an outpatient civil commitment pilot program we have been implementing for years in Baltimore City and have gradually been expanding. So we strongly oppose this piece of legislation. We also have concerns, but I want to tell you about the OCC program because it's working, and it flips AOT in its head in that the program we have in Maryland, that Maryland is leading to implement, takes the system and actually commits the system to the person who has not been well served by the public behavioral health system. One of the lessons learned that we have now know from implementing this program for several years is that peers, people with lived experience, are central to the program, and that they are very effective in engaging people in treatment and making sure that they stay connected to that treatment. Our role as the local behavioral health authority is to ensure that the hospital system and the services actually get to that person. So again, that point of committing the system and the services to the person rather than holding the person accountable to adhering to a treatment plan. The other benefit of this program is that rather than having the person check in with a judge or a court system regularly, they are checking in again with that peer. What we have seen in the implementation of this, again, very small pilot program is that it's very effective. 80% of the people who have been served complete the program, which is a 6-month stay, and then they stay connected to the services after they complete the program. As I've mentioned, we've been gradually expanding this program over time. We are recently going to plan to expand the eligibility yet again to broaden the geographic coverage of the area. We are waiting for the Department of Health to approve regulations, and that is part of the holdup that we're experiencing right now. But again, we urge an unfavorable report of this unfavorable report and would encourage you to look at our program that we've been implementing for years and consider expanding that. Thank you, and I'm happy to entertain any questions.
Thank you. Next, we appreciate your testimony, Ms. Ann Geddes.
Thank you, Madam Chair and committee members. My name is Ann Geddes. I'm with the Maryland Coalition of Families. MCF provides family peer support to families who care for a child or other loved one with behavioral health needs. All of MCF's family peer support staff have lived experience caring for a child or other loved one with mental health or substance use needs, and many family members oppose forced treatment. What they want is for their loved one to have easy access to a broad array of quality, appealing, and readily available mental health treatments and community supports. I also oppose forced treatment because, based on my family's personal experience, we found that it did not work. I will not now share the story of our son, since I will be going into more detail on that in my testimony on House Bill 1160. But I do want to say here that our family found that forced treatment not only did not help facilitate recovery, it impeded progress. And our experience was not unique. There are many database studies that have focused on outpatient commitment programs and found little, if any, benefit. Assisted outpatient treatment is just a nice name for forced treatment. House Bill 1017 acknowledges this and anticipates that the person will not want to cooperate, ultimately requiring that should the individual fail to cooperate, they be taken into custody and transported to a facility for examination by a psychiatrist. And since you can't force a person to engage in therapy, essentially the main impact of the bill is to compel a person to take medication. This is especially troubling since people have very good reasons for refusing to take medication. Extremely unpleasant side effects are common in many psychotropic medicines and can cause lifelong debilitating side effects. Even if a person has executed a mental health advance directive, which typically stipulate which medications the person does not want to take, those wishes do not need to be honored if a psychiatrist considers them contrary to their best interest. Why would people complete advance directives, something that we encourage, if a psychiatrist is able to just overrule the choices they've made? There are a number of good reasons to oppose House Bill 1017. Therefore, we ask that you give the bill an unfavorable report. Thank you.
Thank you for your testimony and for sharing your experience, and we're very sorry what you're experiencing. Next, we have Ms. Carol McCabe.
Yes, my name is Carol McCabe. I'm the chief of the mental health division.
I apologize, that was completely off. McCabe.
Sorry.
Go ahead.
In the public defender's office. My division represents individuals in involuntary inpatient commitment cases. Our written testimony was provided to the ACLU. The ACLU agreed to sign on, and they support our opposition to this bill. The right to bodily integrity and the right to refuse medical treatment is among the most fundamental of our constitutional rights. The Supreme Court, in several cases, as a Maryland Court of Appeals as recently as about 4 months ago in Mercer versus Finance Center, hold that an individual has a constitutionally protected liberty interest in being free from forced psychiatric treatment. The coerced or forced outpatient psychiatric treatment proposed in this bill is a significant deprivation of liberty. And the treatment in this bill is forced, as you just heard. This bill gives a judge the authority to issue a warrant to have an individual arrested and transported to an appropriate facility for a psychiatric evaluation where the person can be detained for 24 hours, all without probable cause that the person has committed a criminal offense or is dangerous derivative of a mental illness. The forced treatment proposed by this bill implicates due process protections, and several of this bill's provisions violate the constitutional rights of individuals being coerced into treatment. The provisions of this bill also invite malicious abuse of the forced outpatient commitment process. The vague and speculative standards and lack of constitutional protections in this bill make it easier for the kind of malicious abuse my office sees in inpatient cases. It's not uncommon for malicious actors involved in divorce and custody battles, spousal abuse, or involving money to abuse this process. This bill may also have serious unintended collateral consequences like those suffered by individuals who have been involuntarily committed to
You have to start wrapping up, please.
No, that was it. Thank you.
Thank you, thank you. Next, we have Keith Lottridge.
Good afternoon, Madam Chair, Vice Chair, members. I'm Keith Lottridge. I'm the Deputy Public Defender for the state of Maryland. You've just heard from our Chief of our Mental Health Division, Carol McCabe, and she outlined some of the constitutional problems. I'm more going to focus on the amendment that was added to this bill, whereby the Office of the Public Defender will be required to represent the people who are put into this program. And what I will tell you is this: we don't have the staff. The Mental Health Division has 8 attorneys who last year handled 9,600 or were involved in 9,600 civil commitments. That doesn't even account for the fact that there are 33 hospitals where they have to go in for hearings. This bill did not give us funding. It didn't give us attorneys. It's not a matter of will or won't, because it's not a decision on our part whether to do this. It's a matter of can or can't. My office has been historically underfunded and we don't have enough people. This bill provides us no staff to do this. And I want to address a couple other things. One, we don't have the people. And two, I've heard that this will save money. I don't think anybody who's been in my position, anybody who's been an attorney, a litigator, can legitimately come up here and say that involving the court in any process saves money. Let me tell you, we are a stated interest law firm. If we get one of these people as a client, we are going to do what they ask us to do because they are not incompetent. If they were incompetent, that'd be something else. That's not what this bill says. And what they don't want is treatment. So we're going to do everything we can to fight the treatment, which means we're going to turn every case into a constitutional case. Everybody here understands we need to work on mental health treatment. The services aren't good enough for anyone. But involving the court is absolutely the wrong thing to do for people who need help. And I tell you, as the person who might be standing next to these people, we'll just slow it all down. and will make it worse.
Can you wrap up,
Thank you.
please? Thank you. Thank you. Next, we have Ms. Karen Foxman.
Thank you, Madam Chairwoman and members of the committee. My name is Karen Foxman, and I am a managing attorney at Disability Rights Maryland, Maryland's designated protection and advocacy agency, federally mandated to protect and defend the rights of individuals with disabilities. On behalf of DRM, I am asking your committee to issue an unfavorable report on this bill because it would deny individuals with psychiatric disabilities the opportunity to be active participants in their treatment and would violate their constitutional rights to live in the community free from coercive treatment. In 1999, the U.S. Supreme Court held in Olmstead versus LC that individuals with disabilities have a right to live in the most integrated setting in the community appropriate to their needs. The Supreme Court has also held that states have no constitutional basis to limit a person's liberty, interest involuntarily if they are dangerous to no one. This bill will restrict the freedom of individuals with mental illness who are residing in the community by creating an extremely low bar for coercive treatment and the likelihood of involuntary hospitalization if they don't comply. The U.S. Supreme Court has also made it clear that an individual's right to refuse medication is a constitutionally protected liberty interest. This bill would order individuals to take medication without knowing the type or the dosage amount being administered, all without having the opportunity to weigh in. This bill will also require an individual to submit to treatment for a potentially unlimited duration based purely on the subjective standards of being at risk for psychiatric deterioration and will have a disparate impact on people of color due to implicit bias and unknown consequence to their future. A recent study involving individuals with schizophrenia and mandatory community programs published in European Psychiatry concluded that patients who are more engaged and included in their treatment decisions exhibit improved treatment outcomes. While one 2020 study showed a very modest reduction in hospitalizations during a 6-month period while individuals received AOT, this reduction was counteracted by negative experiences with coercive care, leading individuals to avoid future interaction with mental health treatment and services. This bill would permit a psychiatrist to invalidate an individual's mental health advance directive if they thought their wishes were not in their best interest. This flies in the face of the purpose of an advance directive and is a violation of the individual's rights to bodily integrity. Thank you.
Thank you for your testimony. We really appreciate it. We're going to open it up now for questions on this unfavorable panel. First, we're going to go to Delegate Robin Lewis, followed by Delegate Card.
Thank you, Madam Chair. Thank you to the bill sponsor and to all the panelists. I am very interested to understand the opposition to collaborative outpatient mental health treatment, which is what I believe the bill proposes. And truly, with respect to the attorneys and constitutional experts who've spoken in opposition, I am not an attorney. I'm a public health researcher. And so with respect to your expertise, how is it a violation of the constitutional, the bodily integrity interest to participate in an outpatient collaborative healthcare process? And and just to hone in a bit more precisely, we heard from Mr. Smith, who is, I believe, the only person in this room who has experienced care through this outpatient model and who declared that without such services, he might not be alive today. So how is it coercive? How is it better to leave someone truly suffering, like the gentle lady's nephew who wanted to have his head cut off and is living with the grandmother? How is it okay to leave that person suffering and deny them access to outpatient care? And I would ask the sponsor, please, to identify the best person to answer. Or the best person.
Delegate Lewis Young, you have to unmute yourself.
This is the opposition panel. It's not the sponsor.
Yeah, you just basically, Delegate Lewis, Who would you like to ask
Oh, I
that
get to
question
pick.
of?
Thank you
Yes,
so
because
much.
it's the opposition
Because
panel.
I never ask questions of the opposition panel, so this is a first for me. Thank you, ma'am. I would say probably an attorney and perhaps
The
Ms.
Public Defender
Foxman?
Service?
Yes. Is that Ms. Foxman?
So if someone from the Maryland Public Defender Service, Mr. Luttridge or Ms. McKay.
I'm here unless,
Yes.
Carol, are you? All right. So I don't want to push back on your question, but I want to make sure I'm articulating my answer in a way that answers it. How is it right? Your question was essentially, how is it right to let someone suffer as opposed to getting them treatment? That's not the question before us. And that's why I'm a lawyer, because that's not the question before us. The question before me is this. I have a client who, by definition of law, is not incompetent, which means as a stated interest lawyer, he gets to make the choice about his life. I'm going to respect that individual's choice, and I'm going to fight for that individual's choice, and I'm going to fight for that individual's constitutional rights. Yes, I said during my statement, we need treatment for people. We need options. But you can't start picking and choosing that once someone has a label of mental health, that they no longer have the constitutional protections that everyone else has. They may not be making the best decision. I can't decide that for them. Until they're not competent in the state of Maryland, they make that decision. And it is coercive. Collaborative is great. Everybody agrees. A collaborative approach, peer-to-peer, those things are the most effective way to get. But it's not collaborative if the person doesn't want it, right? And as long as they don't want it, and if we're their attorney, we're going to fight against it. So it's not collaborative because it's forced. And I think if I'll be honest, we were brought in, the public defender's office was brought in a little late. So I didn't come in with all the research, but I'm pretty sure I know for a fact that forced treatment is much less effective than voluntary treatment. So I think that answers your question. I don't mean to undermine the concept that people should get treatment, and we don't want anybody suffering. But if you're competent, you have rights. And we need to make sure that everybody has those rights, regardless of what labels put on them.
Thank you. Thank you, Madam Chair.
My pleasure. Delegate Carr, followed by Delegate Lewis Young, followed by Delegate Bagnall.
Thank you, Madam Chair. Thank you for bringing this bill. My question is for Ms. Bridenstine. The question is, how many people have actually gone through the outpatient civil commitment, and how many have been offered?
Yes, thank you, Delegate. Can you all hear me? Great, thank you.
Yes, we can.
Thank you. So we have an annual contract to serve 15 people annually. I know that sounds like a small number, and I just want to remind people this is a pilot program, so it's intentionally small. For outpatient civil commitment in Baltimore City, the pilot program we've implemented, there are two options. You can go into the program voluntarily or involuntarily. Does that answer your question, Delegate?
He said yes.
Okay, thanks.
Okay, thank you. Next, we're going to follow with Delegate Lewis Young, followed by Delegate Bagnall, then Kaiser, then Hill.
Thank you, Madam Chair. I actually had a similar question. I would like to know the actual number of people since the program's inception that have gone through it. And if you still have SAMHSA funding for the program.
Thank you, Delegate. We do not have SAMHSA funding for the program. The program has been funded by the State Behavioral Health Administration since 2018. The total number of people who have been through the program, I don't have in front of me, but I'm happy to follow up with you to get that.
Thank you. I do have those numbers. 7.
7 total is not correct, Delegate.
Okay,
I think you may have old numbers. The department has not put out a report on the program for a number of years, so I'm happy to give you those updated numbers. We've served 7 people just this year, so that's not correct.
Thank you. If you could take it offline, please, and give the correct information, not only to the delegate, but to the committee as well. Thank you so much. Next, we have Delegate Bagnall by Delegate Kaiser.
Thank you, Madam Chair. And thank you to all the panelists. This is a very, very hard issue. I think my question is for Ms. Bridenstine again, and it's twofold, because I'm hearing that this isn't forced treatment because it doesn't involve medication, but do we define all treatment as medication only? And do we have in somatic care a scenario where we would supersede an advance directive, or would this bill in essence create a separate standard for behavioral health care and somatic care as it regards the advance directive?
Yes, Delegate, and that's part of our concern with the legislation. I'm sorry, you probably hear my son in the background. And that's part of our concern with the legislation. This pilot program, and its stark difference from the outpatient civil commitment pilot program. With the OCC program we implement in Baltimore City, we would honor that person's advance directive. We don't have anything that precludes us or prohibits us from doing that. So that's the approach that we take. And the peers work closely with people when they're in the hospital, even before they're discharged from the hospital, to develop their collaborative treatment plan, which may or may not involve taking medication adherence, but it also focuses on helping people address those social determinants of health, whether that be housing or getting employment, and other issues like that. And I apologize for my son.
Thank you so much.
We have next Delegate Kaiser, followed by Delegate Hill.
Thank you, Madam Chair. My question is for Mr. Lotridge or Dr. Lotridge. What I hear you saying against this bill feels like the rationale, and certainly I agree, for what we did over the top 50 or so years ago with forced institutionalization. But ultimately, I'm left with a question for you. So what? What can we do? People have some pretty severe needs and they don't recognize their need.
That's a great question. I'm a lawyer. I'm not going to pretend to be anything else. I think you have some very intelligent people out in the world. There are programs all across the country. I do think what little I do know, and I do know a little bit, peer-to-peer groups are amazing. They have some of the most benefits. And the more services we provide that are accessible not just as anybody can walk in, but they can get transportation, and that people feel comfortable with, that you can come in and out of as needed. Those things, if we fund them, if we get more people out of the jails and into treatment, all of those things will make it better. But I don't have an answer for you, Doug. I honestly don't. I do know that much like with, the school to prison pipeline, we have a history in this country of putting things into court and assuming that basically authority or structure will make it better. It doesn't. It complicates it. So that's why, A, we don't have the resources to do this, and B, it's just not a great idea.
All right. Not a follow-up, I guess, for you, sir, but to the others, since we can't ask others questions, that if others can follow up later on with an answer to that question of what can be done. But I'm afraid I'm allowed, I need to go find my power cord before I get kicked off. But thank you, Madam Chair.
My pleasure. Next, we have Delegate Hill, followed by Delegate Johnson.
Thank you, Madam Chair, and thank you all. So obviously, this is really challenging. And this question, I guess, is for either Ms. Geddes or Ms. Bridenstine. So, one of the things we always say about mental illness is that, the physician or the provider makes a diagnosis, and when the patient says, I don't have that diagnosis, the provider says that's because you're in denial, right? So we have very real problem. And you all are presenting it as if the pilot that's out there in Baltimore City and the other things that we're doing, which are designed to entice or support folks to get the help that they need, are adequate. And they're not. They help a small cohort of folks. They're not helping enough people. And all of us hear from family members who have loved ones who, because of their constitutional rights, are cycling in and out of unsafe situations and in and out of criminal justice. And they're just waiting for that one phone call when they hear about what tragedy befell their loved one. So my problem and my question is, you didn't offer any amendments to make this work. You didn't offer an off-ramp for the person who says that they're in, or what instead of the court should have the authority, because that's problematic exactly for the reasons Mr. Loftridge said. The court having ultimate authority on a behavioral health issue is problematic, and the patient not having the ability to walk out after making a decision to participate is problematic. So what is your solution? Because what we're doing and what you've been involved with is not adequate. That's the question. I guess it'll be from Ms. Either one.
All right, who would like to answer the question? Just one person, please. And I'm sorry, we have rules because there's a lot of people, right? And a lot of bills. It's not personal, not to the members and not to you. So just in the interest of time, will you be so kind and one person answer the question?
Ms. Geddes, maybe you.
So we haven't had assisted outpatient treatment in Maryland. I know, and I believe that the data is in Mr. Martin's testimony, his written testimony, but there was a very successful assisted outpatient treatment program in New York. And they invested hundreds of millions of dollars in services for people who are suffering with serious mental illness. So if the state wants to invest hundreds of millions of dollars, I mean, we'd all be before that, but that's not going to happen. What we need are more comprehensive, easily accessible, quality services for people. And peers are great at engaging other folks into treatment. There are things out there that we know about that we know have worked. What this bill does is not one of them.
And Ms. Bridenstine, the follow-up question then for you is, we're talking about a pilot, and it's a pilot. And what would you be willing to work with the sponsor to tweak the pilot to address your major concerns?
Thank you, Delegate. So our major concerns is that this pilot would be so different from the existing pilot that we already have in the state, which is the pilot that was developed and has been implemented with broad stakeholder input. So that's why we're suggesting take the pilot and the model that we already have in our state of Maryland and work with us to expand it. So if that's something that Frederick County would be interested in partnering with us on, then I think that's what we're saying. But the approach that's in this piece of legislation is so starkly different from what the state has already been implementing and what the state is looking to expand to other jurisdictions. So that's our, if I heard your question correctly, that's what our concern is with the legislation.
Thank you.
Okay, thank you. Delegate Johnson.
Thank you, Madam Chair. And I guess my question is for Mr. Loftridge. Mr. Loftridge, you talked about competence, and I'd like to know, to help us understand what it is we can do to help these folks. Where is that fine line of competence when you have someone that has a mental illness that is so severe that their sense of reality is distorted, that they do not know they have a mental illness or are in denial, or their sense of reality is so distorted that they don't realize it? I mean, where is that line of competency?
That's actually an interesting ethical question, which I don't think we have enough time tonight, because I know everybody would probably like to end at some point, but I'll address it this way. In the bill in front of you, the line to get court involvement is that a person has a mental illness, and that there is the potentiality, not that in the future at some point, not a definite period, but in the future at some point, they might be a danger to themselves or others. It's that potentiality, right? If they were a danger to themselves or others, there are mechanisms that would kick in. So right now, for this particular bill, in this particular discussion, it's that unknown, someone else guessing when someone's going to be a danger to themselves or others. The other part of your question is people who are in denial or people who don't want treatment. I don't think anybody on this call will like my answer to that. Is sometimes people get to make the wrong choice if they're competent. That's sadly, not sadly, that is our right, which I will defend. But it's when they are a danger to themselves or others, that's when competence comes in, and that's when the law can basically take a hand. Does that make sense?
Thank you. Yeah, thank you. Thank you, Madam Chair.
My pleasure. Seeing no other questions on House Bill 1017, this concludes the bill hearing on House Bill 1017. Now we are actually going to go to House Bill 1020, Delegate Young and Proctor, Developmental Disability Administration, Self-Directed Services, Self-Direction Act of 2022. Delegate Young, you have 5 minutes.
Thank you, Madam Chair. Well, I've got another one for you all for the most vulnerable among us. And this one's going to sound a bit more familiar to you because this is the third time with this bill. Let me backtrack, tell you a little bit of history. In 2005, the Maryland General Assembly passed the New Direction Waiver. This innovative model allowed individuals with developmental disabilities to direct their health care, including their budget, employees, and treatment plan. In 2013, the program's name was changed after merging with the Community Pathways Waiver. Since 2016, DDA has walked back most of the major components of this program, forcing participants to seek supports from other state programs not intended for the developmentally disabled. Many participants and their caregivers began reporting tighter restrictions on services, decreasing support options, and limited controls over their health care decisions. For example, DDA policies, which have minimized the role of the support broker, reduced access to the only team professional who specializes in self-direction. This has resulted in long service delays for transitional youth and made it difficult for disadvantaged communities or those who lack a strong family support network to get their support. So last year you heard the bill, and there was a huge fiscal note claiming that the federal government wouldn't pay for this program. So a work group was formed. Thank you to our chairwoman, as well as to the speaker. And we had 22 participants, including several members of this committee, a large group of participants in the program, and we worked for 7 months on this issue. We met 7 times. We had 2 subcommittees so that we could get more participant participation. And we proved 4 times over that not only was this program in accordance with CMS policy, but the state of Maryland was leaving money on the table by not implementing the program in its full design. So we've developed 8 recommendations, which should be in one of your attachments, but briefly they include overnight supports, enhancing support broker responsibilities, better training of coordinator of community services, transportation flexibility, utilizing the budget of individual family goods and services, prohibiting the use of competency testing, and greater budget transparency, and finally, payroll parity. After numerous attempts to gain input from MDH from our work group, finally Vice Chair Pina Milnick and I met with Secretary Schrader and Heather Scheck on the 28th of December last year. On a positive note, program participants have finally received financial parity with their peers in provider managed services, and Secretary Schrader did agree to enhance support broker responsibilities and communicating them. He also supported overnight supports, but we reminded him that that was only happening on a very limited basis. Self-direction saves the state from increasing case demand through standard provider services, and it lowers the rate of institutionalization, which can cost tens of millions of dollars over a lifetime. Nothing in this bill is intended to increase funds earmarked for this population. It merely gives them access to the total amount of funds allocated for their support. The amendments I offered today will reinforce that and hopefully make this bill cost neutral. I did this bill in order to ensure accountability. Thank you so much for your time and attention, and thank you to the committee members that served with me in this work group.
Thank you, Delegate, for your work and your commitment. I know you spend a lot of time in the interim on this, so the committee thanks you. Now we have Ms. Catherine Cooper. Ma'am, you have 2 minutes.
Okay. Good evening, Madam Chair and Madam Vice Chair. And what a long day you've had. We've been trying to keep Melanie intact and near the computer. We are coming to you. This is my daughter, Melanie, who's 36. This is my husband, Jim. Jim, get in there. Jim and I are in there. Jim and I are 67 years old. We're coming to you from Bel Air in Harford County. For the past 17 years, Melanie has been in self-direction. So first and foremost, we want to say thanks to DEA for the amazing opportunity to be in this waiver. We say thanks for their forethought in 2005. That was the year she jumped in, 2005, 2006, and for the hard work they've done in implementing. We're here today not to go into the details of Melanie's many disabilities, but in short, for 23 years of her 36 years, she has had seizures, and many of them every day for the last 23 years. But in self-direction, Melanie's been able to live a good life. We want to just mention 3 points about the bill that we surely hope passes. First, hiring family as staff is so critical to her plan. Aside from the 8 staff people we have hired in addition, we really want to access more of Melanie's budget that's actually been already assigned to her. We don't need more money. We just want flexibility and access to the present money. And finally, we want to say that we're so grateful that on Friday, overnight supports were reinstated to the program, but we would really like that overnight supports used as personal supports to be codified. In 2018, they were taken away. So because of the on again, off again of this provision, it's hard to make a plan that fits if maybe the next person that comes in decides maybe they don't want to do overnight supports. So she waited 8 years to get housing assistance. We got that. She's got her own little apartment for the last 8 years. She needs 24/7, but we've been able to pull together a good life in new directions for her in self-direction. We're really hopeful that whatever happens today, it's going to be a good thing. Either way, we'll be back advocating for Melanie and all the other folks with disabilities in Maryland. So thank you.
All right, Dad. Thank you for sharing your experience with us today. I know it's been a long day. But you also waited, and there's so many other witnesses waiting as well for us to listen. And the committee is very respectful, so we're all here listening. And Melanie, thank you for being with us, okay? Next, we have Ms. Marla Hollander.
Thank you, Madam Chair and honorable committee members. Here today to register favorable support for HB 1020 and to share my story. My name's Marla Hollander. I live in Kensington, Maryland, District 18, and I'm here speaking on behalf of my 17-year-old son, Ben. He has autism, seizure disorder, and intellectual disability. Like many teens, he would like to be independent. He loves being with others. He has a thing for technology and listening to music. Despite Ben's disability, he has changed the lives and careers of many. He is a person who needs 24/7 support to be safe, healthy, and productive. And at age 17, Ben will be a long-term DDA client. Ben became eligible for waiver services in September of 2019. We spent the next year and a half searching for support from traditional DDA service providers with no luck. The providers didn't have staff or interest in supporting Ben. In January 2021, someone suggested we explore self-direction, and we inquired with our CCS. While they were helpful, they had little training on how to implement this model. Getting our plan developed and approved took over a year and only included budget authorization for 1 month. This has been a grueling and frustrating process. And I'm a middle-class white woman with a graduate degree and time to navigate this opaque system. Imagine the experience of many DDA clients and families that don't have my resources or time. HB 1020 would bring back important resources like adequate support brokerage and training for CCS staff. As of January 1st, I'm happy to share that Ben is a self-directed participant. In 2 short months, he's hired 2 staff and he's receiving amazing support that's driven by his unique needs. This is not brain surgery. Please help DDA get back to the basics to provide simple, streamlined, transparent procedures and training that ensures all stakeholders have the information they need to provide clients control of their Medicaid waiver services and make choices that are in the best interests of both the client and state. Thank you for your time and consideration. I ask for favorable support for HB 1020.
Thank you, Ms. Hollander, for sharing your experience. We really appreciate it. Next, we have Sunny Sefarati.
Sefarati, thank you. Can you hear me?
Yes.
Mocha, go. Sorry, the dog is being a little bit of a distraction. Can you all see me?
We can see you and we can hear you.
Okay, I am totally blind, so I don't know if anybody can see me. Anyway.
We can see you, Ms. Sefarati. We can see you and we can hear you clearly. Welcome to our committee.
Thank you. I testified last year as well. So my name is Sunny Sefarati, and I am a self-directed services participant. When I graduated from Maryland School for the Blind in 2007, I was placed in a shelter workshop where I remained for 8 years. The sheltered workshop had more negative experiences than positive experiences, and I felt as if I was restrained, and self-direction was never even an option for me. It was not until I met my support broker in 2015, and she helped me get out of a shelter workshop in 2015. Now, I entered self-direction in 2016, and I am currently self-directing my services now. Because I am no longer in a shelter workshop, I serve on 3 advocacy boards: the Musical Autist, the Maryland Developmental Disabilities Council, and the Self-Directed Advocacy Network of Maryland. I ask that this committee please consider passing HB 1020 so that people like me can continue to self-direct and thrive in their community. Thank you.
We appreciate your testimony and thank you for being with us today. Next, we have Ms. Vidale de Palacios. Good afternoon.
Good evening. Good afternoon, everyone.
Yes, it
Madam
is evening.
Chair and
Go
all
ahead.
the, yes, and honorable chairs. Thank you for your time. My name is Alaris Vidal de Palacios, and I'd like to speak favorably for House Bill 1020. As a support broker and the mother of a current self-directed participant, I'd like to focus on the area of this bill which speaks to the accessibility of advocacy and support services rendered by support brokers. Families prior to 2018 were able to interview, hire, negotiate service hours, and pay the broker who they felt most comfortable with and who they believe would be the best advocate for the participants' needs. In 2018, the support broker service hours were capped by DDA, transforming it from being a service designed by the participant for their needs to that of 1 hour per week. No consideration was given to the participant in their person-centered plan. If the plan and budget is that of the participant, then why is it that DDA has chosen to cut this service, which is the most beneficial for the family? Support brokers provide knowledge of the self-directed program to the families. They also provide human resource supports. Support brokers provide financial oversight and case management support to the team. In other words, support broker is working as the unbiased personal advocate for the participant and their stakeholder. Please pass HB 1020, as it would allow for equal accessibility to all self-directed services and a recalibration of those services which DDA has placed caps on. Thank you so much.
Thank you for being with us today. Next, we have Ms. Serena Lowe.
Good evening. My name is Serena Lowe, and I would like to offer my strong support in favor of the Self-Direction Act. From 2015 to 2019, I served as a senior policy advisor to the U.S. Department of Health and Human Services Administration for Community Living. In this capacity, I was a primary liaison to the Centers for Medicare and Medicaid Services Home and Community-Based Services Implementation Team, where I provided technical assistance to all 50 state Medicaid agencies in the implementation of the federal Home and Community-Based Services Regulation and subsequent guidance published on the provision and implementation of self-direction programs. In 2021, I served as a technical assistant to the Self-Direction Advocacy Network of Maryland and served on the Maryland General Assembly's work group to review and recommend policies for the self-direction program. In our deliberations, we determined that the introduction of various policy changes in recent years to the self-direction program had the effect of creating unnecessary administrative burdens on individuals and families, as also restrictions on the use of self-direction resources that actually inhibited an individual's ability to get the level of supports required to live in one's own home or with their family. For example, changes to the program for a time prohibited individuals self-directing from hiring overnight supports unless they went through a provider agency, and also limited their ability to hire family members. People have lost access to the technical support that they had previously relied on from support brokers, given DDA's reduction of allotted hours from 40 to 4 a month. Passage of the Self-Direction Act would help streamline administrative burdens, assure parity between services that are provider managed and those that are self-directed, and assure balance between optimal participant flexibility and fiscal integrity. Nothing in the legislation would compromise the state's existing federal funding match for Medicaid services. Nothing in this bill would increase the cost of individual budgets or increase the cost above what the funds already earmarked for each participant. In fact, the provisions of this bill are consistent with federal policy and assure strong alignment of the state's HCBS self-direction option with federal HCBS requirements. Thank you so much. I'm happy to answer any questions at the end too related to the fiscal assumptions or social or economic impact of this critically important legislation.
Thank you for your testimony and sharing your experience. We're now going to open it up for the committee for questions. And I see first Delegate N. Kaiser.
Thank you, Madam Chair. Two quick questions, and maybe it's to the last person who spoke about, will this act cost more money? And then on the related issue, would it jeopardize any federal funds?
So I'll take the last part of your question first, in that no, based on my over 20 years experience working on Medicaid, HCBS, and working for the federal government across all 50 states and their waiver programs, there's nothing in this legislation that would jeopardize the state's federal medical assistance percentage or the federal funding that you receive in match for services. As far as whether or not this would cost additional money, I have read the fiscal note and the fiscal rebuttal. I believe that the fiscal note has assumptions in it that are factually inaccurate. Things like assuming that 50% of all of the participants would take advantage of therapy services, when that simply isn't even close to what occurs today. Also that over 50% of people would exhaust a 40-hour-a-month limit on support brokers, when actually it's the more accurate estimate based on previous data and utility of the program is that it's probably 5% of 2,000, so less than 3 million a year. The reality is that the way the budgets work, you're only getting a budget allocated based on the services that are needed. And so we're not asking for an increase in the budgets. We're asking for greater flexibility in the available allotted resources that the state budget system already allocates to this program. And that's a very important distinction for the members of this committee to understand.
Thank you.
Delegate Bagnall.
Thank you, Madam Chair, and thank you to the bill's sponsor. We talk a lot in this committee about our workforce issues and direct care workforce in our state. How would the Self-Direction Act help address our workforce shortages, the challenges that we're facing?
Delegate Lewis Young.
Serena, do you want to respond to that one?
I'd be happy to. What we saw over the last 2 years in COVID, I think, is a great endorsement and testament to the power of self-direction. I think every state, including the state of Maryland, realized that family caregivers are the backbone of direct supports and services in the community, and that when you have a workforce shortage, those family caregivers are the ones holding the bag. There are actually some states who did not kind of relax the rules around allowing family caregivers to be the primary caregiver through self-direction. And what they saw is more people going into institutions and nursing homes during the greatest global pandemic that we've ever experienced in modern day history. So I would just say that I think it is a great way. These are people who live, know, understand the people that they're working with. And certainly there should always be a firewall to protect conflicts of interest and to assure that family members aren't taking advantage of the system. But the Self-Direction Act actually has those provisions in here, and I think does a really good job of assuring really strong accountability, as Delegate Young mentioned in her opening comments.
Thank you. Thank you, Madam.
My pleasure. Any other questions for this panel? Okay, seeing none, this actually concludes the bill hearing on House Bill 1020. So for the committee members, it is now 6:30. I know we have not had a break yet. I'm going to take a risk and take a break. Okay, so if we can come back at 6:50, okay, we done 7 bills, but we have 7 more bills to go. Okay, so that is why I was trying to keep the questions short. Okay. Some of these bills will go to subcommittee as well. So you can ask a question, maybe a follow-up, but let's keep it short. We have 7 more to go. Let's meet at 6:50, okay? Thank you so much. And for the witnesses, I apologize, but we do need a break because we've been working since early this morning. Hope you can stretch your legs or have some water, okay? All right, 6:50, welcome back, everyone. We are down to the last 7 hearings of the day, and we're going to get going. Just to refresh the rules, we will have 5 witnesses favorable, 5 unfavorable, and 5 favorable with amendment. For the committee members, with a lot of respect, if you could please adhere to 1 question, maybe a follow-up, okay? I know we have all done it because we want the answers, but let's try to move this along. And a lot of these bills, again, will go to subcommittee, okay? So we're going to now call our wonderful colleague, Delegate Kipke and Henson, House Bill 1160, Mental Health Law, Reform of Laws and Delivery of Service. Welcome, Delegate Kipke.
Thank you, Madam Chairman and colleagues.
My pleasure.
I'm very happy to put this bill forward with Delegate Henson. This bill is very similar to a bill that you saw last year. There's a minor tweak in it that came from some suggestions from committee members. The bill came in to us because the 2020 annual report from the Commission to Study Mental and Behavioral Health in Maryland declared it is crucial for the state of Maryland to develop a clear and unambiguous standard for determining when individuals in crisis pose a danger to themselves and others. I think we're all very familiar that in Maryland law currently, the law is limited in a way that says a clear, an imminent threat to their life and health of an individual or others. This bill seeks to do what most other states have done, and I'll go into the details of that now. So on page 2 of the bill, in the bold text, you'll see that this bill would add to the code language that I think is vitally important that we add for clarity and to sort of modernize what we know about the human brain. We know that people who are experiencing psychosis, the longer they endure that, the more damage is done to their brain, and it makes it harder for people to get treatment and recover. So this bill would keep the danger to life or safety of the individual or others, but it adds clarity as to what that means exactly. But most importantly, it adds language that says, be unable except for reasons of indigence to provide for the individual's basic needs, including food, clothing, shelter. And we added this language, which is different from last year, due to the persistence of active psychosis, delusions, or hallucinations. By adding that language, the opposition for like healthcare for the homeless and other organizations have been removed. There is still opposition, similar to what you heard in a prior bill today, for I think basically the same reasons. I've come to believe it's going to be very difficult to get certain groups on board and supporting things like this. But what we know is that individuals that need this help are in a place where they can't ask for it. They're not able to make those decisions for themselves. And so the bill is very strict in that it can only apply with people that are in active psychosis, delusions, and hallucinations. I think it's inhumane. I think it's cruel to allow individuals to remain in persistent state of psychosis where they are causing, they're losing their life, they're losing their freedoms. And so I think we can do a better job with this. In Maryland, a lot of other states have. And, I know that there is some remaining opposition. I think it'll be persistent. Honestly, I don't know how we get around it, but I'm hoping that we can find a path forward. And with that, I'll conclude, Madam Chairman. Thank you.
Thank you, Delegate Kipke. There's one witness, Debbie Jessen, and I believe she's not here, right, Susanna?
Correct.
Okay. If she comes in, let me know because she is a favorable. I appreciate it. So are there any questions for Delegate Kipke on this bill? 1 second. Seeing none. We're going to go to the panel of unfavorable, and we're going to start first with Mr. Dan Martin.
Madam Chair, thank you very much. Members of the committee, Dan Martin here in respectful opposition to House Bill 1160. We've heard a lot from families today about, a need to get folks, loved ones into treatment. And I feel a lot for those family members. I'm a family member too, of someone with serious mental illness. My sister-in-law has battled schizophrenia for years, and it's been really challenging for her and for my brother and for our whole family. And so I understand what folks are going through, but I have to say that not all family members support this kind of expansion of involuntary treatment. We've been talking for years in this committee about modifying the definition of dangerousness. And last year, following a hearing, as you heard, on a nearly identical bill, and at the request of the Lieutenant Governor, the Behavioral Health Administration hosted a very inclusive process to review and recommend a new definition of dangerousness. And that process included consumer and family advocacy groups, behavioral health providers and professionals, legal rights groups, persons with lived experiences, and more. And in the end, not everyone got everything they wanted, but there was a definition offered that was agreed to by a majority of the participants, and this is not that. It does not just apply to folks in active psychosis. In fact, the psychiatric deterioration standard in this bill was discussed and roundly rejected as overreaching. And that's because it would subject an overly broad population to involuntary commitment unnecessarily. Just because a person's symptoms are worsening doesn't make them a danger or mean that involuntary hospitalization is the clinically appropriate level of care. Predictions of future dangerousness and deterioration are notoriously unreliable, with studies finding clinical assessments only slightly more reliable than chance. And if trained mental health professionals would struggle to predict future dangerousness or deterioration under the bill, then that laypersons and police who would also be required to apply this standard would struggle even more. And so for these reasons, I appreciate what the sponsor's trying to do. I appreciate, all the families speaking out in support of more services, but this is not the way, and we would urge unfavorable report. Thank you.
Thank you for your testimony today. Next, we have Ms. Shauna Brushed.
Good evening, Madam Chair, Madam Vice Chair, and members of the committee. Thank you for this opportunity to testify in opposition to House Bill 1160. My name is Shauna Brock, representing Behavioral Health System Baltimore. Behavioral Health System Baltimore is a nonprofit organization that serves as the local behavioral health authority in Baltimore City, overseeing a full range of mental health and substance use services. I'm also a licensed clinical social worker with 15 years experience in Maryland. As a clinical social worker, I work with people with serious mental illness such as psychotic, bipolar, and depressive disorders. And I also have a close family member with bipolar disorder. Over the course of my career, in rare cases, I've had to seek involuntary hospitalization through an emergency petition for individuals who are in imminent danger to themselves or others. In my clinical experience, hospitalization can address short-term safety needs, but does not address long-term problems as described in this bill, such as a person's ability to meet their basic needs. This bill is overly broad and would create more confusion about when hospitalization is the least restrictive option for people with mental illness. Being forcibly hospitalized is inherently traumatizing due to the sense of lost control it creates. Forcible hospitalization is one tool in a clinician's toolbox to address immediate safety concerns, but it damages efforts to build hope, trust, and collaboration. Hospitalization is not a magic bullet. Rather, working with trusted peers and clinicians over the long term can help individuals envision a meaningful life and consider whether medication is right for them. Finally, as a systems manager, based on the expressed desires of our communities, Behavioral Health System Baltimore is dedicating our efforts towards more community-based services that emphasize individual and family choice and voluntary engagement to reduce their reliance on involuntary care. HB 1160 contradicts and undermines those efforts, and it's for these reasons Behavioral Health System Baltimore opposes this bill and requests an unfavorable report. Thank you.
Thank you for your testimony. We appreciate it. Next, we have Ms. Ann Geddes.
Thank you, Madam Chair and committee members. My name is Ann Geddes, and I'm speaking now in opposition to 1160 as the parent of a child who's now 33, who was diagnosed with serious mental illness as a teen. Since he was a minor and he frequently went into crisis, his father and I did have the power to have him involuntarily committed to inpatient treatment many times, with stays ranging from 1 week to 2 months. He still will talk about how traumatic the experience was, especially since he was subject to the use of restraint and seclusion a number of times during his many hospitalizations. He was put in both 4-point and 5-point restraints on more than one occasion. And on one occasion, the hospital staff used a cold, wet sheet pack restraint. This was on a minor. He says the experience of involuntary commitment forever turned him off from receiving mental health treatment. After turning 18, he refused all psychiatric treatment and medication. We must be aware that this aversion to receiving mental health services can frequently be the consequence of involuntary treatment. Only very recently, as a 32-year-old, did he seek out mental health treatment and decide to begin to take medication after many bad years. He says that the results have transformed his quality of life, and he wishes that he engaged in treatment years ago. So my family's experience with involuntary commitment was not only did it help to facilitate recovery, it impeded progress. Many family members with a child or other loved one with serious mental illness value self-determination. What they want is for their loved one to have easy access to a broad array of quality, appealing, and readily available mental health treatments and community supports. Therefore, we urge an unfavorable report on House Bill 1160. Thank you.
Thank you again for your testimony. We appreciate it. Next, we have Carol McKay.
Yes, as I said earlier, I'm the chief of the Mental Health Division in the Public Defender's Office. The ACLU is also signing on to our written testimony in this bill and also supports our opposition. The current involuntary civil commitment system works to capture the vast majority of at-risk, dangerously ill individuals in Maryland. My division represented clients in 9,612 inpatient commitment cases in 2020. Judges only ordered the release of 219 of those clients at commitment hearings. Our clients are only a portion of the total number of individuals emergency petitioned to emergency rooms around the state. Staff at one of Maryland's largest hospitals advised me that about 60% of the individuals admitted for an emergency evaluation were discharged from the emergency department because they did not meet criteria for certification. The current definition of dangerousness is one of the most flexible and expansive in the country. It is easily understandable, and the data prove that it is not narrowly defined by the vast majority of mental health treatment professionals, first responders, or judges who use the statute daily. In fact, the data support the position that the statute is overused to emergency petition those who do not meet criteria. The solution is more robust training for those responsible for applying the current definition. The proposed changes to the statute are unconstitutional. The change allows for individuals to be committed on the basis of potential future dangerousness. As Dan mentioned, studies have shown that clinicians' opinions about future dangerousness are no better than chance. And we had several psychiatrists testify before the work group that predictions of future dangerousness are notoriously unreliable even by trained professionals. And indicated that accuracy, they may be reliable if you're talking about minutes or hours, but the accuracy falls off very quickly. Thank you.
Thank you for your testimony. We really appreciate it. Next, we have Ms. Karen Foxman.
Good evening again, Madam Chairwoman and members of the committee. My name is Karen Foxman, and I am a managing attorney at Disability Rights Maryland, Maryland's designated protection and advocacy agency, federally mandated to protect and defend the rights of individuals with disabilities. On behalf of DRM, I'm asking your committee to issue an unfavorable report on this bill, basing the criteria for involuntary hospitalization to include individuals who are reasonably expected, if not hospitalized, to present a danger to self or others is purely speculative and raises constitutional concerns regarding the rights of the mentally disabled to live in the community. Data consistently shows that people of color are more likely to be retained involuntarily than their white peers due to implicit bias, and the criteria established in this bill will undoubtedly feed into that bias, particularly with people with disabilities experiencing homelessness and poverty, and potentially traumatizing those individuals and all of these individuals, resulting in their potentially avoiding treatment in the future. In 1975, the Supreme Court held in O'Connor versus Donaldson that states have no constitutional basis for confining such persons involuntarily if they are dangerous to no one and can live safely in freedom. This bill creates a structure that assumes that institutional care is best for anyone who is at risk for a worsening mental health condition, and that someone whose condition is worsening will become dangerous. In 1999, the U.S. Supreme Court held in Olmstead versus LC that individuals with disabilities have a right to live in the most integrated, appropriate setting in the community, and that undue institutionalization of persons with mental disabilities qualifies as discrimination under the Americans with Disabilities Act. Maryland must focus on expanding behavioral health care in the community and provide voluntary, culturally appropriate, trauma-informed care, and provide case management and housing supports, as opposed to expanding unnecessary and unwanted treatment in the most restrictive setting. Thank you for the opportunity to share my thoughts.
Thank you for being with us, Ms. Foxman. Now we're opening it up for questions for this panel of unfavorable. Are there any questions for this panel? Okay, seeing none. This concludes the bill hearing on House Bill 1160. Next, we have Delegate Kipke. Concludes the bill hearing on House Bill 1160, but next we have House Bill 900, and that is Delegate McKay and Kipke. Sorry, Delegate Kipke, I was about to make you work some more tonight. Go ahead, Delegate McKay. Thank you for your patience tonight. Can you get started, please?
Thank you. Thank you.
Our pleasure.
Good evening, Chair Pendergrass, Vice Chair Peña-Menech, and the members of the HGO Committee. It is my pleasure to present House Bill 900. Now, this bill prohibits the Maryland Department of Health and local health departments from collecting fees for certified or abridged copies of death certificates for the first responders killed in the line of duty, if a copy is provided to the first responder's surviving spouse or child for a certain purpose. Unfortunately, a record number of law enforcement officers have died in the line of duty in 2021, the most ever on recorded. According to the new data in 2021, 458 law enforcers died. That was up 55% compared to 2020. And according to the data released by the National Law Enforcement Memorial Fund, in 2020, 295 federal, state, local, or tribal officers died in the line of duty. The closest number recorded was 1930, and that was 312. All law enforcement officers, firefighters, emergency medical technicians, and correctional officers in the state of Maryland should be issued a no-cost death certificate when they die in the line of duty. I urge a favorable report for House Bill 900, and I'm glad to take any questions you may have.
Thank you, Delegate McKay, for your testimony today. We do have another witness that is favorable, and that is Mr. Robert Phillip from the Maryland State Firefighters Association. Good afternoon, sir.
He will not be joining tonight.
Okay, so that is it. Are there any questions for Delegate McKay? We have Delegate Carr.
Thank you, Madam Chair. Thank you, Delegate, for bringing this bill. Just a quick question. You know, when you go to order your birth certificate, there's the fee that you pay, and then you can also pay the higher fee through Vital Check if you want to get, expedite your birth certificate. So would your bill apply to both of those, or just basic fee for getting your birth certificate?
So in the line of duty death, especially when it comes to the MSFA, there is actually a committee that goes ahead and does process all the paperwork and that such, and they don't need it on a fast. So the bill would just be for the $30. There again, there's not as many line of duty deaths, so I don't think it would have a big fiscal note as of yet, but if it was the committee's prerogative, we would accept that the rapid charge would be waived as well, but I don't think that's needed in this case, sir.
Are there any other questions? Seeing no other questions, thank you, Delegate McKay. This concludes the bill hearing on House Bill 900. Next, we have House Bill 981. Delegate Henson, Maryland Medical Assistance Program, Personal Care Aids, Reimbursement, and Required Wage. Good evening, actually.
Good evening, Madam Vice Chair. Good evening, Chair Pendergrass and all members of the Health and Government Operations Committee. Thank you for your consideration of this bill and the many bills that are before you this evening. Thank you for the chance to present House Bill 981, Personal Care Aids, Reimbursement, and Required Wage. Maryland faces an increasingly dire shortage of personal care aides, otherwise known as home health care workers. This hurts older adults and people with disabilities, and frankly, it's Maryland Medicaid policies that are the reason, which means that this is a challenge that we can totally tackle and resolve. The past year saw a series of investigations into the home healthcare workforce shortage in Maryland and beyond. Demand is increasing as Maryland becomes an older state and more people with disabilities receive care in their homes rather than institutions. A 2018 study found that Maryland will need 40% more home health care workers over the next 10 years, but the supply of home health care workers is not increasing. Resident Services Agencies, RSAs, report sky-high turnover. The biggest reasons for this is Maryland Medicaid policies. Medicaid funds about 60% of the state's home health care. The Maryland Department of Health currently provides RSAs just $20.54 an hour for home care. And that's not what's paid to the worker, that's the entirety of the budget, $20.54 per hour for this very valuable care. Median wages for the workers is $13.51. Maryland already has an extreme difficulty with finding and keeping home health care workers. If action is not taken soon to increase these wages, the shortage and its consequences will be felt by those who need help the most. Historically, care work was often not even considered work because it was performed by women, specifically women of color. Personal care aides in Maryland are mostly Black, with 90% of them being women and 70% of them being Black. Maryland's very low Medicaid reimbursement rates trap these workers and their families in poverty. This bill has two solutions, or two main parts that create a solution. First, it increases the Medicaid reimbursement rate by 15%, which would be a little over $3 per hour. Second, it provides that starting July 1, 2023, personal care aides whose work is funded by Medicaid must be paid a living wage of at least $16 an hour, up from the average of $13.50. The policy benefits both businesses and workers, as it allows businesses to retain skilled workers and it allows workers to have a living wage. Wage pass-through policies like this have been implemented in states across the country. This bill is similar to a Maine law passed last year, which increased reimbursement rates while requiring Medicaid-funded workers be paid at least 25% more than the minimum wage. So we're not taking as big of a step as Maine, but it would allow Maryland home health care work to remain competitive and to remain something that can support families. Thank you for your consideration.
Thank you, Delegate, for being with us. You have 1 minute and 42 seconds. Who would you like to give that time to from your panel?
Am I able to reserve the balance for any rebuttal, or does it trickle down to panelists?
No, just for the next witness.
Thank you, Madam Chair. I'd like to give that time to Mr. Rodwin, David Rodwin.
Okay, wonderful. Is Mr. David Rodwin here?
Yes, good evening, Madam Chair.
Yes, so you have 1:42, 1 minute and 42 plus your 2 minutes. And good evening, sir. You can get started. Nice to have you.
Thank you so much. Good evening, Madam Chair and members of the committee. My name is David Rodwin, and I'm an attorney at the Public Justice Center, focusing on job quality for home care workers. I'd like to thank Delegate Henson for introducing this important bill. This bill is about taking a huge step, or a leap really, to solve our state's growing and really devastating shortage of home care workers. Delegate Henson already summarized what the bill does, so I just want to highlight the bill's impact on the two things, the gender pay gap and racial equity. In Maryland, women are paid just 86 cents for every dollar a man makes. Part of this is women working the same jobs as men and just getting paid less. But just as much of it is jobs mostly done by women. that society values less and pays less. The same is true for racial equity and the racial pay gap. Black women in Maryland make just 69 cents for every dollar a white man in the state makes. 90% of Maryland's home care workers are women and 70% are Black, but Maryland Medicaid policy treats this work as if it's not even real work. Reimbursement rates are barely enough to pay workers $14 an hour, and there's no wage minimum other than the state's minimum wage. A few weeks ago, you heard testimony from Stephanie Williams, a home care worker who testified in support of HB 544, who testified that she's getting paid just $11.75 an hour, less than Maryland's current minimum wage of $12.50 an hour, to provide this care, which again is funded by Medicaid with state money. This bill would take meaningful steps to help narrow the gender wage gap overall and advance racial equity in particular by ensuring that home care workers under Maryland's Medicaid program are paid something closer to a living wage. I do want to make a quick point about the fiscal note. We think it is incorrect for two reasons. First, nursing homes are just about always more expensive than home care. The minimum cost annually for someone to be in a nursing home is north of $80,000, usually north of $90,000 a year. Home care is always cheaper than that. This bill will ensure that more Marylanders can get home care where they reside in their communities, so they don't have to go into nursing homes, which will save the state money in Medicaid costs. The health outcomes are also generally better when people live in their homes and communities rather than in nursing homes. Second, the fiscal note doesn't address likely federal funding that we hope will be passed if and when Congress passes a reconciliation bill. Folks who follow this stuff closer than I do say that one of the things that everyone agrees on, all of the key stakeholders in the Senate, is $150 billion or so in federal funding specifically for Medicaid funded home care. And Maryland's share of that would help cover a very large chunk of this fiscal note if and when it's passed. With that, I thank the committee and I ask for a favorable report. Thank you.
Thank you for your testimony. We appreciate it. Next, we have Ms. Ricara Jones.
Good. Hope you all can hear me.
We can hear you.
Great. Awesome. Madam Chair, members of the committee, my name is Ricara Jones. I am the political director of 1199 SEIU. We are the largest healthcare union in the country, and we represent workers in long-term care facilities, hospitals, and clinics across the state, and we support this bill today. Our members are on the front lines of the long-term care system, working every day under critical staff shortages, and we know that the conditions for our counterparts who provide home and community-based support are equally dire. When someone needs home care services, but they can't receive them, it puts a lot of pressure on our nursing homes and our hospitals. So to address this staffing shortage, we have to address the poverty wages of this workforce. So today, I just want to highlight really quickly that if we invest the money now in this workforce, it'll actually save the state money in the long term. Many other states, just like Maryland, are dealing with the staffing crisis, but a few states have decided to make massive investments in their workforce. So we think about states like Minnesota, Colorado, Wisconsin. They're doing exactly what this bill would do. They are using their resources to pass the rate increases to improve the wages of the direct care workers. For example, we have New Jersey. They're going to invest $634 million in home and community-based services. They are going to increase their personal care assistant rate to $23 an hour. Tennessee is launching a plan to invest nearly $140 million in wage increases for direct care workers. And Wisconsin is investing a total of $247 million over the next 2 years in workforce funds. So we're hoping that Maryland will do the same. This is a great opportunity to attract workers to this field. And we can make the decision to change, the issues that we're having with this workforce. So we urge a favorable report. Thank you for your time this evening.
Thank you for being with us. We appreciate you and the work that your members do. Next, we have Mr. Eric Colchamero.
Good evening, Madam Chair, Madam Vice Chair. My name is Eric Colchamero, Director of Government Affairs for the Alzheimer's Association in Maryland. Thank you for the opportunity to testify today on this important piece of legislation. The Maryland National Capital Home Care Association, which represents the home care workers industry, has been a longtime ally of Marylanders with Alzheimer's and other dementia. They serve on the State Alzheimer's Council, and we're grateful that this committee passed legislation last year with MINCA's support, which requires an annual and continuing education on dementia for all of the home care workers who work with individuals who have this cruel disease, Alzheimer's. The bill under consideration today is a rate increase. It is a 15% rate increase for these invaluable providers who go into our homes and help seniors age in place. This is also a bill that helps our direct care workforce, and that, my goodness, is important. The workforce aids individuals with dementia, 95% of whom have at least one other chronic condition. There's a shortage of them overall. There's been legislation on studying the healthcare workforce shortage, and yet the median wage for home and personal care aides is just over $13 an hour. I'll close with this. This fiscal note outlines a high cost. We may even hear from industry that they want additional funds in order to pay their workers $16 an hour. This would be on top of the annual 4% rate increase they are receiving, on top of the one-time 5.2% rate increase, and on top of the 75% of the FMAP funding that came in the stimulus plan that went to industry. The workers deserve care. There's a workforce shortage. We're studying it for reasons like this, because they simply aren't getting paid enough. I thank you for your time. I urge a favorable report to help the industry and their workers.
Thank you for the service you do. We now have Ms. Ann Seacock.
Thank you, Madam Chair, members of the committee. I'm Ann Seacott, and I'm testifying this evening on behalf of the Maryland chapter of the National Association of Social Workers. And I want to wish everybody a happy Social Worker Month, as I was informed by my friends at NASW a little while ago this evening. Social workers care about this because while we have talked about the two very important parts of this bill, raising the reimbursement rates so that the employers are able to better meet their costs, the extremely important piece, the reason really for the bill to have, workers be able to have a better wage. But this is all about making sure that quality services are provided to the people that we love who need these services. This is an important way to save the state money by averting nursing home costs. But remember, the issue with the workforce shortage is that there is such a high amount of turnover in this industry because of the low wages. And that hurts the people who are being served. And so to ensure better quality services paid by for our loved ones, paying the workers better just makes a whole lot of sense. So this is one of those win-win-wins for the state and our communities. So I ask you for a favorable report on the bill. Thank you. And thank you, Delegate Henson, for bringing this bill.
We have actually Randy Ames.
Good evening. Thank you, Madam Chair and committee members, for the opportunity to provide testimony on House Bill 981. My name is Randy Ames. I'm an assistant managing attorney with Disability Rights Maryland, the state's congressionally mandated protection and advocacy agency responsible for advancing the civil rights of people with disabilities. The current staff shortages and caregiving crisis in Maryland has widespread effects and costs. It touches personal caregivers who are overworked, underpaid, and leaving the field at rapid rates. There are hundreds of Maryland Medicaid participants that are unable to access the medically necessary services they are entitled to like DRM's client who was trapped in his wheelchair for approximately 48 hours because his caregiver quit without any notice, and his home health agency that he was working with had no one available to cover his hours that weekend. Informal caregivers, friends, and families of Medicaid participants are having to miss work to fill in for uncovered 8 hours to ensure their loved ones do not experience unnecessary medical emergencies or hospitalizations, or to simply have a bath or eat. The small business owners in Maryland that run home health agencies are unable to provide the services that they've been contracted to provide. House Bill 981 is part of a larger strategic plan to improve our home and community-based service programs in Maryland. It's the logical next step given the large funding opportunities under the American Rescue Plan Act of over $230 million that the state of Maryland will be receiving. Last legislative session, our budget designated 75% of our ARPA funds to go towards provider rates, and this bill is the next step to ensure those rates, those increased rates get to the, key providers providing services to people with disabilities. For these reasons, DRM is requesting a favorable report of House Bill 981. Thank you.
Thank you for being with us this evening. We really appreciate it. Now we'll open it up for questions. For this favorable panel, are there any questions from the members? We have Delegate Hill.
Thank you, Madam Chair. And just real quickly, can anyone tell us, for people whose insurance has run out or are uncovered or have to pay out of pocket, what is the rate that they're having to pay for these personal care, direct care?
Delegate Henson, who's the best person to answer that question?
I'll send that to Mr. Ronwin.
Thank you very much. Sir, will you be so kind?
Yes, thank you, Delegate Hill, for that question. I'll note that typically people who pay out of pocket or who have a long-term care insurance policy, generally, if they're paying out of pocket, they pay a higher rate to the home care agency. Just anecdotally, I think it's closer to $30 an hour. This compares to the current Medicaid reimbursement rate of $20.54. As a lawyer at the Public Justice Center, we represent home care workers in wage theft cases and other employment claims. Nearly 100% of the wage theft cases that we take on behalf of home care workers are home care workers whose work is funded by Medicaid. And that's the state not doing the oversight that it needs to do and not funding this work at the level that it needs to, and not requiring the wage minimums that it needs to. So the rate, people who pay out of pocket generally pay more than the state is paying.
Thank you. Any other question for this panel? Seeing none, now we go to the favorable with amendment panel, and that is Ms. Dana Kaufman. Good evening.
Thank you very much, Vice Chair Penna-Melnick, members of the committee. Good evening. For the record, my name is Dana Kaufman. I'm here on behalf of the Maryland National Capital Home Care Association. We are favorable with amendments. I'm going to briefly go over what the amendments are, though. So the bill basically says it's a 15% increase in Medicaid. However, when we took a look at it, it appeared that 15% failed to take into account ancillary costs that are mandatory, such as payroll taxes, unemployment insurance, and workers' compensation, to name a few. So when you take the wage that's being paid now, which is around $13.50, and you add those costs, it was our calculation that Medicaid would need to increase instead of 15% to 20.8%. And then we would also be asking for language in the bill, and this is noted in my testimony, that the funds are supposed to supplement and not supplant existing funds. And on that note, I do want to point out that even after the 4% and the one-time 5.2% ARPA funds, which is actually the 75%, our costs, as you heard, are still, or our reimbursement is $20.54. Back in 2018, 4 years ago, when Hilltop released their study, the estimated cost of care and what we should have been reimbursed was $25 and some cents. I can't remember what it is. My testimony actually had the wrong number of 24 something. But that was 4 years ago, and we were off by $5. And now we are still behind the 8 ball. So this will address the issue of wages to a certain extent, but until the state invests in our Medicaid programs and increases the funding for all of the programs, not just home care, but for all of the programs, the provider community is always going to be behind the 8 ball, and so were all of the wages paid to our workforce. Thank you very much.
Are there any questions for Ms. Kaufman? Seeing none, thank you so much for your testimony. This actually concludes the bill hearing on House Bill 981. Thank you, Delegate Henson, for being with us today. Next, we have House Bill 1302, Delegates Mortz and Adams, Food Service Facility Retailers of Prepackaged and Pre-Inspected Goods Exclusion. Good evening.
Good evening, Chairman and colleagues. Great to be with you. Johnny Moutz here, District 37B, Talbot, Caroline, Dorchester, and Wacomico counties for the record. HB 1302 would exclude retail businesses engaged in selling prepackaged and pre-inspected goods from the definition of food service facility. This stems from an issue in our district with a retail facility that was selling some prepackaged, pre-inspected foods, and they were determined to be selling potentially hazardous food, and a food service license was required. The establishment doesn't have the infrastructure to meet the requirements for a food service facility. They've been selling the goods for over 20 years. I think the issue that we're trying to address with this bill may also fit well within the confines of other discussions about bills dealing with appeals and things like that, within specific decisions made by folks in the health department. But HB 1302 is our best faith effort to try to address this situation. We urge a favorable recommendation, and the bill is pretty straightforward. So thank you very much, and I appreciate your attention.
Thank you for being with us this evening and for your patience. We also have Caitlin McDonough. Caitlin.
Good evening, Madam Chair and members of the committee. Caitlin McDonough on behalf of the Maryland DC Vendors Association. While we did not, request that the delegate introduce the legislation before you, we do support the intent, whether it be through this bill or some other practice, of kind of taking a closer look at facilities that only sell prepackaged, pre-inspected, and kind of pre-regulated goods, as opposed to preparing food products on site, more like a restaurant or a traditional grocery store. Our bread and butter in the vending association are vending machines where food is held behind glass and it meets the prepackaged definition. And we have a pretty straightforward regulatory system in place under law now for those. As we move into the future, and particularly during COVID, we've seen increased demand in the marketplace for prepackaged items that people aren't putting their hands on, and also for cashless options and options where people don't have to, interact directly with a cashier or anything like that. And that's led us to, develop one of our other kind of, more modern vending offers, known as a micro market, where it's very similar to a vending machine, but you basically don't have the glass between you and the food. We'd like to see, just a way forward for these types of establishments to be regulated in a way that's appropriate for them, as opposed to having to meet a lot of the higher standards that are really designed for restaurants and other types of facilities. So we appreciate Delegate Moutz's and Delegate Adams' work on this, and happy to work with the committee if there's a desire to move forward. Thank you.
Are there any questions from the committee? I do have one question, if I may, and I see Delegate Johnson. The Department of Health and also UFCW 400, they said that this bill will roll back the food and safety regulations on food businesses, retail, or engaged in selling prepackaged or pre-inspected goods. They also says that, the workers will be forced and pressure to extend the food shelf life or other things to food items. How will you address the concerns of the Department of Health and UFCW? And I think that will be for the sponsor.
Yeah, so it was the expiration date? Was that the
Yes.
the issue? Was
Yes.
there another workplace issue? that they were raising?
They're raising the fact that these regulations are placed for the health and safety of the consumers and businesses, and rolling them back will create an environment for sickness, food poisoning, or worse, especially given that we are, dealing with COVID.
I guess that's the argument against the bill, right? The business I'm referring to has been in business for, I said 20 years, but it's been longer than that, and there's never been an issue.
Okay. All right, thank you. I have Delegate Johnson followed by Delegate Bagnall.
Thank you, Madam Chair, and thank you, delegates, for bringing us this bill. We heard something the other day, a bill that was similar to this, and some of the concerns, now these are all prepackaged foods. Are any of these foods, do any of these foods need refrigerated? Because that was one of the arguments on the other bill that we heard, not keeping it the proper temperature, and like Madam Vice Chair said, expiration of foods.
That would, so the bill's contemplated to cover refrigerated foods, absolutely.
And are those refrigeration units? Does anything get inspected?
The inspection on the refrigeration units, there would,
Does the health department go out and inspect their area that they sell it in? Do you know?
I offhand, I don't want to give you a false answer and try to make something up.
I was just trying to address some of the roadblocks that we ran into on the other bill to see if maybe those were not a roadblock for you. But if you could just let us know, I'd appreciate it. Thank you.
Sure.
Thank you, Madam Chairman.
My pleasure. Delegate Bagnall, I no longer see your hand. Is that right? Okay, great. I see no other hands. This actually concludes the bill hearing on House Bill 1302. Thank you, Delegate, for being with us today. And if you could submit that information to us offline, that would be great.
I'll get you a specific answer tomorrow morning.
Thank you so much for being with us.
Thank you.
Our pleasure. Next, we have House Bill 1357, Delegate Shi, Public Health Packaged Ice Testing.
Thank you and good evening, Madam Vice Chair. I am Delegate Lily Chi here to present HB 1357. This bill is about testing packaged ice for public health and consumer protection. Currently, the Maryland Department of Health sets sanitary and labeling standards for packaged ice in Maryland, which is considered a food item by the Food and Drug Administration. But there is no testing requirement to ensure that the ice being produced is safe and healthy for consumption. Established ice manufacturers are subject to equipment inspections twice a year, but this does not include smaller retailers such as convenience stores, gas stations, and liquor stores that may also bag their own ice and sell to consumers. HB 1357 requires quarterly testing of packaged ice by any ice manufacturers, which would include the persons or businesses who manufacture packaged ice for retail sales in accordance with the standards set forth by the MDH. The ice manufacturers are to keep the record for 2 years and submit the test results upon request. That's basically what the bill does. The reason for this bill is needed is because packaged ice is an overlooked area in terms of public health standards. A study by the International Packaged Ice Association of 156 on-site packaged ice samples in California actually showed that over half were contaminated with yeast and mold, and more than 1/3 had some form of bacteria, including E. coli. Several states have also implemented testing requirements and standards or are in the process of implementing similar legislation. Florida and California have adopted similar testing policies, and the legislation in New Jersey is also being advanced. In fact, it has passed the House and is being advanced in the Senate. So with that, I want to thank you for your consideration, and I want to turn to my witnesses.
Thank you for being with us, Delegate. We do have two witnesses, Chris Lamond.
Yes, thank you. Thank you for the invitation to testify today. I'm Chris Lamond with the International Packaged Ice Association, and let me first thank Delegate Chi for proposing this important legislation related to packaged ice production in Maryland. I want to start by providing a review of the current federal and state guidelines for how to properly manufacture packaged ice. It's important to note that the FDA does recognize that ice is a food and also recognizes that ice can become contaminated and cause illness and death. But given the lack of resources that most state and federal agencies have to deal with, the FDA has not promulgated any rules for how to properly manufacture packaged ice to date. Currently, ice falls under the category of good manufacturing practices. And the last major food modernization act that was passed by Congress, the Food Safety Modernization Act, actually exempted all retail ice manufacturing, from the provisions in the law. So there's a big gap that we're trying to help close to protect consumers. Because of the lack of consistent manufacturing oversight on the local, state, or federal level, the International Packaged Ice Association, following the steps of the bottled water industry, developed our own industry standards. Our quality control program is called the PICS, the Packaged Ice Quality Control Standards, that our members, all IPIA members, are required to follow, and affords the confidence for our membership that manufacturing packaged ice is free of potential contamination. These standards set the mark very high to ensure that a bag of ice produced under the International Packaged Ice Association standards is safe for the consumer. Absent of those standards, it's really a free-for-all in terms of the packaged ice industry. Due to the lack of governing regulations for packaged ice, it's notable that the United States Department of Defense, the Army Corps of Engineers, as well as some very high-profile private retail establishments, including many big box retail stores, require that when they purchase packaged ice, it is from IPIA members to make sure that their acquisition of ice is safe. While our industry standards protects the consumer, we estimate that IPIA members make up only about 50% of all packaged ice sold in the United States. So it's a really big market out there that is unprotected. So if this legislation is approved, Maryland can join California, Florida, New Jersey, and Montana as states that have recognized this issue and stepped up to improve the packaged ice safety for their citizens. I thank you for your time, and I urge the committee to favorably report this legislation.
Thank you so much for being with us today, Mr. Lamond. The next witness is Ms. Deb Conklin. Good afternoon.
Good evening. Hi, my name is Deb Conklin. I am the CEO of Ready Ice, which is the nation's largest manufacturer and distributor of packaged ice. We have 3 facilities in the state of Maryland, 2 of which manufacture and the third just distributes, and over 100 employees. We call ice the silent, star of any family event. And what people don't understand, and I've been shocked by as an engineer, people don't think that they can get sick from ice. They think it's cold. There's no way it can carry bacteria. And I believe the reason why we need this bill across the entire United States is because once folks test their ice and realize that they could get their family members sick, I believe they'll work to comply with the requirements for proper cleaning of their ice machine to make sure that they don't get people sick. I think the most important part is this is not a land grab by similar manufacturers like me who want to end up with more ice in our plants. I don't really care about that. I care about a peanut butter or lettuce type outbreak that literally shuts our industry down. And we're a small business. Even though we're the biggest, we're only a $400 million business. And so This could be catastrophic to the industry, where ICE, which is incredibly important to many industries, we wouldn't have no less ICE for the fun times that we all enjoy with our family. This is not arduous. It's once a quarter. It's probably $25 or less to test a bag quarterly. And then once people know that they're not making good ICE, they'll address the processes to make sure that they do make good ICE. I appreciate Delegate Chi giving us opportunity. I appreciate her support, and I look to support Maryland constituents in making them safe, including my employees that work in the state.
Thank you for doing business in our state and for your testimony today. Are there any questions for these witnesses? Okay. Seeing none, this concludes the bill hearing on House Bill 1357. Delegate Shi, thank you for being with us today, and to your witnesses, have a great evening. We now have two hearings left, and I know I'm the one standing between you and the door, so I'm going to make mine really fast. And that is actually, the first one is House Bill 1082, which is Public Health, Consumer Health Information Hub and Requirements. And we do have members of the Appropriations Committee with us as well. So I will start with my testimony. And I would like to say good evening, Chairman Pendergrass and fellow members of the committee. I am pleased to present to you House Bill 1082. This bill addresses a common problem that this committee faces. What is an accessible, patient-centered health system for Marylanders, you may ask? Each session, we work to expand access to some aspect of healthcare, whether it's insurance coverage, maternal health, mental health, and substance use disorder services. Until now, we have not tackled a key social determinant, one of the root causes undermining Maryland's progress on healthcare access, equity, and more, that is health literacy. What is health literacy? It's a two-sided situation about accessible, useful information and services for health. One side of the health literacy, we legislators know well because our constituents regularly call our offices to tell us about letters and forms that denied them benefits they thought they had, and you find yourself contacting one of the insurance carriers, or they were charged for some service they thought were in network. They tell us about not having access to broadband and telehealth services, so they miss their appointment, and they can't see their healthcare providers to get trustworthy, personalized advice and care. But we don't know the other side of health literacy as well. This is the side that House Bill 1082 tackles. Our public agencies and health information and services providers may be well-intentioned, but many times the information they create is too dense and too complicated to be useful for our constituents. In addition, health services may be too hard to find, understand, and navigate to benefit our constituents to the maximum extent possible. To be clear, health literacy isn't a problem of poor reading skills. It's a problem that affects all of us whenever we encounter health information and services that don't meet our needs in order to make healthy choices and live our best lives. This is personal to me. As an 8-year-old, I helped my Spanish-speaking mom try to understand confusing, jargon-filled English language letters and forms that made no sense to her or me. Yet we both knew these letters and forms had important information that we should understand and act upon. My mom and I would have been much better if we had received plain English information or Spanish with clear directions about what to do. This is what we should want and help build for all Marylanders. A health system that gives them a fair chance at their best lives because they have the information and services to be as healthy as possible. Think about when you have a loved one in the hospital, you have to be the advocate, make the calls, get things really explained to you in simple terms. House Bill 1082 designates the University of Maryland Horrigan Center for Health Literacy to support health information and services providers so they can best serve Marylanders. The witnesses will explain why the Center Health Literacy expertise can help our entire state evolve toward a more accessible, patient-centered system envisioned by the total cost of care model. So I'm going to allow my witnesses to testify, and they will have the rest of my remaining time. Thank you. The first witness is Ms. Cynthia Bauer from the University of Maryland. Good evening. And you
Good
have
evening.
my time plus 2 minutes.
Great, thank you so much. Good evening, and thank you, Vice Chair Peña-Melnick, and good evening to the HGO members. Thank you, Delegate Peña-Melnick, for sponsoring this health literacy bill. I'm Dr. Cynthia Bauer, Endowed Chair and Director of the Horowitz Center for Health Literacy at the University of Maryland School of Public Health. So as we've heard this evening, this committee considers many serious public health issues, but there are still 3 key reasons to support this health literacy bill. First, it will improve the ability of our health professionals and government agencies to communicate effectively with the public and for the public to understand what is being communicated to them. Public health and healthcare professionals get little to no communication training, even though communicating information is a large part of their jobs, as we saw during the pandemic. Second, as a result of HB 1082 activities, individuals and communities will be better prepared to use health information and services. We can improve outcomes when we give patients plain language medication instructions, when we explain clearly how and why diabetes prevention programs are worth their time, when we show why people should choose an emergency department, urgent care, or primary care, and when each is best, and when we break down complex health insurance information. Each of these situations has both personal and system level costs, and HB 1082 can address those costs without adding hospital beds or paying for more expensive medical care. Indeed, if we use health literacy to cultivate a culture of prevention and an informed public, the long-term result will be a patient-centered system with better outcomes and diminished costs in line with the total cost of care model. The third reason is that it advances Maryland's health equity goals. Do I still have time, or is it done?
Sorry, you have about 2 more minutes.
Oh, great. Okay. So the third reason is that this bill advances Maryland's health equity goals, giving everyone, no matter their education level or literacy and numeracy skills, access to plain language information is what's called a universal precautions approach to communication. We don't judge someone for being low literacy. Instead, we make clear and useful information available and accessible to all. Maryland has the chance to be the national leader in showing how to advance health literacy and benefit its residents while meeting its healthcare goals. I have additional information in my written testimony, and I'm happy to answer questions. I urge a favorable report on House Bill 1082, and again, thank you for your consideration.
Thank you. Next, we have the League of Life and Health Insurers of Maryland. Ken Ziersky.
Thank you, Madam Vice Chair, and thank you for introducing this important legislation. My name is Philemon Konjursky here today on behalf of the League of Life and Health Insurers of Maryland in support of House Bill 1082. Researchers show clearly that health and benefits information play important roles in the health status of individuals, and that those with poor health literacy who cannot easily access, understand, and act upon such information are more likely to experience poor health and incur significantly higher healthcare costs. They're less likely to be engaged in their care, and they have a harder time managing their chronic diseases. Achieving these goals outlined in this bill requires a collaborative, system-wide commitment that involves all of the professionals, organizations, and disciplines communicating with consumers. Health insurers remain committed to improving health literacy in Maryland, and we're happy and willing to engage in this program as necessary, as it is an important step in improving health outcomes across the state. And with that, I'd just like to reiterate our strong support for House Bill 1082.
Thank you so much for your time and for your support. Next, we have Mr. Joseph Wright. I know that he had to go back to the hospital. Is he on? Susanna?
He is not.
Okay. The next we have Mr. Mark Larkner from the Maryland Health Benefit Exchange.
Good evening, Madam Vice Chair and members of the Health and Government Operations Committee. For the record, it's Mark Luckner from the Maryland Community Health Resource Commission. I believe you may have another person from the Health Benefit Exchange in a moment. So I'll keep my.
I should have recognized that mistake, sorry.
It's okay, it's okay. So it's good to be before you again. I'll keep my remarks very brief. You have my written testimony. For the record, Mark Luckner, Maryland Community Health Resource Commission. We are thrilled to support House Bill 1082. I was listening to your oral comments, Madam Vice Chair, and I was thinking about how our commission was created by this committee and the members of the Senate Finance Committee in 2005 to help expand access to health services in underserved communities. And over that time, I've been here since 2009, we've awarded 648 grants totaling $112 million. There's a common theme in many of these grants, which are designed to serve underserved communities and vulnerable populations. And that is that these communities, they're special and they have unique challenges. And we should be doing everything we can as policymakers to help promote access to health literacy, because that'll help break down those non-medical social determinants of health. These are things like transportation, food insecurity, a dearth of providers, and yes, as you said so eloquently, Madam Vice Chair, health literacy. So we believe in promoting access to health literacy and working with the Horowitz Center for Health Literacy will help arm our grantees with a greater tool to help design programs that will be closely aligned with the needs of their community and to help empower individuals who face these non-medical barriers to access healthcare. With that, I would say it's an honor to be before you again, Madam Vice Chair, and be part of your sponsor panel. I'm happy to answer any questions. Thank you.
Thank you so much for your support. We appreciate it. Next, we have Michelle Everly.
Thank you, Madam Vice Chair, and members of the committee for your incredibly hard work today and a long day, and for this opportunity to testify in favor of House Bill 1082. I am Michelle Eberly, Executive Director of the Maryland Health Benefit Exchange. Health literacy is a matter of particular significance for the exchange, as we have statutory authority to conduct outreach and education activities to increase health literacy. In 2019, MHB worked with the General Assembly and the governor to enact House Bill 1421, which amended our statutory authority to address health literacy. Uncertainty over benefits, cost sharing, pre-deductible coverage can lead patients to avoid necessary and preventive care. Thus, health literacy is a key part of ensuring that individuals can take full advantage of their health benefits. Currently, more than half of the adults in the US report having low confidence in using insurance to access health care. Most adults have inadequate knowledge of their annual out-of-pocket costs and plan deductible amounts. And there are health insurance literacy disparities by race and ethnicity, socioeconomic status, and insurance status. Increasing the state's investment in health literacy will improve access to health care. We have worked with the Horowitz Center for Health Literacy in the past, and we would look forward to working with the Consumer Health Information Hub on issues of health insurance literacy in the future. Thank you, Delegate Pena-Melnick, for introducing this bill, and to the committee for your work. I encourage a favorable report from the committee on House Bill 1082.
And thank you for staying to the end. We really appreciate it. Now I will open it up for questions from the committee. Are there any questions from the committee? Seeing none, I actually have one unfavorable. Mr. Vince McAvoy, is he here?
Yes, he is.
Mr. McAvoy? Mr. McAvoy, you have to unmute yourself.
Okay, thank you so much. I appreciate you working with me. It's really late. I had to stop out for dinner. I'm opposed to this bill. The reason I'm opposed to it, can you hear me all right?
We can hear you and we can see you.
I'm really sorry about this.
It's okay. We could hear you. Go ahead.
Okay, so what I'm seeing on this is basically a redundancy of what we already do with medical system. When you go to Hopkins, they have all these stands, and you go in and you go ahead and present your medical information, your insurance information, and then you have a chance to talk to people who will help you out with your case. That's what we need to do, not this bill. I understand that we want things plain. I think that what this bill will end up doing is censoring. We see that there's a provision as far as procurement of the state where there's going to be favoritism given to plain speak. I think that we need to have individuals decide their own individual cases without dumbing it down. If they want to go into bigger detail, they can go into it with a doctor. But as far as all the other determinations, especially when you're talking about public health, these issues need to be iterated without censorship and without restrictions. So when I see plain language initiatives, and I am empathetic that we have foreign-born who are needing to hear something in a jargon they understand. Well, we just actually enacted a commission last year just for this type of thing, and they would have jumped with this. So again, I urge an unfavorable. I think this is the wrong approach. It will bring censorship. Thank you all for working so late. I appreciate your service and have a good night.
Thank you, Mr. McAvoy. Just to let you know that there is an amendment that was discussed with the MIA, and the provision on procurement has been removed from the bill because that was not the intent. Is there any? Yeah, I know you will like that. That's why I'm sharing it with you. Are there any questions for this witness? Seeing none, thank you so much. This actually concludes the bill hearing on House Bill 1082. And next we have the last bill of the day, which is also my bill, is House Bill 1078. And it's cannabis regulation, medical cannabis definition and study. I just want to let you know that this bill is now a study. I know there was some opposition as the bill was drafted. We decided after meeting with all the stakeholders to make it into a study. And I believe that now there shouldn't be opposition to it. However, thank you for allowing me to present to you House Bill 1078. This emergency legislation has been amended, as I stated, in consultation with the Medical Cannabis Commission and the Department of Agriculture to study and make recommendations on the classifications and regulations of the, and I'm going to mispronounce it, actually, of the tetrahydrocannabis and certain manufactured products that are artificial, synthetically or naturally derived, as well as manufactured products containing Delta 8 and Delta 10. Basically, the FDA has received adverse event reports involving Delta 8 THC products from December 2020 through July 2021. There were reports from both consumers and law enforcement describing 22 patients who consumed Delta 8 THC products. Of these, 14 ended up in an emergency room. Adverse events included vomiting, hallucinations, trouble standing, and loss of consciousness. Additionally, National Poison Control Centers received 661 exposure cases of Delta 8 THC products between January 2018 and July 31st, 2021, 660 of which occurred between January 1st, 2021 and July 31st, 2021. Of the 661 exposure cases, 41% involve unintentional exposure to Delta 8 THC, and 77% of these unintentional exposures that affected pediatric patients less than 18 years of age. Delta 8 can also have psychoactive effects and are often manufactured with unsafe chemicals. Their impact on the Maryland medical cannabis market needs to be closely examined. In this legislation, this study does that. So I hope you can support this and give it a favorable report. I would like to give the rest of my time to 2 minutes and 51 seconds to my panel. And I would like to call Mr. William Tilburg to address us. Good evening, Mr. Tilburg. Will you be so kind and address us? You have my 2 minutes and 51 seconds plus your 2 minutes if needed.
Thank you, Madam Vice Chair, and good
My
evening
pleasure.
to Chair Pendergrass, members of the committee. Again, Will Tilburg on behalf of the Maryland Medical Cannabis Commission here tonight in support of HB 1078, as including the proposed amendments that Delegate Pena-Melnick just discussed. I'd like to use my time here tonight to further clarify the amendments, and then also sort of give some additional background on what exactly is Delta 8, Delta 10, what are we talking about here? So first, the amendments proposed do three things. First, strike the proposed changes to hemp product from the agriculture article and marijuana from the criminal law article. Second, to amend the proposed medical cannabis definition in Health General to align with the Commission's regulatory definition that's been in effect for the last several years. And then third, as the Vice Chair noted, it turns the restriction into a study where MMCC and the Department of Agriculture are to come together and study and make recommendations to this body and to the General Assembly more broadly on how to regulate non-Delta 9 tetrahydrocannabinols. So then what are non-Delta 9 tetrahydrocannabinols, THC? What exactly is going on? In 2018, Congress passed the Farm Bill provisions, which legalized hemp, and they defined hemp as any cannabis plant that has 0.3% or less of THC, Delta 9 THC. The issue is that there are many different kinds of THC. There is, as the sponsor noted, Delta 8, Delta 10, Delta 6A, 10A, THC, acetate. What do they all have in common? They're all intoxicating. They all provide the same or similar high to what you associate with cannabis more broadly, that is Delta 9. Compounding matters. These other THCs are not present in the plant in volume enough to be commercially used. So in order to produce these, manufacturers are taking CBD, which is not psychoactive, and through acid and solvents, often harmful solvents, are transferring chemically CBD into these artificial THC isomers, which are psychoactive. So as a result, we have a federally and state legal product that has no regulatory oversight. So there's no required testing, there's no age restrictions, and they're widely available in Maryland in retail stores and online. 21 states have already addressed this issue. The proposed amendments, again, turned it into a study. And the reason that makes sense is Maryland is now evaluating through HB 837 and House Bill 1, the constitutional amendment, how to regulate adult use cannabis, that is Delta 9 cannabis. And so it makes sense that at the same time, you're building an adult use cannabis structure, that you're incorporating Delta 8, Delta 10, these other isomers, so that there is consistent standards set for testing, age restrictions, and other things. And so with that, we would urge a favorable report to House Bill 1078 as amended by the sponsor. Thank you.
Thank you very much, Mr. Tilburg, and thank you for your work. We have Mr. Daniel Simmons.
Hi, good evening. Thanks for working so late. Delegates, my name is Daniel Simmons, here on behalf of Maryland Healthy Alternatives Association. A sincere thank you to Delegate Pena-Melnick for responding to our concerns and our invitation to participate in the study. In addition to being one of Maryland's first MMCC patients, my business has played a major role in Maryland's hemp economy since its inception. I hold multiple industry certifications. I'm a panelist at the University of Maryland School of Pharmacology. I participate in research with the University of Maryland Eastern Shore's hemp study, and consult both Maryland medical cannabis growers and processors, as well as hemp businesses globally. My business was built and is sustained by careful adherence to testing and product labeling protocols. We employ a QC process that not only guards our customers from dangerous contaminants, but could be utilized to improve upon current MMCC testing standards. MHA offers these protocols to the committee for use in drafting future legislation. Our stringent testing protocols track chain of custody, follow current good manufacturing practice, and include a full panel lab test, as well as utilize a third-party food toxicity lab for additional toxicology screens. 80% of our business is referral by healthcare practitioner, and we operate and consult with them when manufacturing. This process would help eliminate consumer health risk and would even identify contaminants like PBO, which have been found in dispensary products. We support an equitable regulatory system that would govern manufacturing and sale of hemp-derived cannabinoids. While there are certainly bad actors in our industry, it appears that the majority of complaints received involve a specific chain of stores. We take issue with having our entire industry negatively painted because of one or two bad actors. Thank you.
Thank you very much. Next, we have Mr. Nicholas Patrick.
Good evening. Can you hear me?
Yes,
Okay.
we can.
All right. Thank you, Madam Vice Chair and members of the committee. My name is Nicholas Patrick, and I'm a representative of the Maryland Healthy Alternatives Association. I'm also a first-generation immigrant and the proud owner of Embrace CBD Wellness Centers, which has 3 locations in Maryland. I'd like to thank Delegate Pena-Melnick and the committee for their interest in this issue, and also for slowing things down to perform a group study around the issue of Delta 8, as the bill in its original form would upend the Maryland hemp industry and shutter hundreds of businesses in the fallout of the COVID economy. We are excited to see things change for the better, as we agree that our industry needs regulation. However, I'm slightly concerned about some potential misinformation regarding the potency and safety of Delta 8. According to an article published in the Journal of Cannabis Research, Delta 8 is significantly less psychoactive than traditional Delta 9 found in medical cannabis. This is the primary reason that people purchase these products. The average Delta 8 customer is more akin to a traditional CBD user than a medical cannabis patient, and many of our customers have no desire to become a medical cannabis patient, while many others simply cannot afford to. There are many bad actors and irresponsible sellers in the industry, but there are also many of us who take testing and age gating very seriously. As my partner Daniel has just described, we apply the most rigorous testing standards that surpass those of the MMCC, and we offer these standards as a model for future regulation. My customers rely on these products for many reasons, and many of them come from underserved communities. I've seen firsthand the amazing benefits that these products have in the lives of my customers who shop with us every day. We are truly seeing lives change for the better. I believe that there is a fair and equitable way to regulate this industry, and believe that the hemp industry and medical cannabis industry can and should coexist. I'm offering an amendment to the language of this study to include the MHA as a contributing member of the working group. I know that our association can be of tremendous value in helping the legislature craft regulation based on elements of age gating, testing, licensing, penalties, and oversight that I believe can be invaluable to the mission of this study. We wish to work along the MMCC and the Department of Ag to make sure the study meets its stated goals. Thank you for your time.
Thank you. I really appreciate it. Next, we have Raimi Eck.
Good evening. Thank you for holding this hearing on this. My name is Dr. Ramiak, and I am an epidemiologist, and I'm the policy co-chair of the Maryland Public Health Association. So I would just like to say I am not a lawyer, but Delta 8 itself is not really the issue here. And I think that's what a lawyer would say. We're here to decide what needs to be done relative to an unregulated product that potentially has toxic or even unknown properties to it. So I'm not disagreeing with some of the things that have been said about Delta 8 itself. It's just there's a certain problem is that we don't actually know what this product is. Let's see, there's no age restrictions at all. So even if there is age gating, there's nothing that's actually legally required. The products can be sold in corner stores and gas stations, not just in cannabis type retailers. You also see some pictures in our testimony of advertising being used for these products that can also be ordered online by anyone, shipped anywhere, and they don't pay taxes on them. A number of independent chemical laboratories have tested thousands of products labeled Delta 8, but find very few that don't also contain Delta 9, Delta 10, other isomers, unidentifiable chemical byproducts, or heavy metals and strong acid residuals from the production process. We do know that a number of other states have blocked access to this product, which is not unreasonable given the realistic concerns, but we don't see that as a long-term solution either. So we do support the amendment with the study. Policies and practices should be informed by empirical evidence, but that's difficult when we don't have as enough evidence as we would like, but it does steer us towards other reasonable actions in the meantime. To put this into another context, we require licensing, regulatory oversight, and the paying of taxes for anyone who produces tobacco or alcohol outside of a home grow or home brew situation. You'll see in our testimony, we had 3 different asks of the committee. I've expanded that to 5. One is just make the products available to those aged 21 and over immediately. to allow consumers to make a more informed choice, require a point of sale warning for retailers that this is an unregulated product with unknown properties or other verbiage certain like that, require the same warning for online sales, require retailers to track these products until the report is available. And ultimately, I would at least consider placing a temporary ban until the report is completed and is available. Thank you very much. We urge a favorable report with the amendments.
And thank you so much for your testimony. We really appreciate it. Now we're opening it up for questions from the committee. And first, I see Delegate Hill.
Just real quick, for clarification for the record, are we talking about spice, bath salts, and K2, or we're talking about some other synthetic cannabis?
So is the best person to answer this the doctor that just spoke or William Tilburg? How about the doctor? Oh, Mr. Nicholas Patrick?
Delegate Hill, no, we are not talking about spice, K2, or any sort of synthetic chemical that is not made from actual raw hemp material.
And I would only add what he said, the key word is synthetic.
You can only one person can answer.
Oh, sorry.
Okay, and I have to respect the rules because I'm sharing, like I have to be straight. So thank you so much. Delegate Johnson, followed by Delegate Belcastro.
Thank you, Madam Chair, and thank you, panel, for coming to explain this to us. And Madam Chair, I'm glad you brought this bill to us because I had some of my own constituents call me in the interim, and I had spoken with Delegate Belcastro in the interim about this issue. So my question is, why, now we've already heard testimony that we really don't know when they're advertising Delta 8, what else is in there? And I've seen that other states have banned the Delta 8. So instead of a study, why did we not do some kind of ban until we know what's going on? Because this is available to children and they're recommending it for pets. So it's just really under the radar and it's going wild out there.
I know, and in all honesty, what happened was we put in the bill and the industry when a little bit got really excited. Let's say got very spirited. So in the interest of a compromise, we decided to, look at it, study it. I know that I have spoken to some of you and you want, in addition to a study, some of you have requested that we consider, an age limitation on there for the time being. So look, it's going to go to subcommittee. The subcommittee will decide. I was just trying to compromise with the industry, but I know there are a lot of concerns.
All right, thank you, Madam Chair.
My pleasure. We have Delegate Belcastro, followed by Delegate Saab.
Thank you, Chair Melnick, and thank you so much for bringing this bill. I was first cued into this in the interim when a constituent reached out and said that their child after school went into a CBD shop in Baltimore County and was sold this Delta 8, and they thought that it was marijuana at first, but we later found out that it was Delta 8. So just from someone on the panel, I just want to confirm, are children legally right now able to walk into a CBD shop or a gas station and purchase these Delta 8 products?
Yes, there's no law that restricts that. So what we've heard from tonight is some operators that have restricted sales themselves, but there is no legal restriction prohibiting minors from purchasing these products.
Thank you.
Madam Chairman.
Delegate Saab. Sorry, I was muted. I apologize.
I figured you muted. I was going to go ahead and go because I could hear what you're saying.
Thank you.
This is actually interesting because before today, I don't know anything about Delta 8, but while you were testifying, in my Google browser, Delta 9 came up, which is supposed to be, I guess, more potent than Delta 8. So is the study studying, I'm just trying to understand, I know the bill is different now, the study, is it also covering like all of these harmful chemicals or things that could potentially, all this the harmful one? Was it just specifically going to concentrate on Delta 8?
Delegate, I'm going to allow Mr. Tilburg to address that.
Yes, thank you, Delegate Saab. The study will be broader than just Delta 8. There are a lot of cannabinoids, there are a lot of THC isomers that are not Delta 9 or Delta 8. And so the study would encompass all of the different commercially available, at least now, THC isomers. So as I was saying in my testimony, Delta 8, Delta 10, Delta 6A, 10A, THCO, there's a lot. And so we'll look at what's available, the science related to potency, how intoxicating these products are. The limited data on Delta 8 is that it's about 50 to 75% as intoxicating as Delta 9. The store down the street from me has 100 milligrams of Delta 8 available in gummies. And even if that's 50% as intoxicating as Delta 9, that is a lot for anybody to be consuming. So it'll conduct tests on what products are available in the state now to see if there are contaminants, to see the potency of these products, look at the packaging and labeling, look at laws in other jurisdictions, and try and come up with some recommendations about what would make sense for classifying and regulating these products.
Thank you for your answer, and I appreciate it. Thank you, Madam Chairman.
Thank you for your question, Delegate Saab. Are there any other questions for this panel? And I don't see any. So now we're going to go to the unfavorable. So we have the following people. The first one is Mr. Barry Pritchard.
Good evening, committee members. Thank you for having me this evening. My name is Barry Pritchard. And just for clarification, at this point, I'm actually favorable with the amendment. So if I could take a moment, again, thank you for taking my testimony. As a matter of background, I am an analytical chemist by education with no less than 40 years experience as a natural products chemist. I'm also the owner of Sunex Analytical based in Cambridge, Maryland. Sunex is a fully vertical hemp processing company. In other words, we're a hemp CBD products manufacturer. We provided testing or extraction formulation services for many of the region's hemp farming operations. We've been instrumental in providing guidance for the Department of Ag on industrial hemp regulation issues and have been a trusted testing partner for the University of Maryland Hemp Pilot Program and their principal investigators. We've also been awarded 2 Rural Maryland Council grants to support the hemp industry. Our vision has been to guide the CBD industry, the hemp industry, through the early years to raise awareness of the overall value of the hemp crop for the farming community, with the goal of having that community adopt hemp as a potential rotational crop for harvest for seed, oil, and fiber. We submitted a comprehensive background primer on the topic of Delta 8 and suggest that you take a look at that. Just a few comments about the health crisis. As a minor producer of Delta 8 products, we're keenly aware of the market pressures associated with consumer products manufacturing. And we've witnessed as D8 prices fall, that quality control has been impacted. Our technical analyses of D8 concentrates confirm that the claimed purity of these products is woeful. Most of the D8 on the market, by the way, is being produced outside of Maryland with little regulatory oversight. We do indeed have a health crisis. Potential solution to this is to empower a non-government organization such as the Maryland Hemp Coalition to develop standards for manufactured D8 products. Under these circumstances, Department of Agriculture.
So you have to wrap up, please.
Sure. We further
Okay.
suggest the adoption of a protected industry in Maryland whereby Delta 8 source plant materials are required to be grown by Maryland hemp farms, enabling our vision for a vigorous hemp industry in Maryland. I'm at your service to answer questions on the topic and would consider inclusion in the proposed work group.
Thank you so
Thank you.
much for your testimony today. We appreciate it. Next, we have Mr. Kevin Addix.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. Kevin Addix with Grow and Fortify, representing the Maryland Hemp Coalition, a coalition of growers primarily, with also some processors and retail stores as members. As it has been discussed already, and first I should say that we've switched our position to favorable with amendments with news of the study. Delta 8 as a product absolutely must be regulated for all the reasons that have been mentioned before. The hemp plant is already regulated under the USDA, under careful regulation by the Maryland Department of Agriculture, and there are rules afoot at the federal level to adjust some of those, or legislation to adjust some of those rules going forward. But what I would say is, I would ask that this committee and the subcommittee look at the hemp plant separate from Delta 8. Delta 8 needs to be regulated. The hemp plant is already regulated, and it's regulated under a scheme that makes sense for a burgeoning industry that is growing this plant and farmers who are trying to figure out all of its merits. Hemp can become a product in the form of seed or oil or flour or as you've heard, processed into CBD. It can also become concrete and flooring and other things. So to be a hemp plant, it is tested to ensure that there's nothing coming out of that hemp farm that is intoxicating. The processing that we're talking about here for Delta 8 happens down the chain. It should be regulated. Hope that can be reasonably regulated. And I would ask that the hemp plant be considered still an agricultural product and not move over to deeper regulation under the Medical Cannabis Commission. We would also urge the committee to include, and the sponsor to include, hemp growers in the study. So with that, we urge a favorable with amendment report. Thank you.
Thank you for being with us and thank you for your suggestions. I have Mr. Sellers next.
Thank you. Good evening, Chair, Vice Chair, and members of the committee. My name is Levi Sellers. I hold a seat on the Maryland Ag Commission, and over the last 2 years have reported on the Maryland hemp industry. I'm an advising member of the Maryland Hemp Coalition and also own a state licensed hemp farm. One issue I would like to first address is the comment on the hemp tetrahydrocannabinol. The 2018 Farm Bill was not the only act by Congress that addressed this. The Agricultural Improvement Act of 2018 actually amended the Controlled Substance Act in 2 ways. The definition, one, the definition of marijuana was changed to exclude hemp based on the definition of the 2018 Farm Bill, and 2, all tetrahydrocannabinols in hemp are removed from the Controlled Substance Act's definition of tetrahydrocannabinols. This bill changes that action and attempts to include these in the Maryland Controlled Dangerous Substances. But allow me to also continue. Responsible retailers are not marketing these products to kids or pets. Just so that I'm clear, I want to state that I'm here today in favor of HB 1078 as amended, but oppose as drafted. As drafted, I feel this bill will further the confusion between hemp and marijuana, limit research, and opens the door for a potential conflict of interest. I support the proposed study and agree that there is a need for appropriate regulations in regards to hemp-derived Delta 8 products and consumer safety. Although, why not consult the industry to be regulated for their input on how to best handle the matter? The Maryland hemp industry is prepared to work with state agencies towards fair and equitable regulations of the production and sale of specific hemp and hemp-derived products with respect to consumer safety and education, including good manufacturing processes, compliant labeling, age-restricted sales, and quality assurance testing requirements. Given the opportunity to collaborate, I believe that myself, along with the associations representing the interests of the Maryland hemp industry, could assist in crafting reasonable regulations. Thank you for your time and consideration.
Thank you for your testimony today. We really appreciate it. And next we have Honey's Harvest Farm, Anna Shaney.
Hi, yes, thank you so much, Madam Chair, Madam Vice Chair, and members of the committee. Out of respect, I will try to be brief. I wanted to clarify that I am in support of this bill at 1078 with amendments, and I ask that you also support this bill. My name is Anna Cheney. I serve as the chairperson for the Ag Commission of Anne Arundel County and have done so for the last 4 years. I have served for the Southern Maryland Agricultural Development Commission. I am on the Maryland Hemp Coalition, and I'm a certified functional nutrition counselor. So as I said, I respectfully request that you support this bill with amendments. I own and operate Honey's Harvest Farm with my son and 2 daughters. We are regenerative ag farmers. We are licensed and have grown hemp for the last 3 years. We produce a high quality, full spectrum hemp product grown in living soil. So I want to make sure that we are all kind of the same mindset that hemp is very multifaceted, as Kevin Addix has said, and it's different from medical marijuana or cannabis. Hemp is not the same, does not produce the high THC constituents. Hemp is vital for human health and can not only modulate our immune response, but can also, with current research, prevent viruses from entering the human cell. The phytochemicals in hemp are hemp-derived and naturally part of the hemp plant. We believe at Honey's Harvest Farm in full spectrum hemp products as being very important to human health, and Delta-8 does exist in the natural plant in small percentages. When it comes to Delta-8 derived from hemp, it can be regulated in a fair and equitable manner, including age-restricted sales and the quality and safety standard requirements and labeling. And as Kevin Addix stated, it is already regulated, hemp, the plant, by the USDA and MDA. This legislation, though, I think can provide an opportunity for a collaborative study, and I would ask that you do include the industry in which you hope to regulate in that discussion. So thank you so much. As a certified functional nutrition counselor and hemp farmer, I am available for questions and support during this process. Thank you so much.
Thank you for your testimony today. We appreciate it.
Yeah.
Are there any questions for this panel? Okay. Seeing none, actually, no, there are some questions. I have Delegate Kerr, followed by Delegate Belcastro.
Thank you, Madam Chair.
My pleasure.
My question is for Levi Sellers. Levi, I think I just realized that I think you're across the street from my brother.
Oh, yeah. In Boonesboro?
Yeah, right on Cleveland Town Road.
Yeah. Very quaint little road, very tight-knit community, that's for sure.
I think he lives.
Okay, Delegate Kerr, we can hear you. I think you're frozen, maybe? Okay, well, let's go to Delegate Belcastro, and if he comes back.
Anyway, I was wondering if you know what Delta-8.
Delegate Kerr, we can hear you, I think.
Oh,
can you,
am I back?
Well, yes. And will you be so kind, Delegate Kerr? Will you be so kind and turn off your video and just leave it on audio so that it's best, okay?
Yes, thank you. Levi, I was wondering if you know what other states are doing in terms of hemp grows and THC Delta-8.
Yes. So currently there are 16 states that have either banned or limited access to Delta-8. But there is some efforts actually in Florida and some other states that are actually pushing back on those efforts in hopes that we can actually find some more reasonable regulation that wouldn't ban access for adults to Delta-8, but a more reasonable approach that would actually age gate warning labels, things along those lines. I've actually been in communication with the American Cannabinoid Association on this. Matt Gunther is the individual or the president of that organization. And he's provided me with some wordage that would be critical, I think, in the state to use towards the study to draft regulation that's safe for consumers and helps the hemp industry develop as it needs to right now. It's been quite a struggle coming out of COVID-19 and trying to market these products, and also to the fact that the FDA has not stepped up to the task that they were given to regulate CBD products even, that has caused a lot of consumer lack in confidence of these products. But if we could provide something similar to supplements that the FDA has regulations for other products, I believe that would provide the safety we're looking for on these type of products, and also build and bolster that consumer encouragement or comfort with these products to help build the industry. And I think right now, the agricultural industry has really taken a hit from COVID. Fertilizer prices are skyrocketing and everything. And given the ability to help the Maryland hemp industry expand and develop and grow, it would also provide other opportunities to farmers and producers as well too. So I would
Okay,
be
thanks so
glad
much.
to, absolutely, I'd be glad to give assistance in this study, especially with the knowledge that I've acquired from the American Cannabinoid Association as well.
Thank you, Madam Chair.
Thank you very much. Delegate Bill Castro, followed by Delegate Johnson.
My question was just answered. I'm going to take my hand down now. Thank you.
Thank you very much. Delegate Johnson.
Thank you, Madam Chair. And this question
My
is
pleasure.
for Levi. I don't think we're talking about hemp, but we are talking about Delta 8. So you said some states have done some things to restrict. Do you know how many states have restricted or banned Delta 8?
I know currently 16 have, but we are actually talking about hemp because this is a hemp derived. I actually have a note here. It is defined by, I'll find the note. It is a derivative extract isomer of hemp, and this was defined by Sean Hauser of Vicente Sederberg, LLP of Colorado. And so since we are talking about a derivative and an isomer of hemp, that is covered under the 2018 Farm Bill. So we are actually still talking about hemp.
Follow up, Madam Chair. So
Sure.
Thank you. So in the states that have banned it, and I just read that it was 18 states. So in the states that have banned the Delta 8, what did that do to the hemp industry? I mean, can they no longer sell hemp?
No. So one of the things that's been pointed out to me by the American Cannabinoid Association is in the United States, from the 2018 Farm Bill, we had an excess supply of CBD hemp. That drove the price down of the hemp raw material that farmers were producing. Due to the interest and demand for Delta 8 products and deriving those products from CBD hemp or CBD isolate derived from hemp, we were able to deplete that surplus of hemp, CBD hemp material, allowing now that excess supply to be depleted and allowing the market value to begin to increase. So without having that market demand of Delta 8, we would see far lower prices of CBD hemp and far less benefit to producers and farmers.
My question was, in the states that have banned the Delta 8, did that decimate the hemp industry in those states? Or is there still an industry in those states?
In my Ag Commission report, I reported that we're actually seeing a 50 to 75% decline in hemp planted areas nationwide. Due to that is the reluctancy of producers to continue to produce hemp due to the excess that was provided from the producers. The Delta 8 depleted that excess. So now we are able to increase the value, which would give benefit to the farmers. In the states that had those regulations, I don't really see there being any different of an impact besides the impact that we've seen nationally with the excess material and decrease in value.
Let me break this down. Do they still grow hemp in the states that have banned Delta 8?
Yes, yes, they do.
Thank you. Thank you, Madam Chair.
Thank you. Are there any other questions for this panel? Seeing none, this actually concludes the bill hearing on House Bill 1078. It also concludes the work of the day, actually tonight. I just want to say thank you so much, to the all the members and the witnesses, especially the members. I know you have worked all day. Thank you for being so attentive, and I hope you do get to have a little dinner and have a blessed evening, okay? On behalf of the chairman, we appreciate you. Bye-bye.